I'm Dr. Kirti Suta from Dr. Makkar's Diabetes and Obesity Center, and it gives me immense pleasure to welcome you all to ACCD 2025. We extend a warm welcome to our distinguished faculty, esteemed delegates, researchers, and industry partners. Your presence reflects a shared commitment to improving lives, and we look forward to the knowledge, energy, and innovation this conference will ignite. From last 15 years, ACCD has been instrumental in disseminating the latest information and enhancing knowledge and skills of participants. The program is attended by physicians, diabetologists, and endos from all across the country and has become a benchmark scientific event in the field of diabetes. Known for its scientific agenda and masterly deliberations, ACCD focuses on recent advances in understanding of diabetes and their clinical implications. Over the next 2 days, eminent faculty from EASD and India will be discussing different aspects of diabetes in a highly interactive format. State-of-art lectures, debates, updates from latest trials, real-life case templates, panel discussions, and workshops will be delivered by eminent experts in the field of diabetes, which are going to create ample opportunities to learn and discuss the application of current concepts in the field of diabetes and their applications to clinical practice. All the participants will be getting a certificate of participation from EASD, and we hope that this conference not only enriches your knowledge, but also fosters collaboration and sparks ideas that last well beyond these sessions. So before we begin the exciting 2-day scientific journey, a few words about our center, Dr. Makkar's Diabetes and Obesity Center. It's located in West Delhi, Paschim Vihar. It offers an integrated high-tech approach to diabetes, obesity, and metabolic syndrome management, led by Dr. B.M. Makkar sir. The center is the only ESO-accredited obesity management center in the country, with advanced diagnostic, personalized diabetes and weight management programs, and a mission to make meaningful clinical social impact. It combines clinical excellence with compassionate care. Our mission is to deliver world-class healthcare with an emphasis on early detection, prevention strategies, and better health for people living with diabetes and obesity. So, to set the ball rolling, I would like to invite Dr. B.M. Makkar sir and Dr. Julia Mother. Welcome. Can I have a big round of applause? So over to Makkar sir.
Good morning, everyone. It's indeed a pleasure and honor to welcome you all to yet another edition of ACCD, which is the 16th edition, and I'm sure quite a few have been part of last 15 editions also. And this year, we also have the honor of having Dr. Julia Mother, who is chair of the Training and Education Committee of EASD, to be present for this program. And welcome, Julia. It's a great honor to have you here. And she has been very actively involved and very supportive in developing the whole scientific agenda for this program. Introduction slides. So just to give a brief introduction, Julia is full professor of medicine at Medical University of Graz and deputy head of diabetes and outpatient clinic. She graduated at the Medical University of Graz, where she also trained in internal medicine and endocrinology. She is, very active person, very actively involved in the EASD projects, and also very supportive of educational programs in different parts of the world. Above this, she is a wonderful human being and a great friend, and very, very easily accessible to us. So we can connect with her anytime, and she, comes up with answers. Thank you, Julia, for being a good support. Now, I would like to invite Professor Andrea Jacare to please come on the stage. Let's have a round of applause for Professor Andrea. Professor Andrea is, he got mentored with Professor Ralph DeFronzo in 90s. He's currently Professor of Endocrinology and a Senior Diabetologist. He is also head of the Center of Endocrine and Metabolic Diseases of the Policlinico Gemelli in Rome. He has substantial track of being involved in very, very path-breaking clinical research and has been on board of the European Medicine Agency. He, I understand, is a phenomenal teacher and a mentor, and he is very actively involved in clinical research even now. Welcome, Professor. Now I would like to welcome Caterina. Caterina Conte is again from Italy. She is in Milan. She is Professor of Internal Medicine at San Raffaele Roma University in Rome and Head of Obesity and Obesity-related Cardiometabolic Complications Research Unit in Milan. She earned her degree from the Sapienza University in Rome, Italy, completed her residency in internal medicine, achieving the board certification in 2012. She is very actively involved in the obesity research, especially looking at the sarcopenia component in people who are undergoing obesity management. She is also a member of the Technical Training and Education Committee of EASD and also involved in the European Federation of Internal Medicine. Very passionate about obesity and working for the cause of recognition of obesity as a disease in Europe. Welcome, Katrina. Where is my old friend David? David, I am sure you have seen David here, met David here, and he doesn't change. So no change in his introduction. He is a phenomenal researcher, speaker, super active gentleman, also working on his own. And always, he has always been available for us. So thank you, David. I have, invited him on very short notices and he has never said no. And he happens to be one of the, best speakers that I ever come across in the field of diabetes, especially explaining the concepts. He's at University of Exeter, where I visited once, and he is also very good friend of nature, loves to be, in the gardens, gardening. He plants, if I remember correctly, he plants a tree every time he goes back from a meeting. You're still doing it. Thank you. Welcome, David. Last but not the least is Professor Shagun Bindlish. Where is Shagun? Yes, Shagun, please come. Welcome, Shagun. She is board certified internal medicine physician, board member, educator, writer, international speaker, and so many accolades she has. She did her fellowship from Ohio University, Athens, internal medicine in Brooklyn, New York, and she then worked at Berkshire Medical Center, Pittsfield. She is currently working majorly in the field of nutrition, but she is a diabetologist and also has keen interest in the newer technologies in diabetes. So welcome, Shagun. So I will request Dr. Kirti to take over from here.
So, Atiti Devo Bhava. As we begin this prestigious conference, it's my honor to extend my warm welcome to our esteemed dignitaries and speakers. On behalf of organizing committee, I now invite Dr. Purvi to present bouquet to Dr. Julia. Purvi ji. A token of our deepest gratitude and respect for your presence today. We are privileged to welcome Dr. Andrea, and I invite Dr. Pooja to present the bouquet. So please accept this bouquet as a mark of our appreciation for your invaluable contributions and for joining us here. May I now request Dr. Hanish Gupta to present the bouquet to Dr. Katerina. Ma'am, please accept the bouquet as a gesture of heartfelt welcome. May I invite Dr. Sen Gupta to present the bouquet to Dr. Shagun. Kindly accept our gesture. And finally, we extend our warm greetings to Dr. David, requesting Dr. Seema to present the bouquet. It's an honor to you, for us to have you here. So moving forward, as we commence this auspicious gathering, we light the ceremonial lamp. Lighting the ceremonial lamp is more than a tradition. It represents our collective commitment to dispelling darkness with learning, innovation, and compassion in healthcare. I now invite our esteemed dignitaries, Dr. Vinod Kumar sir, Dr. Bansi sir, Dr. Shashank sir, Dr. Sunil Gupta sir. Please come on the stage for the lamp lighting ceremony, sir. Dr. Das sir, sorry. We begin this auspicious occasion by invoking the blessings of Lord Ganesha, the remover of obstacles and harbinger of wisdom and success. May this flame inspire us all to work towards a healthier future and a healthier world.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
सिंदूर लाल चढ़ायो अच्छा गजमुख को, दिल लाल विराजे सुत गौरी हर को। हाथ लिए गुड़ लड्डू साई सुरवर को, महिमा कहे न जाए लागत हूँ पद को। जय देव जय देव जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारो दर्शन मेरा मन रमता। जय देव जय देव भाव भगति से कोई शरणागत आवे, संतति संपत्ति सब ही भरपूर पावे। ऐसे तुम महाराज मोह को अति भावे, गोसावी नंदन निच दिन गुण गावे। जय देव जय देव जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारो दर्शन मेरा मन रमता।
May I request all of you to please take your seats. So thank you everyone. And now I would like to invite Dr. Julia on the dais to address the August gathering before we proceed for the sessions.
Good morning, ladies and gentlemen, dear friends. I'm really happy to open up the conference also on behalf of EASD. So for us it's a very good and long-standing relationship that we have with India and specifically of course with Dr. Brij Makar. So we are really happy to have such an in-depth collaboration where we can spread the joint knowledge that we have from India, from Europe, from the US, to bring it back to you guys, to have some interactions during the breaks and hopefully maybe also establish some joint projects for the future. So what EASD aims, of course, is to have more collaborations in the future, to have a global outreach. So again, this year we will have the Global Prize that goes to India as well during EASD meetings. So I think we do have a very good and long-standing collaboration and are very happy about that. I also would like to draw your attention that EASD, and I'm chairing their Training and Education Committee, not only hosts live events or supports live events, but we also have the Training and Education Committee's platform where you can access up-to-date presentations, up-to-date modules, and also for, especially maybe for the young people when they are on the commute, have short snippets of information that are also kept up to date. And only yesterday I convinced David that he will also join with one of the new activities on our e-learning platform. So stay tuned for more to come on the e-learning. And I also hope to see a lot of you people back in my home place in Vienna in the coming EASD in September. And we do have good numbers of registrations, so I think it's going to be a very, very interactive event as well. So whoever has not had the chance to register and come over, there are direct flights, as I heard again, for this morning from Delhi and from other places in India, at least via other places in the Middle East to Vienna. So if you have the chance, come and visit us at EASD in Vienna as well. Thank you very much.
So thank you, Dr. Julia, for the kind words. May I now request Dr. Vinod Kumar sir, Dr. Accd sir, Dr. Bansi sir, Dr. Shashank sir to be on stage to felicitate our faculty. Shashank sir to felicitate Dr. Julia. May I request Bansi sir to felicitate Dr. Andrea. May I now request Dr. Das sir to felicitate Dr. Katerina. May I request Dr. Vinod Kumar sir to felicitate Dr. David. May I request Shashank sir and Bansi sir to felicitate Dr. Shagun? So thank you everyone. Now I'll request Makar sir to be here to carry on.
Thank you, everyone. We are towards the end of this short inaugural function. Now, can I have some housekeeping slides here? So, before we close, there are some housekeeping announcements that I want to make. There are certain things which we have to try doing differently this year, and I hope you will like them and you will find them useful. So, first thing is, please keep your mobiles on silent. Once the sessions are on, it's always better that we have good attention towards the speaker and the slides rather than on the phones. Also, this year we have created an app for the conference which you can download from the QR codes outside. I'm sure you have received the QR codes in your email also with your registration. So there are QR codes, 2 QR codes in your email, one to download the app and other to download the program. Both are available online, but you have a copy of the program in your delegate kit also. So in this, app, this is not working. In this app, you will also find your badge. You have a physical badge, but in case you misplace it, your badge is there on the mobile also, and you have multiple areas which can be accessed from here. And so, you will see there are areas which are, which will give you program. You can check on the faculty, your badge is here. You have the details of organizing committee, industry partners. You have a digital Q&A. So, all you need to do is click on this and you will find, area to submit your question. And once you submit your question, you will be able to see the questions at the bottom. And these questions will populate at the back end with the chairpersons, and chairpersons can get those questions on iPad. I am sure there can be glitches, so in case you are not able to use it, there are notepads in your delegate kit and there is a pen. Please write down your questions, give it to volunteers. We will get the questions to the chairpersons, and the chairpersons will make sure the best, queries that are there in the questions asked, they will be addressed by the speakers. If the questions are unanswered, we will have sufficient tea breaks, lunch breaks, and times where you can interact with the faculty and have direct, access. You have 2 QR codes displayed outside also, where you can download the, app, and you can also download the scientific program. Tea and coffee is being served continuously outside the hall and outside the workshops, in the exhibition area, everywhere. So, though there are going to be breaks so that you can stretch your legs, go for the washrooms, whatever, have another round of coffee, but we will be starting all these sessions on time, and we will try to maintain timing through and through for this meeting. For the breaks, you will, I just told you sessions will start on time. For the workshop halls, we don't have pre-registration, so you will be seating there first come, first serve basis. So when you want to go to workshop, just leave 5-7 minutes before the workshop time. Lunch time today is 1 p.m. to 2:15 p.m. and after that we will start with the sessions, and dinner will start at 8. Your feedback is very important. In the app, you will be able to download your certificate, or you will get the certificate after the conference on our website. But before you download the certificate, you will have to put your feedback. And it is very important for us to get feedback to make sure that we keep on improving this meeting. We also have a wonderful exhibition which is going to start at 11. So you can visit exhibition whenever you want and meet our sponsors and academic partners. At the end of every session, I would request everyone to stand up for applause. So this is a good way of recognizing speaker's contribution and also keep you active and not to fall asleep. So it is very important that everybody rises and claps after end of every speech. With that, we come to end of this session. I would request Dr. Kirti to start with the first session of the day. Before we do that, I think it's error on my part. We will have national anthem to finally conclude this inaugural function. Can we have the national anthem on?
गणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Thank you.
So starting our first session with the plenary session, may I now request Dr. Vinod Kumar sir, Dr. Makkar sir and Dr. Bansi sir to chair the session.
Good morning, everyone.
So over to the chairpersons for the further proceedings.
Good morning, everyone. I request Professor Dr. Vinod Kumar to introduce our first speaker. And is there any CVs there? Yes. sports director. Should I speak for her?
Yes.
Yes. CVD for Andrea. Yes.
किसको इंट्रोड्यूस कराना है?
So our first plenary session is CVD in type 2 diabetes. When and how does it start? Dr. Andrea Giasari, who has been already introduced, he will be delivering the first plenary session. Please put your hands together for Professor Andrea. Can we have slides up there, please?
Okay, so good morning, everybody. First of all, let me thank Dr. Makar and everybody for inviting me here. It's a wonderful place, wonderful country, but I'll say wonderful people. So it's really a good thing to share my impressions with you. Now, we know that in the last years, can I have my slides, please? We are treating type 2 diabetes, but it's not just that. I mean, diabetes is hyperglycemia, and somehow it's easy to treat often hyperglycemia, while type 2 diabetes is associated with cardiovascular disease, and I think this is the most important part of our work. Well, this is a comparison with people with type 2 diabetes or without type 2 diabetes, and you will see that at different age, having diabetes with comparable other risk factors means an increased risk of atherosclerotic cardiovascular events. And that's why our work is changing in the last years. So in Europe, the European Society of Cardiology has developed this kind of very easy app, and I hope there will be something in the future also in India, which helps us to understand what is the cardiovascular risk of our patient. For example, this kind of patients, you see, 68 years old, never smoked, no events, blood pressure, cholesterol, lipids, everything is fine. The kidney is also fine, but then we will see that also HbA1c is good. He just had 20 years of type 2 diabetes, and this means that he has a 21% risk of having a cardiovascular event, which is a very high. You see it's in a dark red part, means that it's a high risk of having an event, even if all the risk factors are under control. So let's try to see who is with lower cardiovascular risk. In this case, we have another patient with similar parameters, including HbA1c of 6.5, just 5 years of diabetes, and still the risk is not low, is moderate. And to make this moderate risk lower than this, you have to really lower the HbA1c to below the pre-diabetes values, meaning that HbA1c is a risk factor, and it starts to give risk even at levels just in the pre-diabetes range. So the question is pre-diabetes an evidence-based treatment target for cardiovascular risk reduction? Well, this has been very important debate in Europe, where you will see that actually some of the people said that pre-diabetes is not something that we have to treat in order to reduce the cardiovascular risk of our patients. So the question is really this: when does the cardiovascular risk start? Just a diagnosis of diabetes or even before that? Well, we don't have very strict evidence on this, but some suggestions. For example, this is an oral glucose tolerance test done after a myocardial infarction. And you will see that having diabetes at oral glucose tolerance test increases the risk. And here, okay, you see here, increases the risk of having another event. But then, if you see impaired glucose tolerance, the risk is even higher. We don't know why it's higher, maybe because diabetic patients were treated with drugs which reduce the cardiovascular risk, but still the risk is at least comparable between IGT and type 2 diabetes. So diabetes is a significant and treatable cardiovascular risk factor. It's a progressive disease. It's not just higher than 6.5. It's anticipated by prediabetes, which is also a risk factor. So is there a threshold beyond which a cardiovascular risk suddenly increases? That's the real point. I mean, that if you have a patient who has prediabetes, should we treat their cardiovascular risk or not? We try to find many evidences. It's a little bit complicated slide, but prediabetes is atherosclerosis is proportional to HbA1c, so there is no threshold beyond which there is a change. And the same is also for the risk factors in the score predictors. So again, if you have prediabetes, still the atherosclerosis is going up. This is associated with the calcium score. You know what is the calcium score? Again, you will see in orange the prediabetes, the calcium score is higher, and also the plaques in the coronary arteries are more frequent in prediabetes. So again, prediabetes means that people already has cardiovascular risk factors. And if you see the occurrence of cardiovascular events, you will see it's not just a moment in which here you have type 2 diabetes diagnosis and then the risk increases. The risk starts much before here on the left, okay, even when the patient just have prediabetes. So it's a sort of ticking clock of impending diabetes, but the cardiovascular risk, such as the hyperglycemia, starts much before the diagnosis. So prediabetes and diabetes are a continuum. Both increase cardiovascular risk as a continuum. And the question is, can we delay diabetes and cardiovascular risk progression? There is no really strict trial telling us whether we can prevent diabetes and prevent cardiovascular events, but there are observational studies. This is in a Chinese population. These were IGT subjects, and some of them progressed to diabetes, here in red, and you will see that the risk of myocardial infarction is higher. On the right side, also the all-cause mortality tells us that developing diabetes after a diagnosis of prediabetes means an increase of cardiovascular risk factors. Again, this is not an intervention trial, but you will see that if you revert to normal glycemia, there is a decrease in the risk of myocardial infarction, also a decrease in all-cause mortality. I mean, we don't know the strict reason for this. We don't know why this patient revert to normal glycemia. Still tells us that treating or somehow doing something for the prediabetes and reverting to normal glycemia reduces the cardiovascular risk. So both hyperglycemia is strictly related to cardiovascular risk, again, as a continuum. Delaying diabetes progression reduces the cardiovascular risk. And the point is, what kind of prediabetes we are looking for? Because we know that prediabetes means many things. Fasting glucose or glucose after the oral glucose tolerance test, and the ADA introduced, and we use also in Europe the HbA1c. And this has been done because we know that there are subjects on the right who are IGT here, who do not have a hyperglycemia in the fasting state, meaning that if you don't do an oral glucose tolerance test, you cannot catch this patient as pre-diabetic. So the reason why HbA1c was introduced is in order to catch all these patients as having pre-diabetes. And there was a major debate, especially in Europe, trying to understand whether these different definitions were associated with different cardiovascular risk. And here you will see the different fasting glucose on the bottom and the different oral glucose tolerance tests at 2 hours on the right. And these are the mortality risk, and there was this major evidence that the 2-hour glucose tolerance, the 2-hour glucose concentration after the oral glucose tolerance test was the major predictor of mortality. And really, a question was the comparison between the isolated IFG, so those who just have fasting hyperglycemia but not hyperglycemia after the oral glucose tolerance test, and isolated IGT, so just hyperglycemia after the oral glucose tolerance test, and trying to compare these kind of subjects, as both of them have prediabetes. And you will see here that HbA1c on the left and the 2-hour glucose tolerance, the glucose concentration at 2 hours after glucose tolerance test, tells us that there is an increased ratio for coronary artery disease, while the fasting hyperglycemia does not determine an increased risk for cardiovascular events. So this tells us that it's not just hyperglycemia, because on the right IFG, I have hyperglycemia but no cardiovascular risk. So probably it's much more linked to the postprandial hyperglycemia as measured after the 2-hour oral glucose tolerance test. So IGT rather than IFG predict cardiovascular risk. So prediabetes is just a generic definition with different kind of subjects, IFG and IGT, which might have different cardiovascular risk. So probably it's not just hyperglycemia, it's insulin resistance, which can be a cardiovascular risk factor. And can we just treat insulin resistance? We know that we do it, so we just look for some kind of evidence. Now the first tool is how to measure insulin resistance. Certainly I grew up, as Dr. Makar said, with Ralph, and I learned, and with Katerina we do clamp studies, but it's not clinical useful. So there are different measures two different estimates to measure insulin resistance. They all perfectly measure the cardiovascular events. And this is something that everybody forgets. This is a trial done in subjects who already had a stroke, but without diabetes, just insulin resistance as measured with the HOMA. And you will see that treating them with pioglitazone here actually reduced the recurrence of MACE, of cardiovascular events. So this is actually an evidence that treating patients without diabetes, just insulin resistance, is able to determine a reduction in cardiovascular events. And another indirect evidence is the SELECT trial. I remember SELECT trial was done with semaglutide in non-diabetic subjects. Yes, they were not diabetic, but you will see that actually 2/3 of them had prediabetes. Okay, so sure, they were obese or overweight, they had high cardiovascular risk, but they also had prediabetes. And you will see that while the MACE, which was the primary endpoint here on the top of the figure, that was not different according to HbA1c, it's right the same. Here, if you see the all-cause mortality, you will see that there is a major reduction, especially in subjects who had prediabetes in the higher interval, meaning that really prediabetes is a cardiovascular risk factor, and together with obesity can be treated with, in this case, with semaglutide to reduce the cardiovascular events. So cardiovascular events in non-diabetic patients mostly reduce events in pre-diabetic patients. We've seen that with pioglitazone, with semaglutides. And can we do something with trying to really be aggressive in our patients to reduce their risk linked to hyperglycemia? But I'm sure that now the major evidence is with tirzepatide. This is a trial conducted in patients with, you see here, in monotherapy. And 45% of them were naive to therapy, meaning that this was at the beginning of the national history of diabetes. And certainly, if you treat aggressively your patient with a very powerful drug like tirzepatide, you can obtain major results in terms of HbA1c, and you will see that actually 52% were able to reach normal HbA1c. Okay, so it's not just treat hyperglycemia, it's not just then to revert them to prediabetes, it's to revert them to normal glucose tolerance. And this, I hope, might be linked to a reduction in the cardiovascular events, especially in this kind of patients. So maybe one idea is try to treat them early. There is no major evidence on this, trying to be more aggressive. The only trial which was designed like this was the Verify conducted by my friend Stefano Del Prato and Dr. Matthews, where they tried to compare either the classic stepwise approach, which we always do, start with the metformin, that add something else. In this case, they added vildagliptin, and we know there is no reduction in cardiovascular events with DPP-4 inhibitors, while on the other side, they treated all these newly diagnosed patients with a direct combination, an early combination of metformin and vildagliptin. The result, the primary outcome of this trial was not the cardiovascular events, was just let's say the durability of the treatment, but still it appears obviously there is a reduction, although not statistically significant on these cardiovascular events. So really trying to be aggressive at the very beginning, even before the diagnosis of diabetes, might be useful, not just to prevent or reduce hyperglycemia, but just to prevent the cardiovascular events. So although no trials have been strictly conducted on pre-diabetic patients, some cardiovascular outcome trials reduce events in these patients, and we see the SURPASS trial, we will see also the other trials. Actually, there is no drug authorized to treat pre-diabetes. This is a problem, at least in Europe. We don't give even metformin in patients without diabetes because it's approved only for that. Still, we use it. And there is strong evidence that the cardiovascular risk induced by the pre-diabetic state may be by the presence of insulin resistance, can be treated, and cardiovascular events, which is the most important point for our patient, can be reduced. So I believe that, yes, prediabetes is an evidence-based target for cardiovascular reduction, and this is our daily duty when we see our patients in our offices. Thank you.
Thank you so much.
Thank you very much, Professor Andrea. Notwithstanding the fact that you have eloquently shown the relationship of diabetes and pre-diabetes with cardiovascular disease, and you have also shown that pre-diabetes is also a proved target for intervention. Notwithstanding these known facts, how do you think, because every individual is also passing through different conditions during his lifetime, like, for example, psychological stress or exposure to pollution, particularly in developing countries, how much they play out in determining why, how, and when this cardiovascular disease emerges in diabetes. The second very brief question, American Diabetic Association reduced the limit of fasting blood sugar for definition of pre-diabetes from 110 to 100. How much it is played out for the reasons of cardiovascular disease emerging at 100 versus 110?
Yeah, that's a very good point. We'll see, I don't know here, but the major problem they have in the States, but also in Europe, and maybe I think is the same here, is that how to catch people who have diabetes, but then glucose is not that high. I mean, 15 years ago, 105 meaning was normal, now it's not, and it's just a way to get more attention to these people, try to understand that maybe there is something different. So if you have a patient who has 105 and now if he has 99, you know there's something that is there, and probably you have to do something more, for example, the HbA1c, because the best way would be to do a screening with the oral glucose tolerance test, but we will never do oral glucose tolerance test every 2 or 3 years to our patient to get whether they have prediabetes or diabetes or insulin resistance. It's something that cannot be done. So the reason why they did this was to lower the threshold to catch more people at high risk of diabetes and cardiovascular events. Even if the discussion whether there is a major difference between 100 and 110 is not that high, it's just to give more attention to these people at the beginning of the natural history of diabetes, and then see what happens to them.
Thank you so much. I think it's a plenary session. Professor Andrea will be available with us for dialogue. I now pass on the mic to the organizers. And thank you so much. Put your hands together again for Professor Andrea for a very eloquent topic. And we clearly recognize what he said, that pre-diabetes insulin resistance are novel targets for intervention and we need to do more science around it.
So thank you, chairpersons and speakers. So we have a little change this time. The mementos we will be handled outside the hall. We have a dedicated place where the mementos will be handled. So may I request Dr. Purvi to please proceed and hand over the mementos. So moving on to the next session, may I now request Dr. Das sir, Dr. Saurabh Srivastav and Dr. P.N. Chaudhary to please come on the stage to chair the session. So welcome chairpersons, and over to you for the further proceedings.
Dear friends, we are in for a very exciting session, and may I have the great honor and pleasure of inviting Dr. Julia Madam, the course director of this particular event, and she has been introduced and you have heard her in the introductory lecture, to speak on a very important subject, classifying diabetes. I present Dr. Julia Madder to speak to us on a very important topic, contemporary challenging topic, classifying diabetes. Julia, all is yours.
Thank you very much for the kind introduction. And yeah, so it's a great honor and pleasure to talk to you about classifying diabetes, because I think there is still a lot of misclassification and with that difficulties for our people living with diabetes going on. So these are my disclosures. And there is still a lot of undiagnosed diabetes, and just yesterday David and I were talking in the car ride when we had the chance to visit a bit of Delhi about the undiagnosed cases of diabetes back here in India, and also if you compare that to some other regions of the world, it's still a tremendously high number of people who are not even diagnosed as having diabetes. And also in my country, where we still have the drafting for adults at age 18, we do recognize undiagnosed diabetes at that point in time. But that's only one part. So we need to, first of all, identify that a person has diabetes. So therefore we use those standardized criteria that we have and that most of the associations have in common. So I don't want to go through them in detail, and you are very well familiar with them, but just really raise the awareness to your GP colleagues, to your students, that they screen for diabetes up and early, because depending on ethnicity, depending on BMI, diabetes can occur already at quite early ages and can be quite asymptomatic in the very beginning. So when we look into the testing, of course, there might be a selection bias depending on the costs, because some of the tests might not be available, some of the tests might not be available in GP offices. So whatever we can do should be done, and of course keeping the costs, of course, in mind. And for example, my university, they stopped doing HbA1c repeated tests. So for example, if a person is admitted twice within a certain time frame, they do not allow to do a repeated test, because of course that does not make too much sense as well. So be mindful about the measures that you use for using to diagnose. And that's a slide that I usually bring in or brought into my students. The classical definition of diabetes also needs to be taken into account. So we should, or used in the past, an elderly person coming into your clinic, and usually you would say, okay, that person has type 2 diabetes. We nowadays only should use the definitions type 2 diabetes, type 1 diabetes, and not so much relate to the age, because we have seen different types of diabetes can occur at any age. So don't be misled just by the appearance of a person. Really be mindful in the next steps that you take for classifications. So what you usually should do for the diabetes workup is, if the person is admitted to the hospital and you have access to more data, request the nurses to take the glucose more frequently, because the fasting glucose alone might not reveal the diabetes. And that still, for example, we have in the classification of diabetes for aviation in Europe. So they solely rely on capillary finger prick fasting glucose. So that probably will not reveal many diabetes cases, and that could be a problem, or could be even used as a kind of escape pathway for the ones who do not want to have the diagnosis of diabetes. So only fasting glucose won't help us to reveal. Otherwise, you can hand out a capillary measurement device so that people can take several measurements, so that you also have a greater insight, or when available, use a glucose sensor for seeing how the glucose traces evolve over time. Then we should also look into HbA1c to see what has happened in the past. And importantly, and that's what I really stress also within our community, do the C-peptide test, because that gives you a first hint of what the current status of the beta cell function is, so that you know, is there insulin deficiency or is there still enough insulin production. And only then you can step up and measure diabetes antibodies in case of low C-peptide levels. And don't fall into the trap that not looking into more details if C-peptide, for example, is normal, because we have had some cases where we then had the bad surprise of having pancreatic diabetes, meaning in many cases pancreatic cancer. So just to say, just coming from the age, it's now outdated, and we should really do a proper workup at any point in time when the person is presenting to you. One classical case could also be you have an older person coming to your practice, having all types of orals, and telling you everything ever failed for me. Upon the beginning, I was treated with oral agents and I never achieved my HbA1c goals. That should also bring you to the direction that potentially in that person it was already an insulin deficiency, and that person should have been treated with insulin upfront. So just by the aspect of the person, don't get misled. Really do a proper workout, not only on the aspect, but really get a thorough medical history, get a proper workup when it comes to the laboratory tests, and then treat the person according to your findings. So when we look into the treatment and assessment tree of type 1 diabetes from the American Diabetes Association, they also say adult with suspected type 1 diabetes, test for islet antibodies. If they are positive, type 1 diabetes. If they are negative, depending on the age, Are there features in the younger ones of monogenic diabetes? And we'll hear about that in a minute a bit more. If there are no features of monogenic diabetes, islet antibody negative, then we can suspect type 2 diabetes and treat accordingly. If there are features of monogenic diabetes, test for C-peptide. If this one again is below 200 picomoles per liter, treat as type 1 diabetes. If it is above, go for genetic testing. And you have already done a tremendous work back here in India with Dr. V. Mohan about identifying different genomes of diabetes, and I think you are really at the upfront here and way better than we are doing in many centers back in Europe. So keep that good work up and running. At the age of above 35, if there is an unclear classification, again, go for the C-peptide and repeat the test after 3 years. But if there is any hint of any underlying condition, don't miss out on the imaging procedures. So go for an ultrasound, go for a CAT scan, MRI, whatever is available, to not overlook pancreatic cancer in that situation. Why it is now important also to look maybe at early risks of type 1 diabetes, and I discussed about that earlier this year with you guys back in Jaipur, discussing the intervention that we have for nowadays early stages of type 1 diabetes. So the more we can do in the early phases, the more important it is also to identify people who are at genetic risk of type 1 diabetes, because some of those treatments, of course, only work if there are still alive beta cells, which means the beta cells should be up and functioning, and the treatment should start at stage 1 diabetes without symptoms, but with autoantibody positivity. And I don't want to go into that procedure. Sorry, I did not hide this part. We also now are working on the potential to use continuous glucose monitoring to identify early stages of type 1 diabetes. And there is now the hint that if people have time above 140 milligrams per deciliter in a relative large proportion, there can be the case of upcoming glucose tolerance or glucose regulation impairment, and the hint of having type 1 diabetes. Then, of course, we look for protocols when we can also start monitoring type 1 diabetes, and how often should we do that. The current consensus tells us in people at risk, we should do the screening at ages 2 and ages 6, if available in the country, because that can help us to identify early stages of type 1 diabetes. And the idea here and the concept here is, of course, not to cause fear, but to really avoid negative outcomes, meaning ketoacidosis and early death in type 1 diabetes. And importantly, type 1 diabetes can happen at any age. And here it's data presented from 2018. And interestingly, I had 4 cases of type 1 diabetes back in 2019, so early after potentially people had virus infections, and they were at age 80 and above, and they had truly type 1 diabetes. So it can happen at any age, even if you don't suspect it up front. So we need to understand, especially if type 1 diabetes occurs at a later age, they might not be fully insulin deficient in the beginning. There might be still some C-peptide present. People might still be susceptible to ketoacidosis, especially in cases of infections. They might or might not have antibodies, especially with longer duration of diabetes. The titers might drop, but usually they should be present immediately at diagnosis. But as said, if there was a hidden type 1 diabetes treated as type 2 diabetes, uncontrolled type 2 diabetes for many, many years, potentially also the antibodies have dropped by then. pathogenetics of type 2 diabetes. So we have a beta cell dysfunction and insulin resistance at the start, many years before diagnosis. So type 2 diabetes in many cases is a quite silent disease that we only see if 50% of beta cell function is lost. And we need to see how to treat people then, depending again on remaining beta cell function, if we can go for orals or orals together with insulin. And there is again a good screening tool from the American Diabetes Association for screening the risk for type 2 diabetes, and that's more for a Caucasian population. I do not know if you have like an Indian tool for looking into your specific risk, but maybe there might be some determinants from the genetics and the area you are from. Because what we have seen here within a study done in the UK, that people of South Asian and Caribbean descent have a higher risk of developing type 2 diabetes at younger age and lower BMI compared to Caucasian population. And not to forget, and I said that before, that people might have other forms of as type 1 and type 2 diabetes, so type 3 diabetes, and I'm not talking gestational diabetes or corticosteroid diabetes, but mostly the one that we should not miss to treat. That would be type 3C diabetes, which is either a pancreatic agenesis or pancreatectomy, for example, or can be acquired after chronic pancreatitis, so which might be even the most difficult to treat, because in many cases chronic pancreatitis comes along with alcohol abuse, and if you then need to put that person on fully insulin therapy, that might be a big challenge. Can be also neoplastic or paraneoplastic, and those cases are not that rare. Additionally, we do have monogenic forms of diabetes that can be syndromic or non-syndromic. We do have neonatal diabetes or MODY, and I brought to you a very busy slide, so don't be afraid of the next slide. I don't want to go through it in detail, but just to show you and highlight what different forms we have, and that we should simply not miss the genetic screening of monogenic diabetes, because that also has, of course, a relevance for the next generation and upcoming generations of these people. We do have, in forms of mitochondrial diabetes, sometimes concomitant deafness or other mitochondrial syndromes. So if you have a person where you suspect mitochondrial diabetes, also go for further testing. And then when we talk about the monogenic diabetes, I just wanted to highlight, depending on what type of monogenic diabetes it can be, the treatment can be different. And again, for example, some of them don't require treatment because they only have mild hyperglycemia, such as MODY2. Others might be well treated with diet or sulfonylureas, and only a few cases truly require insulin in their treatment. So in general, we all know how to handle diabetes, but the challenges are the good classification. So we can have young onset type 2 diabetes, late onset type 1 diabetes, lean type 2 diabetes, type 1 diabetes with overweight, ketosis-prone type 2 diabetes, so that we specifically have in people in my country coming from Western Africa, so migrants of Western Africa. They need very little doses of insulin, but without them they go into ketosis. Then we do have pancreatogenic diabetes and MODY that we should at least consider. Why is it important to correctly classify? Someone with type 2 diabetes might need insulin or might not need insulin, depending on duration of disease and pancreatic function. Someone with type 1 diabetes who does not get insulin causing life-threatening ketoacidosis. And that's what we sometimes observe in our hospital, that, for example, if a type 1 person is admitted to some other ward, receives IV insulin, then they say, oh, glucose is well controlled, we just stop the insulin infusion, and then go into ketoacidosis and go to the intensive care unit back again. Someone with different type of diabetes might not be optimally treated. It impacts the education, the management, where the people should be allocated to, especially when it comes to pregnancy, and of course can cause frustration if the diabetes treatment does not go well and never reaches glycemic control. So we should also consider that everyone with diabetes can develop ketoacidosis. So, for example, a person longer standing type 2 diabetes having an infection could go into ketoacidosis, especially if there is a co-treatment with SGLT2 inhibitors, if they are fasting, if they are on a ketogenic diet. Then we do have the people who have ketosis-prone type 2 diabetes who can develop ketosis quite early, and of course any type of type 2 diabetes on insulin or type 1 diabetes. And my take-home message, don't just rely on clinical features, really go for thorough testing, look into C-peptide. If that is negative, go for further testing, look for autoantibodies and go for also imaging procedures if needed, and use some time and reflection on the case that you have in your practice to make a thorough diagnosis. Thank you very much.
Dear friends, a simple but fabulous lecture on the classification of the diabetes, and we will have the discussion at the end of the all the three talks. May I hand over to my colleague to call the next one.
So, our next speaker is Dr. Katrina. She talking on gender differences in obesity and diabetes. Dr. Katrina is Professor of Internal Medicine at San Rafael Roma University in Rome. Over to Dr. Katrina for his lecture.
Thank you. Good morning, and thank you for this warm welcoming. So, sex and gender, what are they? I'm talking this morning about sex differences, gender differences in diabetes and obesity. First of all, we need to highlight that these two words, sex and gender, identify different concepts. So sex refers to biological differences like chromosomes, hormones, anatomy, and gender encompasses social and cultural roles. So sex influences adipose tissue distribution, as we will see, hormones and metabolic regulation, while gender influences behaviors, healthcare access, stressors, and sociocultural norms. We are very different. Male and females are very different. So we should consider both to improve precision medicine and diabetes care. Let's take a quick look at the epidemiology of diabetes. This has been increasing over the last decades, both in men and women. And we know that the prevalence of diabetes is generally higher among men, and women usually have a higher obesity burden at diagnosis. So there are differences, and I will look more deeply into this. So, as I said, prevalence is higher in men in different age groups, so this doesn't differ by age. And we know that women have greater BMI than men at diagnosis. So when men are diagnosed with type 2 diabetes, they're generally younger and have lower BMI as compared with women. And women also have a greater burden of cardiometabolic risk factors, such as blood pressure. And this also applies to people in this region. So the prevalence of, this is for overweight and obesity, the prevalence of overweight and obesity has been increasing over the past decades And so it raised from, it was about 10% at the beginning of the year 2000, and it's now about 23% in men and 24% in women. So approximately 1/4 of the population in this area has overweight or obesity. And it's been very, very, very impressive, this huge change over the years. So as I mentioned, men usually are diagnosed at a younger age and with a lower BMI as compared with women. And this is because men have greater visceral fat. So they tend to accumulate more visceral fat. And this is why there are differences, and these are sex differences, which are, let's say, genetically determined. So men accumulate more visceral adipose tissue, and premenopausal women preferentially store subcutaneous fat. So there is a difference in the accumulation, and we can see it very well here. So men have more visceral fat, women have more subcu fat. And also the way adipose tissue increases is different. So in men usually adipose tissue expands by hypertrophy, so larger adipocytes, whereas in women hyperplasia is the main way of expansion of the adipose tissue. And this is also important because hypertrophy is associated with adipose tissue dysfunction, which is more associated with detrimental cardiometabolic differences. So these sex differences in adipocyte biology underpin differences in metabolic risk and treatment response. And we also know that women are kind of more susceptible. So women develop diabetes at lower thresholds of visceral adipose tissue. So the amount of visceral adipose tissue in women is needed to develop diabetes is lower as compared with men. So they're more susceptible. And we also know that there are differences in the response to insulin in adipose tissue and in the other organs involved in the regulation of glucose metabolism. So for example, adipose tissue in men is more insulin resistant, so the lipolytic rate is greater in men. There is more circulating free fatty acids, and also we also know that liver is also more insulin resistant in men, and so glucose output is greater with the same insulin levels. And the inflammatory milieu, as I mentioned, adipose tissue, visceral adipose tissue expands by hypertrophy in men, and this is associated with an increase in pro-inflammatory cytokines, such as tumor necrosis factor alpha, and we know that chronic low-grade inflammation drives insulin resistance and atherosclerosis. So this slide summarizes this first part, differences in metabolic homeostasis between men and women. Women usually have greater total fat mass, but actually the distribution of fat mass, the body composition is different. Men have more muscle and more visceral fat. Women have more subcutaneous adipose tissue. And women have greater insulin sensitivity at different organs, liver, fat, so they respond better to insulin. And the prevalence of type 2 diabetes is greater in men, and women also have a more favorable lipid profile. And why is that? So, of course, these are kind of hypotheses, but actually it's a trade-off. So being slightly more insulin resistant and having more substrates circulating is good for having more readily energy supply for men who had to hunt, who had to fight. So they need substrates, energy substrates, immediate, very readily, very quickly available. And so this is why we think there is an increase in insulin resistance, well, a slight insulin resistance, whereas women are more insulin sensitive, because this is kind of protective during the reproductive age, because we know that hyperglycemia and insulin resistance have detrimental effects on fertility, and the risk of gestational diabetes may increase. And so this is why we think women are more insulin sensitive. This was an advantage during the reproductive age. And then what happens? We know that with aging, first of all, the amount of fat mass increases. So in red we have women and in blue we have men. And actually this increase is greater in women. The proportion of fat mass increases in women more than in men. But also body composition changes. So after menopause, after the reproductive age, there is an increase in the amount of visceral adipose tissue. So women become more similar to men after menopause. And this slide summarizes these changes. So basically, again, women become more similar to men, and so the adipose mass increases, but particularly visceral fat mass increases. So while women during the reproductive age have more gluteofemoral fat, then the proportion of visceral fat mass increases after menopause, and also the fat content in muscle and in liver increases. So the prevalence of fatty liver disease associated with metabolic dysfunction increases after menopause. Before menopause, it is actually lower in women than in men. And also there are other life course events that can happen to women. For example, gestational diabetes mellitus, which increases the risk of developing diabetes, or PCOS, which also is associated with insulin resistance and an increase in cardiometabolic dysfunction. And this slide summarizes these differences, but one thing I want to highlight is that, as I mentioned, the prevalence of MASLD, metabolic dysfunction associated fatty liver disease, is lower in women before menopause and increases after menopause. But what is important is that the presence of fatty liver disease in women is a stronger predictor of type 2 diabetes. So it is always important to assess all of these things, also visceral fat, remember to measure waist circumference, very important. And how about the complications? So after people develop diabetes, is there a difference in the rate of complications? Yes, so men have higher absolute rates of cardiovascular disease, kidney disease, and lower limb complications. And the rates are high, both in male and females. But if you then compare the increase in risk between women and men, actually, women have a higher risk, a higher increase in risk as compared to men. So they have a proportionally greater increase in cardiovascular risk. And there are also treatment disparities, and these are not sex-related. These are actually doctor-related, probably. So this is a very important difference that we can really correct. So women in cardiovascular outcome trials are less likely to receive statins, beta blockers, or aspirin, and these are very important treatments in people who have had already cardiovascular event. So we should always bear this in mind and don't forget to treat our female patients. And this is also important because actually treatment response, especially with the newer drugs as SGLT2 inhibitors and GLP-1 receptor agonists, is not different between women and men. So we should treat them because these drugs are equally effective in reducing hemoglobin A1C, so in improving glycemic control, and in reducing cardiovascular risk. And as for weight loss, there is a slight difference. So women respond slightly better to incretin-based obesity management medications. So this is a study that compared tirzepatide and semaglutide, and there were also analyses by sex, and there is approximately a 6% difference. So women lose a little bit of more weight as compared to men, and this is true both for tirzepatide and semaglutide. And women also have different beta cell and incretin response, so they display stronger beta cell secretory capacity and incretin hormone response as compared to men, and this is because of estrogens. And, but this doesn't translate into differences into glucose control. And finally, another important point that I would like to stress is the socioeconomic and cultural barriers to diabetes care. So we should always remember that gender differences matter because there are often differences that prevent women from seeking care. For example, in this paper, which is actually from Indian authors, they identified barriers such as women giving less priority to their health and so not seeking diabetes treatment, and this is very gender related. Lack of education, which can be, again, sometimes greater in women in some geographical areas, whereas men neglect preventive care due to work pressures and sociocultural norms. Usually, you know, the macho men, they believe they don't need a doctor, they're strong, they're healthy. And so interventions must be culturally sensitive and address dietary practices, which may also differ between men and women, physical activity opportunities, and gender norms. So it is very important to perform a comprehensive assessment. And so these are my take-home messages. Sex and gender shape the epidemiology, biology, and outcomes of obesity and type 2 diabetes. So everything, sex and gender matter for every aspect related to obesity and type 2 diabetes management. Men have higher prevalence of type 2 diabetes due to greater visceral fat. Women become more susceptible when visceral fat accumulates, so after menopause. Postpartum and menopausal screening for women, so it is very important. These phases of a woman's life are very important because risk of developing cardiometabolic complications, diabetes, may increase during these phases, so advice is very important. Advising women during these phases is very, very important to change the course of the risk. We should always measure waist circumference, which is an indicator of visceral fat mass, waist to hip ratio, height to waist ratio. So these indexes, which are very strongly associated with the risk of developing cardiometabolic complications. And remember that men and women face distinct barriers and behaviors as the treatment is concerned. There is limited evidence, so apparently the newer drugs are equally effective in women and men, so we should treat them. Remember, we should treat them because some of these differences are due to us, and this is totally wrong. So this is something we can really change. And we should perform personalized screening, treatment, and research strategies. We need them to address disparities and optimized care. And with this, I thank you for your attention. And I like very much this standing thing. I will adopt it. I will steal it from you. Thank you.
Thank you, Dr. Katrina, for an excellent lecture. Now, questions answer will be in the end.
So thank you, Dr. Katrina, for a wonderful talk, and I think these lectures have not been discussed in the conferences, so gender difference is very important, right? So continuing the last talk of this session, I invite Dr. Shashank Joshi. Dr. Shashank Joshi, sir, needs no introduction. I think he is known to everybody, and he has an immense contribution in the field of diabetes. So he will be speaking on the diabetes recommendation management in 2025 for India specific. Dr. Shashank Joshi, over to you.
So thank you, Bridge, thank you ESD, and I think we are moving gears from classification to gender, and now what's specific for India. I don't have any duality or conflict of interest. Every year AD and ESD comes out with standards of care, and there is evidence for that, there's a process for that, there's funding for that, which is usually without a conflict of interest. But one thing is very clear cut, that it's a living document. And whenever there are new cutting edge trials, for example, as we talk, in Madrid there is ESC happening. and they will update those documents very regularly. And there is a very systematic evidence-based grading system, A, B, C and E. And so if you look at this year's ADA-ESD algorithm, it has a lot of options in that. In the diagnostic tests, we know that in absence of univocal hyperglycemia, diagnosis of diabetes needs a confirmatory testing. We still have to rely on a GTT, particularly in our situations. But the role of A1C, which is very a US-centric thing, and the point of care A1C is very much there, but those levels of evidence are B. But we need to recognize that there are geographies, including India, where there are hemoglobin variants, pregnancy in second and third trimester, postpartum period, G6PD deficiency, HIV, hemodialysis, recent blood loss or transfusion, hemolysis or erythropoietin therapy, where we still need to do a plasma glucose therapy. And in India, we still have geographies of sickle and thal belts and thaltrates, so we need to be mindful of that. So obviously A1C, though in the ADA-ESD algorithm is right up there in the pecking order, as far as India is concerned, we need to be mindful of it. We still often need to do a GTT. I wouldn't go into classification, Julia has already dealt with it, so I wouldn't go into that, but type 1 has a pathway now. And we recognize that pathway, and there are stages of type 1 pathway because there is a medication which can be there available for intervention. We also recognize that we are seeing more and more people with pancreatitis, acute and chronic both due to medications and in general also. And therefore it's very important to recognize that any person who has an episode of acute pancreatitis, we need to screen that person every 3 to 6 months for diabetes and also annually for a person with chronic pancreatitis. We also see post-transplantation diabetes mellitus, and therefore we need to recognize that a formal PTDM is very much there, and we need to do a GTT for that. And in the monogenic diabetes syndromes, I wouldn't dwell into that. Tomorrow Dr. Mohan will go into details of that, of diagnosis. He's going to give that as an award lecture. And then of course lifestyle is very much a part of the entire guideline process. So is the prevention. But the entire focus is now personalized care. It's cluster-based approach. So fundamentally we need to recognize that person-centered goals should be the goals when you are treating people with diabetes. As I told you, in the symptomatic type 1 diabetes, there is a pharmaceutical option called teplizumab infusion, which can delay the onset of type 1 diabetes stage 3. And in select individuals above 8 years in stage 2 type 1 diabetes, this is available. It's still not available in India, but it's there, very much there. So the fundamental matrix for ADA-ESD has not changed. It's still goals of care, prevention of complications, optimizing quality of life, is assessing the personal characteristics of individual priorities, lifestyle, comorbidities, liver got added right up there, and then of course age, A1C and weight, then of course choice of individualized treatment, a shared decision making, and then SMART plans. SMART means specific, measurable, achievable, realistic and time limited, and then going over all of that. Immunizations are level A. An adult immunization, we need to be mindful of it, and we need to be more aggressive on immunization front. But very clearly what's new in the algorithm, and we all recognize that, is the recognition of the liver fat, which is now called MFLD, and we clearly recognize that people with type 2 diabetes, prediabetes or obesity with more than one cardiovascular risk factor do a FIB4 score. If it's more than 1.3, then probably you know that it's a future cirrhotic risk, and then you need to get a little more aggressive on management pathways. We know again here we need to do an individualized treatment algorithm, lifestyle, weight loss, CV risk reduction, and now if obesity pharmacotherapy, diabetes pharmacotherapy and MASH pharmacotherapy, all of them are going hand in glove. So you can very clearly see that diabetes is flanked by obesity pharmacotherapy and MASH pharmacotherapy. And that is where the GLP-1, dual GIP, GLP-1, pioglitazone, which our plenary speaker very nicely showed us, the IRIS trial and SGLT2 inhibitors are very much there in diabetes pharmacotherapy, they are very much there in the MASH pharmacotherapy, and then you will have to do a mix and match. Of course in MASH pharmacotherapy we also have resmetirom, and you know that through a third party route in India via Bhutan it's available in India now, and of course we have the GLP-1 and GIP-1s available in India. Also what is included in the guidelines, and IDF also is coming out with its own guidance, is we are a country with fasting and feasting, and there is data on intermittent fasting, there is data on religious fasting. But what are the similarities and differences? That is what is new in the guidance. Hypoglycemia risk, risk assessment and education, pre-fasting, and the modulation of treatment. So that's something which we need to be mindful. And in our geographies, like Shravan fasting just got over, now there is Ganesh fasting in some parts of India, there will be definitely other fastings coming up like Navratri coming up, and very clearly we know that. Then for behavioral change, there is a lot of guidance in that, tobacco cessation, but what is more compelling are the 5 S's for facilitating physical activity. For example, sitting is the next smoking, sweat it out, strengthen your muscles, step out. Even if you do a 5-minute of brisk walk, it will reduce and add 4 years greater life expectancy. And in the sleep, the quantity of sleep should not be more than 8 or 9 hours, not less than 5 or 6 hours. Ensure the quality of sleep is good and you are a morning phenotype. So clearly, I think the entire matrix has changed. For people who are old adults or with complex poor health issues or no limited life expectancy, probably there is no A1C goal. It's a less stringent goal. Older adults with complex intermediate health may be less than 8. If you are healthy older adult, maybe 7, 7.5. Most adults below 7. And if you are in good health, low treatment burden and risk, less than 6.5. So where is it stringent control? Short duration of diabetes, low hypoglycemia risk, young individuals, low treatment risk, and pharmacotherapy with CV, kidney, weight, liver benefits with no comorbidities or cardiovascular complications. But when there is long duration of diabetes, high hypoglycemia risk, lot of risk burden, then you need to go a little easy on a A1C goal. So obviously, we also should be mindful of risk factors for hypoglycemic crisis. We must ensure that we do C-peptides more frequently in India. We don't do them often, and many of our patients have insulin deficiency. Younger age individuals, we need a very hard hit early policy, and then of course various other situations, and we need to be mindful of that. The other thing is we use a lot of SMBG and CGM now, and I'm sure Julia and the group will give you a lot of education on that, but we should be mindful that there are a lot of substances which interfere and give falsely high glucose values like maltose, galactose, xylose, N-acetylcysteine, simple paracetamol, dopamine, furosemide, which will give either high or low values, vitamin C, uric acid, and of course a high or low hematocrit. We should also be mindful of other agents in the same. Digital health is very much here to stay. I wouldn't go into details of that, and we all know that CKD and other behavioral changes are there. So that is where the matrix is: healthy eating, physical activity, apart from first line and additional therapies. The next thing which is added in the guidance, which is new, are the 4 M's. Mentation, mental health is important because we know that we often need patients to cooperate, reduce anxiety, and ensure that distress is there. Is a talk by Alka, who is going to give on distress today, on coping skills and self-care. Medication and medication access is a big issue. Mobility, like foot complications, functional ability, frailty and sarcopenia, leg weakness, neuropathy, vision and impairment is another big issue. And finally, what matters most is a shared goal setting with the doctor and the person living with diabetes for disease burden and symptoms, for meal and treatment preferences, and ensure that life expectancy is at the center of care. And then of course titrate various algorithms. Also what is important in the guidance is the pediatric to adult care and various situations which have been highlighted. But the bottom line is very clear: make it work. So if you look at the global guidance from ADA ESD, it is that you must be centered on make it work. How is it different for India? Because we are different. We have a diverse phenotype, a different thin fat Indian phenotype, we have access issues, we have a lot of diagnosis at complications, and adherence is a challenge. And we don't have a third party like an insurance which is underwriting the cost of diabetes therapy in India. So most of the expenses are out of pocket, and that is something which we recognize. And therefore in our situation, we need to first look at risk, and we are all at risk just because we are in this geography. And then we need to recognize pre-disease, which is increased weight, increased distribution of fat, increased function of fat, and insulin resistance. And that's why our plenary speaker, Andrea, very, very nicely told us that insulin resistance, at least in our geography, is very important to recognize. If somebody has a skin tag, acanthosis nigricans, a waist circumference which is abnormal, evidence of insulin resistance, I think that's the stage for intervention. And then that handle moves into pre-diabetes, and most of us are picking up at the disease threshold, which is obesity, anthropometrics, type 2 diabetes. But unfortunately, as doctors which we treat today in India, we are treating complications. We are treating macrovascular complications, biochemical or cardiomechanical complications, and that's something which we need to switch gears. I don't like the word obesity. I feel BMI in Indian situation, because of our thin fat Indian phenotype, we need to use that as a poor measure of individual's adipose tissue disease burden. It is the fat quantity, quality and location which matters. And therefore, adiposopathy is a more better term. It's a pathogenic driver for many conditions. It represents a disease continuum, and we need to set up the goals. So in India, when we are setting goals, how is it different from rest of the world? Yes, we have to not only just be glucose-centric, but we need to be weight-centric, cardio-centric, because we have a very high burden of extra fat and a cardiac issue. And therefore, a person with type 2 diabetes needs, beyond just a glucose-centric approach, a cardio-renal liver and a weight-centric approach. Very clear. And therefore, if you see the global guidelines now, ACE has its own algorithm. They have the alpha-glucosidase inhibitors right up there. IDF has come out with its own guidance. Dr. Makkad is here, and many of him and many others came out with the RSHD and ESI guidelines, and the RSHD wheel, which is very much there. But what is the core in that? The core is eliminate complications, halt the progression, keep it cost effective, look at comorbidities and elderly and frail population, reduce pill burden, and integrate it with lifestyle. So if you want to simplify management of type 2 diabetes, it's not just glucose control, it's lack of hypoglycemia and weight management. Treat comorbidities of the liver, kidney and the heart, and then ensure that adherence is taken care of. Unfortunately, in India, in our clinics, we see a wide spectrum. We see people who are still very malnourished and lean with a BMI less than 19. We see lean individuals. We see thin-built individuals with central adiposity. We see normal weight, normal build, overweight, obese and morbidly obese. And that is why Dr. Mishra and the entire group, Bansi, Makkad, many of us, we put out this guidance that where do global guidelines don't fit for India? If somebody's BMI is less than 19 or 20, so in lean non-obese individuals, and look for ketosis, infections and major morbidities. Or if the A1C is more than 9%, maybe it's not very, very applicable. So remember, almost 20 to 30% of our population has a BMI less than 25, but 5% from rural or hilly areas will have a BMI less than 19. Now many of the people between 20 and 25 will still have body fat, and they will have subcutaneous, abdominal and intra-abdominal liver fat, which are indicators of insulin resistance. So we should be very mindful of that. And in that population, with a BMI about 20, metformin will still work. So we should be very, very mindful that that is a situation which is there. Second situation we see where the global guidelines are not suitable for India is, we see people with ketosis, with major infections, surgeries, traumas, steroid use, which we saw particularly during COVID times. And the biggest problem is, in India we also see people who suddenly stop medications. They feel their sugars have become okay, they have conquered diabetes, they stop medicine. It's called as major treatment interruptions. And of course we have a habit of having high intake of sugar sweetened beverages and so on and so forth. So ketosis can present, and we do see a variant of ketosis prone type 2 diabetes like the sub-Saharan variant in the Indian population. The other thing which is different in our guidance is that most of the guidelines will not have alpha-glucosidase inhibitors. In India, because we are a high-carb country like China, we still have to have addition of alpha-glucosidase inhibitors in our guidelines, which are carbose and voglibose, and that's the other change which we see. And we still use sulfonylureas in India. So remember, when we are summarizing, one size does not fit all. We need good glycemic control. It is the cornerstone of diabetes care. But when we are adapting global guidelines in India, we not only have to look at no hypoglycemia, no weight gain, but we have to look at the heart, liver and the kidney, but we have to also look at patient safety, we have to look at affordability and access, we have to look at individualization of care. So obviously treatment has to be individualized, and that is something which we recognize, and independent of therapy guidelines, lifestyle is still the key. We have the largest penetration of mobile phones in the world. We are all digitally intoxicated to all our social media platforms, including WhatsApps. So we need an hour of digital detox. And remember, outcomes of people living with diabetes is not just health outcomes, they are also happiness outcomes. So mindfulness and mental health is equally important. And it's important that we not only, integrating lifestyle into the entire therapeutic conundrum is the key if you want to be successful to get better outcomes and healthy and happy Indians. Thank you so much for a patient hearing.
Thank you, Dr. Shashank, for an insightful talk at how we are different, and definitely, as you have rightly said, that Indians are different because of low onset type 2 diabetes, high cardiovascular risk, and high amount of subcutaneous and visceral adipose tissue. So I request Dr. Das sir to have this question answers if there are any.
May I request all these speakers to kindly come to the dais. Dr. Julia, can I start reading the questions? There is one question which says that even not official, there is mention of the type 5 diabetes. What do you speak about it? They have said that the malnutritional diabetes can be termed as type 5.
That's a very good question. So I have not really experience with that. I have to say.
Type 3 diabetes as the Alzheimer's.
Yeah.
So, but they are not officially accepted yet.
That's true. That's true. Sure.
I think type 5 diabetes is a very controversial term. In fact, we wrote an article on it also. I think in the good old days, type 1 is straightforward.
Yes.
Type 1.5 is LADA. Type 2 we all know. People have now nicknamed type 3 sometimes as Alzheimer's, sometimes as now GDM. Type 4, God only knows. And type 5 is nothing but a lean variant of type 2 probably.
Yes, exactly.
Okay, or the sub-Saharan variant which I was just alluding to. But we do see a very lean, malnourished variety. So in the good old days, it was called as PDDM and FCPD, which is nothing but a secondary diabetes of the pancreatic.
Malnutrition.
But this MRDM term has been removed. So we have written a lot of articles. I know it's a very hot and controversial topic in this part of the world. But I think it's nothing but an extreme spectrum of the lean variant which I showed in my talk. That we see people who are very lean from rural, hilly regions who are malnourished but still have type 2 diabetes and they still have insulin resistance. But if their BMI is below 19, they may also have beta cell deficiency. So now current diabetes management is all about clusters. And when we look at clusters in type 2 diabetes, we have different clusters. And I think that's what we need to do. So rather than getting into controversies, we should do more science around it.
Good. I think in the IDF 2025 in Bangkok, they did talk about it, but I must mention that it is not yet official, not fully accepted. It is what we yesterday's used to talk as MRDM or whatever, is probably gaining some importance. But as Shashank pointed out, the IR, insulin resistance, is again the bottom line of the diabetes. The question to Dr. Catherine, will take it up.
Is there any difference in treatment options for male and female? There's a sex difference in the insulin resistance. Whether we should use some different treatment options for male and female, or it is the same for both the, even having the difference.
We should really look more deeply into this. There is not so much data. What we know so far is that women and men respond equally well to different treatments, even exercise and lifestyle. There might be some very small differences, but actually in general we should treat them pretty much all the same. But we need more data. But so far we know that both sexes respond equally well to the newer treatments, to exercise options, aerobic and resistance exercise yield the same results. So we should treat, and we should remember that these treatment options are equally effective. So the difference maybe is us. We can make a difference, and we should remember that, because there is maybe this misconception that women somehow are protected, but this changes after menopause, and when women develop diabetes, they are actually at higher risk. So we should remember this and treat them all.
I think rightly said sometime back, we discussed about the diabetes in women, and we pronounced that it is different, it is difficult to treat, and can become dangerous with GDM and all that can become very dangerous also. And what you pointed out, often dismissed. Diabetes in women often dismissed because the men folk take the best part of the treatment, and therefore pointed out that SGLT2 and other things must be equally administered to the women, and that's a great message that we should not dismiss it. It's very important, women.
From a treatment standpoint, I think one gender issue is there, that if when you are selecting a glitazone, we don't use much of glitazones, but if you are selecting a glitazone in a postmenopausal woman, I will avoid it.
Yeah,
so in therapy selection, definitely gender matters, and I'm very happy that she highlighted all the points. Yeah. But I think in the therapy selection, if somebody has recurrent cystitis, then the selection of an SGLT2, or if there is a postmenopausal woman who is at a fracture risk, I would not probably push for a glitazone, pioglitazone, or this thing. I would probably use a GLP-1. And I think that is where the therapy selection may, if it's a woman gender, I'll be a little more mindful. And that's something which we need to recognize. Yes. That's all. But beyond that, I don't think there's much of data.
I think that is.
Yeah, thank you for pointing out this, because of course this is important. This is one gender difference related to adverse effects of treatment. Thank you.
So Srirang, that you are discussing about that how Indians are different from the West, and actually sometimes we follow the Western guidelines. And there are Indian guidelines too, right? RSDI has come up with guidelines, ESI has also come. So any take home on that Indian guidelines, that any consensus on Indian guidelines that how we should follow our patients, especially when we're treating type 2 diabetes?
I think bottom line worldwide is the same. That is to get to better A1C control. And I think the worldwide, we are not very good at getting A1C under control. So I think it's ABC is very important. Keeping the A1C below 7, blood pressure below 130, 80, LDL cholesterol below 50 or 70, that's the key. And that's universal. I don't think there's any guidance on that. Now, in fine tuning of selection, lean variant, ketosis prone, selection of drugs, there may be some changes. Carbocentric diet may be a role for AGI. But otherwise, if you see, basic dogma is the same. But there are small differences, so it's all about individualized care. What we learn from ADASD guidelines is the shared treatment decision-making approach and the integration of lifestyle and mindfulness in the entire spectrum of guidelines. So I think, and the evidence-based generation, the level of evidence. So I think it's very systematically done. What in India we need to do is, we need to do India-specific data. So we have a lot of recommendations, but they are not backed by high level of evidence. So we really, it's work in progress and a long way to go.
And if I might add something, the social determinants of health are also important, something that is gaining more and more importance, and we really need more data, and that's very country specific, of course, and this is something we should pay even more attention.
So regarding medication, as you all said, that metformin definitely can be given when the patient lean fat Indians because of that insulin resistance. So I would say that all the Western guidelines, they are not promoting the use of sulfonylureas, quite down in the guidelines. So, but if you see the prevalence of sulfonylureas is definitely one of the most preferred drug in our country. So how you place sulfonylurea in Indian settings, sir?
So sulfonylureas have three problems. One is that they cause hypoglycemia. Second is they have challenges related to weight gain, and they don't have durability long term. But in the initial phase of diagnosis, because of the affordability, and they are there in the ADHD, they are not gone. If people don't have access and affordability, because they are very economical, they are very much there. And the old fear of sulfonylureas has gone. After the linagliptin trial, we now know that glimepiride and linagliptin are at par with CV side effects. But by and large, these agents are not the top line agents. Now, the compelling data of a GLP-1 or SGLT2 inhibitor is so high, and so is metformin, that virtually sulfonylureas are getting regulated out a little bit, and I'm very frank here. So I think though we use a lot of sulfonylureas, a cost of a sulfonylurea is actually sometimes more expensive than the cost of a dapagliflozin. And if I have a choice between a dapagliflozin generic and a sulfonylurea generic, my verdict will go for a dapagliflozin.
Yeah.
Thank you, dear friends. A big round of applause for all the three very erudite speakers and lot of learning points. Thank you. Thank you very much.
So thank you, chairpersons and speakers, for an excellent session. May I request Dr. Anchal and Dr. Anjali Bhatt to please go outside and hand over the mementos to the chairpersons. So we have a quiz session. May I request Dr. Bharat to be here? Thank you, sir.
So good afternoon, everyone. Thanks, Dr. Makkar sir, for giving me this opportunity. This is just a simple recap of what we have learned today after these intriguing sessions. So most of you know what is going to be. It is just a quiz. It is working or not? Then how we will move it? So you just need to scan this, put your name, and be eligible for a prize if you win. I hope the people even at the last row can scan it. So we'll wait for just 10 seconds more. Please join fast. Last 5 seconds. Then we will have our first question. I still see some people are scanning it. So here comes the first question to you. Answer quickly to get more points. Which as a continuum increase the cardiovascular risk? Is it pre-diabetes, diabetes, or both? Ten seconds more to answer. Forty-seven people are correct. Yatendra. May I know who is Yatendra? Good, but be very cautious. This changes very fast. Question 2. Be quick. What is stage 2 of type 1 diabetes? If you saw it correctly on the slide, you can answer this. Normal blood sugar, abnormal blood sugar, or the immune response phase. It's the abnormal blood sugar. Now see the leaderboard shifting. Who is Croc? Can I know who is Croc? Oh, good. Be very cautious. Last question coming in. Here is the question. Be quick. How many patients in India do not reach their HbA1c target? a lot of work to do for all of us, but let's answer this. %67%. Let's see who is the first winner. Great. Croc is the winner. Can you please come up? It was a very thin margin, you see.
And yes, you will be taking your medal from outside the hall. We have a special dedicated pick point for it.
A big round of
Congratulations,
applause.
Croc.
A big round of applause for Croc.
Can we know
What's your real
name?
name, by the way?
So moving on to the next session, may I now invite Dr. Jugal Kishore Sharma sir, Dr. Mukilesh Gupta, and Dr. Hanish Gupta to please come to the stage to chair the session. Can I request Dr. Bharat to please hand over the medal to the winner? So over to the chairpersons.
So, now we have this session 2, and we have with us Dr. Manoj Chawla, who will be dwelling upon the soulful solutions advancing cardio, kidney, metabolic health with oral semaglutide. And Dr. Manoj Chawla is well known to all of us. He is director and consultant diabetologist at Leena Diabetes Care in Mumbai Diabetes Research Center, Andheri West. He is consulting diabetologist at various hospitals like PD Hinduja, SL Raheja, BSES Municipal General Hospital, Andheri. He is co-founder of Diabetes Research and Solutions DRS, elected All India Executive Committee member RSDI 2022, scientific chairman Diabetes India 2023, organizing secretary Diabetes India 2022, and honorary visiting faculty DY Patil Medical Sciences. So over to you. It's our pleasure to be here.
Thank you, chairpersons, and thank you, Dr. Makkar and team for having me here. Always a privilege and pleasure. I'm going to be speaking on the soulful solutions advancing cardio, kidney, metabolic health with oral sema. I am contracted for this talk supported by Novo Nordisk. So type 2 diabetes rarely occurs in isolation, and all of us have now learned to look at diabetes as a part of the cardio, kidney, metabolic syndrome. Seldom do we look at it only from hyperglycemia point of view. The AHA also defines the CKM syndrome as a systemic disorder characterized by pathophysiological interactions, along with metabolic risk factors like diabetes, obesity, dyslipidemia, hypertension, etc. Chronic kidney disease and the cardiovascular system leading to a multi-organ dysfunction. So we've always known that why we wanted to treat diabetes was to prevent both the micro and macrovascular complications, but the focus is shifting to the CKM syndrome. When we're talking about CKM, let's understand the stages of the CKM syndrome. Many here would already be, would fortunately be in stage 0, which is normal, within the normal range. BMI and waist circumference is normal, sugars are normal, blood pressure and lipids are normal. But I'm afraid a large more number of people, even in this audience, would be in the stage 1 and 2, and which is excess dysfunctional adipose tissue. I'm sure this meeting also has the body composition analysis machines in the stalls out there. So those of you who haven't done that for yourselves should take the opportunity to do a BC and figure out your own skeletal muscle fat and water content. Which then moves to stage 2, which is presence of metabolic risk factors with or without presence of chronic kidney disease. You'll have hypertension, hypertriglyceridemia, metabolic syndrome, type 2 diabetes as part of the stage 2 CKM syndrome, which then unfortunately does progress to stage 3, which is presence of subclinical cardiovascular disease. You could have subclinical atherosclerotic disease, heart failure, or the risk equivalence. And then eventually progressing to what is a troublesome zone, which is stage 4, clinical cardiovascular disease as part of the cardio-kidney metabolic syndrome. You'll have heart failure, you'll have possibility of stroke, peripheral artery disease, complications like AFib and so on. So let's now understand the benefits of GLP-1s, which extend beyond glucose control and address this problem, which is multiple components of the CKM. GLPs have an effect at the brain, reducing appetite, reducing risk of stroke. At the level of the heart and vessels, there is cardioprotection, improved endothelial function, improved plaque stability, and so on. We now have proven effects at the level of the liver, decreasing free fatty acid synthesis, reducing inflammation and cytokines, reducing liver fat, and so on. At the level of the pancreas, GLPs have been known to increase insulin secretion, reduce the glucagon secretion or the overactive alpha cells, which are a big contributor in type 2 diabetes, and also emerging role of GLPs at the level of the kidney, which I shall be focusing on as we move ahead. So GLPs are now globally endorsed by all major guidelines, including our very own RSSDI as well, clearly talking about the need to use GLP-1 RAs and similar peptides early on in the journey of a person with diabetes or metabolic syndrome. So what really is the evidence with Rybelsus, which is oral semaglutide, on cardio-kidney metabolic dysfunction? Rybelsus, to its credit, had a very, very intense and well-driven phase 3 program. You look at the data, 19 clinical pharmacological trials, subjects which were exposed to Rybelsus in its phase 3 developmental program were about 6,600 out of the total population in the trials of 11,500. They had one phase 2 trial, 12 phase 3A trials, and a phase B trial. What did the trials show in general? That maximum A1C reduction was up to 1.5% by Rybelsus. But every time you're shown this data about A1C reduction, all of us need to start looking at the baseline HbA1c. And in these trials, the baseline A1C was about 8.5, and you were getting a 1.5% reduction. Maximum weight reduction by Rybelsus was up to 5 kilograms. Now, within the same trials, when you look at a subset where the baseline A1C was 9%, you're getting up to a 2.6% reduction in the Rybelsus arm in various trials. So which is why I said that when you look at the efficacy of a drug, and every time you have presented this data, 0.8% reduction, 1.2, always look at the baseline, because it does matter where you are starting from. Of course, higher the baseline, you will see better reduction when you're using a new drug in these patients. Higher proportion of participants achieved a composite of A1C reduction of more than 1% and body weight loss of more than 5%. Now, today is a time that we are seeing a lot of new drugs, cause an average weight reduction of 15% and above. However, still in the trials and by the definition, any drug to be considered in the weight reduction management or obesity management, the cutoff was to cause consistent more than 5% reduction. So that 5% still remains relevant as of now, and hence the proportion of those patients where you had A1C reduction of more than 1% and weight reduction of more than 5%, across the Pioneer program, you can see anywhere between 28 to 40% patients in these trials getting a composite of both the endpoints. The cardiovascular risk factor reduction with Rybelsus was evident in this. You had reduction in the inflammatory markers like the hsCRP, improved lipids, and reduction in systolic blood pressure. There was also reduction in central adiposity and waist circumference on an average 4.7 centimeter waist circumference reduction in the trials. Now this is interesting. Now, this is important for us to be aware that Rybelsus is now approved as a first-line management for type 2 diabetes in India. Right? Professor Accd Das is here and would have been part of the committee which has approved this. We are the 5th country in the world to receive this approval, which means that along with diet and lifestyle change, you can use today oral semaglutide Rybelsus as a first-line drug. In the past, it had to be an addition to some of the other drugs. Now it can be used as monotherapy right from the beginning. So Rybelsus is indicated for anyone with more than 18 years of age as first line. You can use it as monotherapy or in combinations. You can use it safely in special populations of hepatic and renal impairment, and it is found to be cardiovascular safe, the data of SOUL which I'll be showing soon. Now this is an interesting study and data from India. This is the Pioneer Real India study. It was a real world data where the inclusion criteria was patients with type 2 diabetes, more than 18 years of age, who had an HbA1c value available in the database for within the last 90 days, and they were naive to GLP use before. Those who had used GLP were excluded from this study. You had 3 visits, visit 1, visit 2, visit 3. The visit 2 was in between the first and 33 weeks. So it was a more of an observational real world data. 388 was the sample size across India, with the primary endpoint of change in HbA1c from the visit 1 to visit 3, which was any time between 34 to 44 weeks, as it would be in the real world clinic setting visits. The secondary endpoints were change in body weight and proportion of people achieving an A1C of less than 7%. What did this pioneer real world India study show? That 90% of the patients were started this drug by the physicians for achieving glycemic control, better glycemic control and better weight management. The baseline A1C was 8.9% across the sites when you're looking at the average A1C. 1 in 2 participants here had cardiovascular disease related history, stressing the need for more effective treatment options. And 1 in 5 were started on Rybelsus within the first year of diagnosis. So this was something pleasing to see, that in our patient population also in these clinics, that patients were being offered, at least 20% were offered this drug earlier on, and which is where the actual benefit of a drug like Rybelsus comes in. The data showed that when you're looking at the differences, what they found was A1C came down from 9 to 7.25, so estimated change was 1.78% in the real world scenario, the efficacy of Rybelsus, and the body weight, the estimated change was 7.23 kilogram in the real world scenario, now which is clearly significant and what most of our patients would be happy with. So the real world pioneer study concluded that clinical significant improvements in glycemic control and reduction in body weight were observed. No new safety concerns. In this non-interventional study, people with type 2 diabetes who were naive to injectable glucose lowering drugs and received treatment with Rybelsus, according to the local guidelines, they experienced clinically significant improvement in glycemic control and reduction in body weight. And the study, of course, provided newer insights for us into how Rybelsus performs and is utilized in routine clinical practice. Now, your RCTs are extremely important for regulatory approval, but for us sitting in the clinics and trying to understand what drugs are going to be helpful, a well-conducted real-world study always is paramount, because it tells us the scenario of what is happening when patients come into the clinics and not in a clinical trial which is completely supported and funded. Let me move to presenting the data for SOUL, which was the cardiovascular outcome trial. One can refer to as cardiovascular superior trial as well for oral semaglutide. They had an earlier one called Pioneer 6. This was a second one clearly attempting to show superiority. The SOUL trial was conducted to prove cardiovascular benefit with oral semaglutide in type 2 diabetes, randomized, double-blind parallel group placebo-controlled trial. The trial product was to be added on top of standard of care. So you had 9650 participants, well represented from India, 800. We were one of the sites in India based out of Mumbai. The patients on top of the standard of care were offered oral semaglutide 3, 7, 14 up titrated as per their tolerance, and the other arm was of course placebo. And then there was a 5-week follow-up study. This was of course an event-driven trial. So it's not that you have a 52-week or a 104-week period. It's all predefined number of events in any cardiovascular outcome trial. And it went on for over 5 years. The earlier estimate was around 4 years, but because of the pandemic in between, a lot of events which would have been looked upon as a cardiovascular event were reported as COVID-related deaths and hence not captured, and which is why such trials, most of the CVOTs during the pandemic period got extended for the same reason. So it went on for 5 years, which gave us more data actually. The primary objective was to demonstrate that oral semaglutide lowers the risk of 3-point MACE versus placebo. Well, let's look at the demographics and baseline. The male-female ratio, largely more male patients across the globe in this, mean age 66, A1C mean 8%, BMI 31, type 2 diabetes duration was 15.4 years because these patients had to have cardiovascular or renal risk and baseline characteristics. You had the populations divided, hypertension in 90% patients, mean systolic blood pressure 134, diastolic at 76. The baseline comorbidities and CKD stages, very interesting. 70% patients had coronary heart disease at baseline, because as I said, for CVOT, you required the high-risk patients. 21% had cerebrovascular disease, 23% had chronic heart failure, and 15.7% had peripheral arterial disease. CKD was present in 42% of patients, baseline, those who were included in this trial. The mean eGFR was 73.8. Now, within the CKD patients, those 42% patients, if you divide them, there were about 31% patients who had a normal GFR. Maybe they had albuminuria and hence they were in CKD. Mild impairment 38%, moderate 26%, severe impairment 2.4%, and end-stage kidney disease 0.1%. The concomitant medication, these patients had 80% of them were already on RAS blockers, 64% on beta blockers, 88.8% lipid-lowering drugs, 77 antiplatelets, diuretics 42, about 76% on metformin, 50% patients were taking insulin, 29% on sulfonylureas, and 23% on DPP-4s, and about 27% had SGLT2s. Now, this is important because in the past, when any of the drugs have shown improvement in results in MACE reduction, they did not have these drugs. So for a statin or an antiplatelet to show the reduction, probably more evident. However, in today's times, when you have patients who are already on all these drugs, they are on RAS blockers, statins, they are on beta blockers, they are on SGLT2 inhibitors, how much will a drug still show improvement in MACE reduction is challenging. And which is where this result and data becomes so much relevant. So the primary outcomes for the SOUL trial, oral semaglutide significantly decreased the risk of MACE. The 3-point MACE, of course, were cardiovascular related death, non-fatal MI, and non-fatal stroke by 14%, which was statistically and clinically significant. As you can see, the 95% confidence interval between 0.77 and 0.96. And there was an early separation itself noted in the first few months itself between the oral sema and the placebo arm. Now, what's important is all the components contributed to this overall 3-point MACE reduction, largely driven by non-fatal MI. You also had cardiovascular death and non-fatal stroke, but yes, in itself they were not clinically significant. All of them contributing, but non-fatal MI being the driver of this 3-point MACE reduction. The benefit with oral sema in reducing the risk of MACE was generally consistent in all the subgroups. So they looked at both male, female, age less than 65, more than 65, BMI less than 30, more than 30, A1C less than 8, more than 8. So when you looked at different subgroups, right, was there a difference in where oral sema or Rybelsus was more effective? Not really. Across the subgroups, they found that this was consistent. They also observed that the larger reduction in risk of MACE was seen when the A1C was more than 8%, and those in our Asian region. There were secondary renal trials in the SOUL renal events. So oral sema indicated decreased risk of the 5-point major kidney disease events composite outcome by 9% versus placebo. However, this did not reach clinical significance. There was 5-point major kidney disease, which was CV related death, kidney related death, persistent more than 50% reduction from baseline eGFR, and the others listed. So you saw reduction for Rybelsus in the kidney endpoints, but this is not clinically and statistically significant. Oral sema, however, did reduce the mean eGFR decline by 32% at 4 years. We know eGFR will decrease every year by age and in patients with diabetes, but this halted the decline in eGFR. There was consistent reduction in annual eGFR decline, as we can see, as compared to placebo. Patients on oral sema did much better in preventing the fall of GFR. And this has been another study which looked at effects of oral sema on kidney outcomes with people with diabetes, a nationwide multi-center retrospective observational study, which again looked at in a population with an average of 63 years, eGFR of 88. Their co-primary endpoints was looking at change in urinary USCR and eGFR at 6 and 12 months. So another real-world data looking at kidney endpoints, which again showed that the USCR reduced by 30 and 40% at 6 and 12 months interval, and there were no changes in GFR. So no changes in GFR is good, because that meant when you're using oral sema, you're preventing the decline of GFR and reducing USCR in this another real-world renal endpoint related study. So the safety profile of oral sema in SOUL was similar to that observed in all the previous trials with sema. Serious adverse events were reported in fewer participants in the sema group as compared to placebo. The difference was largely driven by infections and infestations or cardiac disorders. The adverse events leading to permanent treatment discontinuation were more common with semaglutide, 15% versus placebo, 11.6%, as expected in the use of GLPs. And the difference was largely because of the gastrointestinal disorders, which we expect in a certain percentage population with GLP usage. Choosing the right anti-diabetic in CKM becomes important, and probably oral semaglutide fills in all those tick marks. Glucose lowering, effect on body weight, cardiovascular risk reduction, pleiotropic benefits, and low risk of hypoglycemia. So with that, let me conclude the talk, and thank you once again for being here and for being invited to speak on the SOUL. Thank you.
Thank you, Dr. Manoj. Please join us here. The questions will be taken at the end of both the sessions. And now, we have amongst us Dr. Hemant Thakkar. May I invite Dr. Hemant Thakkar to be on the podium? And he will be speaking about the stepping up obesity care with semaglutide 2.4 milligram. Dr. Hemant Thakkar is the Director of Medicine at Jaslok Hospital, Head of Department Medicine at Bhatia Hospital, and Senior Consultant at Breach Candy and Reliance HN Hospital. Principal Investigator for more than 35 years in numerous international and national clinical trials. Founding Chairman of South Bombay Physicians Club. And now the stage is yours, Dr. Hemant.
So good afternoon, everybody. Organizers, thank you for asking me to participate in your lovely symposium. I guess you guys have already swallowed the semaglutide pill. So you know what semaglutide orally is all about. I'm going to talk about semaglutide injectable 2.4. And this pill which is in the system is now replaced with 2.4 milligrams injected in our obese patients. You know, losing and maintaining weight loss with diet and exercise alone is a constant struggle. By reducing calories and increasing activity, you aspire for weight loss, but reduced metabolism, the hunger hormones increasing, the fullness hormones decreasing, it's frustration. You go down, 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 you lose only to be deceived when this flattery stops, and that is what gives depression to the patient. Despite his best efforts, metabolic changes to weight loss finally promote weight gain. So there is no sweat if you don't cut out everything, and the ants will come back. And you have to think of injectable semaglutide, which is now marketed as Wegovy. It's a GLP-1 receptor agonist that works in key areas of the brain to help control hunger and cravings. Semaglutide is a human GLP-1 analog, 94% homology to human GLP-1, which has direct activation of the hypothalamus and direct activation of the hindbrain. This injection works in the key areas which are important to obesity. Homeostatic regulation, where it increases satiety, making your patients feel less hungry. And hedonic regulation, where it reduces food cravings and the preferences for certain foods. We all know that behind whatever you cover, there is gross obesity, and the central obesity in our country plagues a large portion of the population. So, has Wegovy been assessed clinically? Yes, multiple phase 3 trials involving more than 26,000 participants, which translates to over 33 million patient years of exposure to semaglutide. The different step 1, 2, 3, 4, 5, 6 going up to 11, then the select trial and so many others. I will allude to a few. Semaglutide, which has been extensively studied even in Indian patients, more than 3,500 participants who took part in STEP, Sustained, Pioneer, Essence, etc. Remember, Wegovy translates for a change in a lifetime, where the obese person, the depressed person who has tried to exercise, to diet and has failed and is now fighting with his back to the wall, think of the step 1 study. Wegovy in patients with overweight or obesity. Almost 2,000 participants with overweight or obesity given 2.4 Wegovy versus placebo once a week, with all the objectives to look at body weight, cardiovascular risk, glucose metabolism and other factors, and to look at safety and tolerability. Participants experienced significant weight loss with Wegovy compared to lifestyle intervention alone. 2.4% reduction with lifestyle using placebo, and a whopping almost 17% reduction from week 0 to 68 with Wegovy 2.4. That is astounding. And clinically meaningful weight loss with Wegovy 2.4 was achieved by the majority of patients. 5% had 92%, more than 5% weight loss when taken over 68 weeks. 74% had more than 10%, and 34%, which means 1 in 3 patients had more than 20% weight loss. All the tailoring shops after that have prospered in one of these 3 patients. And this was achieved in 68 weeks as an adjunct to reduced energy diet and increased physical activity. Even other parameters, confirmatory secondary endpoints, waist circumference, systolic blood pressure, SF36, and supportive secondary endpoints, A1C, diastolic pressure, and the all-important C-reactive proteins, all of them improved with Wegovy plus lifestyle intervention. And therefore the obesity with multiple arms soon started getting clipped and the arms started falling down. What about this step 4 study, effect of maintaining Wegovy versus treatment withdrawal? About 1,000 participants with overweight or obesity were started, they were titrated and they were pushed to Wegovy 2.4 once they were at a steady state. In one arm, Wegovy was continued, and the other arm, placebo, was taken. Of course, only participants who reached the maintenance dose were randomized. They were all fitting into the inclusion criteria. And what was the study result? The result was that the maintenance dose of Wegovy helped these patients sustain their weight loss over time. And when you stopped it and gave them placebo, there was a 6.9% increase from week 20 to week 68 when placebo was substituted. But 18.2% reduction when 2.4 semaglutide was continued. So more than 20% weight loss of 1 in 3 patients is seen, and you can see that this can only happen if you continue the medication and do not get off it. What is the long-term maintenance of Wegovy? A small study, 300 participants with overweight or obesity, where Wegovy 2.4 was continued and placebo was continued from week 16 to week 104, similar inclusion criteria with key endpoints. patients continued to experience weight loss over 2 years with Wegovy. And if you see 0.6% reduction from week 0 to week 68 with placebo, but about 17% when the Wegovy was continued for 68 weeks at 2.4 milligrams. Of course, I'm going to allude to the SELECT trial, which has also demonstrated that weight loss achieved with Wegovy is sustainable over 4 years when treatment is continued. So there is no tachyphylaxis, there is no stagnation, there is no reversal. 4 years. What is the safety profile of Wegovy? The safety profile is consistent with others in the GLP-1 RA class. If you look at the different studies, the adverse events in the GI tract, fatal, severe, adverse for discontinuation were all mild. And they were mild to maximum moderate and interestingly transient. After a while, the GI side effects, either the patients got acclimatized or they didn't occur. We come to the most important study, the SELECT. One of the largest cardiovascular outcome trials, 41 countries, more than 800 sites, and almost 18,000 participants, and the tricolor was there with 500 patients. Let's see what this SELECT large study showed. The SELECT trial design was overweight or obese patients more than 27 BMI, age more than 45 years, and established CVD with no prior history of diabetes. So non-diabetic established CVD were put placebo plus standard of care or Wegovy standard of care, and the primary endpoint was CV death, non-fatal MI, non-fatal stroke, first occurrence, with confirmatory secondary endpoints. And this study went on and on, double-blind, long study. Let's look at it. Of course, the standard of care in SELECT was good medical management for lipids, BP, platelet, antiplatelet therapy, and glycemic control, healthy lifestyle guidance with physical activity, smoking cessation, alcohol limitation, etc. So standard of care guidance was according to the standard of care clinical practice guidelines. What did it show? Wegovy is the first anti-obesity medication with proven MACE reduction in people with overweight or obesity and CVD, but without diabetes. So there was a 20% reduction with 2.4 Wegovy for the risk of MACE. And therefore semaglutide earned the distinction of being the only ESC recommended obesity medication in patients who are overweight or obese with chronic coronary syndrome without diabetes to reduce CV mortality, MI or stroke. You can see the two lines diverging, the blue with the placebo and the pink with the Wegovy. In India too, Wegovy got the label that it is indicated to reduce the risk of major adverse cardiovascular events in adults with established cardiovascular disease who are either obese or overweight. The risk reduction in MACE, interestingly, was evident soon after initiation, suggesting that the effect of Wegovy here was beyond weight loss and in spite of weight loss. You see, the separation of these curves began very early. So separation of MACE curves appeared before maximal weight loss was achieved. And 80% of the MACE risk reduction is mediated by factors other than body weight loss. And the MACE risk reduction with Wegovy thus is independent of changes in body weight. So there's something in the molecule which is reducing MACE, because the maximum weight loss occurred later but the MACE reduction appeared soon. Wegovy also showed consistent beneficial effects across all measured CV outcomes. A 19% reduction in the risk of all-cause death versus placebo, 18% reduction in the risk of composite heart failure outcome, again in the Wegovy group, and a 15% reduction in the risk of CV death in the Wegovy group. So all CV outcomes were definitely reduced, and all these, mind you, were before optimal or maximal weight reduction. So if you look at the CVOT success stories, SELECT on the extreme right occupies a position of great superiority. 2.5 semaglutide injected once a week dropped your MACE incidence and later on continued 20% of weight loss in 35% of patients. So in a retrospective, observational, real-world study in the SCORE, Wegovy was associated with significant MACE reduction in this group compared with non-users, MACE-3, revised MACE-3, CV-related mortality, and all-cause mortality, all the pink arrows going down, 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 all-cause mortality 86%. So, if you look at the end game, it is something to reduce weight, it is something to reduce your circumferences, your CRP, your systolic pressure, etc., but to reduce MACE, and you tilt the balance of power. The tug of war in the beginning turns in favor of the patient, and you are able to win the battle with this chronic disease. Obesity is a disease. It's not only a lifestyle disorder, it's a disease. So the balance of power can be tilted. In summary, Wegovy is suitable for adult patients from a BMI of more than 27 in the presence of at least one weight-related comorbidity, or more than 30 regardless of any comorbidity, because it causes more than 20% weight loss in one of 3 patients. This weight loss is sustained for over 4 years. So this yin and yang of ballooning and thinning is all gone. You have a good safety profile and you remain lost as far as weight is concerned. And not only that, your MACE reduction, your risk of popping because of weight-related complications and otherwise reduces by 20% on top of standard of care when 2.4 semaglutide is used. I think with that, that's my message for Wegovy.
Thank you so much, Dr. Hemant. You can please be here. And please join here so that we can have just a minute of some discussion. So we know that this particular group of medication, GLP-1RA, has really become very important as far as addressing the CKM and may I say CKML, the liver part also now. But now we know that the weight lowering potential of oral semaglutide against the newer one, GIP, GLP-1 and the injectable ones are differential. And obesity, as you have already emphasized, is something which is very central. And then the injectable ones are also going out of patent. With that sort of phenomena, any of both of you can take this thing. How do you position oral against the injectable semaglutide and both of these agents with the newer ones, GIP and GLP-1RAs?
Hello. So the speed of weight loss, the aim achievement, and the other pleiotropic benefits are definitely better with injectable, not to take away from the benefit that also oral accrues. As Dr. Chawla said, even ADA has put Ribelsus as a first-line treatment. So it will depend on your target, the patient's compliance, and what you want to achieve.
So I'll just add to that. So it's not about, it's not, one drug versus the other. It's not that Dr. Thakkar and me are debating for 2 different approaches. But what's important to remember is Rybelsus or oral semaglutide is approved as a drug for type 2 diabetes management. Wegovy or injectable semaglutide has its approval as a drug for chronic weight management for anybody who has a BMI of more than equal to 30 or a BMI more than equal to 27 with one of the comorbid factors like type 2 diabetes or hypertension or dyslipidemia. So your choice of either of these approaches depends on what you are treating the patient for. If it's largely for glycemic control or type 2 diabetes management where you're not looking at significant weight benefit, oral semaglutide is a fair option given the cardiovascular benefit now seen in the SOUL trial in the 3-point MACE reduction by 14%. If you're of course looking at managing or helping the patient with weight management and chronic weight loss benefits and looking at significant weight reduction. So to be fair, the oral semaglutide, what you expect on the weight is about 5 to 7%. You will have some real world data and anecdotal references of patients having lost 15 kgs or more on even oral semaglutide, but we are talking about average. And that for injectable is clearly much higher as the data shown by Dr. Thakkar. Also, for many who are starting off with this therapy with GLPs, in spite of the convenience of once weekly injections, many don't dive into the injectable. So it's fair to start their GLP journey with the oral peptide. And for those who are looking at further weight reduction after a while, probably move from the oral to the injectable higher dose options.
Here is one question coming from one of our audience. This is regarding oral semaglutide. That up to what level of eGFR can we put this drug on? And secondly, how should we step up and after how many days? So this is a very usual simple question, but yes, Dr. Manoj to answer.
Well, thank you for that. Both relevant ones. One, the GFR cutoff as of now for semaglutide is 30. So below 30, you will not use it or you will have to stop it or use with caution. So up to a GFR of 30 is where you can use semaglutide. In terms of stepping it up, well, the on-paper literature advice is to step it up after 4 weeks, starting with 3 milligram, moving up to 7 and moving up to 14. In real world, people have done different things and probably titrated earlier where there have been no symptoms. But the general advice is 4 weeks. What's also important...
times to come, that 14 will go higher.
Yeah. So you do have the data for 25 and 50 milligram, which may be looked upon as, again, drugs for weight management itself. But what's important is, all of us have this tendency that when a drug comes in new for us to use, we are very cautious and we explain all the instructions to the patients. We did that with the glitazones when they came in with Rossi and Pio. We are looking at the liver enzymes in the follow-up. But after a while, you forget everything. And the same we see happening with even oral semaglutide, Rybelsus being started to patients and without instructions because we've all lost our patience. It's extremely important yet to explain to every patient the way it has to be taken. The fact that it has to be taken first thing in the morning with just 60 to 100 ml of water, so 2 to 3 sips, keeping that half an hour gap before you eat or drink anything to make sure that this peptide gets absorbed and works effectively is important. So my appeal to all of you using this is do not forget this instruction. We all did that and then after a while we get complacent and you see now other specialties also using this drug. You see gynac starting it, you see some cardiologists using it who may not have the patience to explain these instructions. This drug wouldn't work as well without this specific instruction.
Dr. JK has something to say? Yeah.
To Dr. Hemant, a very clinical and a practical question. A patient of diabetes and obesity comes to you. How do you clinically decide whether this patient will go on GLP-1 only or GIP-GLP combination, that clinical decision?
So as a clinical decision, you want to see that which drug are you more familiar with in your clinical practice. That does not mean that the combination agonism is also something that you have to run away from. You offer the patient both the choices. Obviously, one is a little more potent as far as weight loss is concerned. So whether you want to start and keep running, or whether you want to introduce and gradually up titrate, most of the other benefits are pretty much similar. So it's something that you will have to offer to the patient. Remember, both of them under separate names have similar indications. So I cannot say that Wegovy is not for diabetes, but Ozempic is. Because I know that black label, whether served in a Coca-Cola bottle or in a black label, will taste the same.
But in that case, since a person of your stature have experience of both the drugs, like I will say Monjaro and Wegovy, and the patient leaves it to you, Dr. Sahib, you are the best judge, then what will you do?
It depends on that day, what you are looking at, his other comorbidities, his ability to understand and what he wishes. Cost-wise also, the choice is not much. There will be protagonists of one over antagonists of the other. Again, you toss it up there.
Can I just add to that quickly?
I'll interfere.
Just one quick statement. So, what's interesting is Wegovy is a GLP-1 receptor agonist, and it really increases supraphysiologically the GLP. Tirzepatide is a dual GLP and GIP, but largely based on the GIP backbone. Now, what we yet don't know is eventually when we evolve into precision medicine, that can we actually predict and say in this individual whether it's going to be the GIP-GLP which is going to work better or the GLP. And also the fact remains that as of today, you do have evidence for the GLP-1 higher dose through the SELECT trial that Dr. Thakkar showed from cardiovascular superiority, and the recent data in the MASLD improvement, which tirzepatide yet has to prove. Maybe it will in the years to come. So if you look at today, in terms of the evidence, it's in that aspect slightly favoring the injectable semaglutide, but times will tell again for tirzepatide. And also we will all learn to evolve probably where we don't have that clarity yet for whom you should be using tirzepatide, for whom you should be using semaglutide injectable. Times will tell. Today people are trying that out. If somebody is not responding to one, shall I shift to the other one and see? So all those combinations will happen.
So I think we'll close the session now.
We are closing the session.
Thank you chairpersons and speakers. And I'll request Dr. Sen Gupta and Dr. L. Srinivas Murthy to please hand over the mementos outside the hall. So thank you everyone, and we'll break for lunch. Make sure to be here before 2 o'clock so that we start in time.
Thank you. Thank you. Good luck. A good question. But it's yin and yang, malum. If I say I have more experience with semaglutide, they will say that... very clear. Depends on the mood that... मैं तो बोलेगा साला आज का सेक्शन तुम semaglutide. You tell me. Doesn't it depend on... Yeah, it depends. हमको मुझे
This is, just an announcement. We are going to start sharp at 2:15, but I thought I'll inform you, somebody has by mistake taken this color conference bag from the front row, which belonged to Dr. Julia Madar. Bag doesn't matter, her passport is in that bag. Any of you were in the front row that time between 11 and 1, just check your bag. By chance, if somebody has exchanged it, it'll be a great help, we should recover her passport quickly. So it is a lighter color bag. By mistake, it has got exchanged with somebody's bag. this colored conference bag, which is containing Dr. Julia's passport. So, you know, this bag has been by mistake exchanged with somebody's bag. And please, if you are ever in the front row, just check your bag and see if there is a passport. If it is there, it will be great help for us to, you know, restore her passport. So please check your bags. If you have lighter color, it has got exchanged somehow. Second thing is to download the program or the app. Just look at the back of your badge. There are 2 QR codes where you can download both program and the app. And you can send your questions in the app, which will come to the head table. With that, thank you once again for your attention, and hand over to Dr. Pooja for the next session.
Good afternoon, everyone, and welcome back to the post-lunch session. We'll be beginning with the plenary session, for which I would like to invite the chairpersons, Dr. Sen Gupta, Dr. Amit Sharma, and Dr. Rajesh Keshri to join us on the stage and to start the proceedings. Thank you.
Good afternoon, everyone. Welcome to the post-lunch session. This is a plenary session. Dr. Julia Mader has already been introduced in the morning. Very important session that we have to look at whether we should be stopping at HbA1c. Oh, she has recovered a bag?
So sorry for being distracted, because maybe we found the bag. So let's see. I'm waiting for the pointer.
Yes, so the topic is, does glycemic control stop at HbA1c control alone? And what should we do with regard to the cardiovascular risk factors and the other comorbidities and the glycemic targets and factors that is there in for glycemic management? Over to Dr. Julia Mader.
Thank you so much, and thank you very much for the kind introduction. So far, it's not working. Sorry. Nothing has changed from my conflict of interest. But what I wanted to highlight is that, again, we do have an increase and an expected increase in... thank you. So unfortunately, I can't stay with you tonight. Dr. Makar is throwing me out of India with my passport. Thanks for your help. So we do have an increase in incidence of people living with diabetes globally, but specifically also in the area where you are living, back here in Southeast Asia, in India. And so that's why really achieving targets and maintaining targets is so important. We do see that there is roughly half of people living with type 2 diabetes not meeting their HbA1c criteria, and 90% of people living with diabetes are also affected by overweight or obesity. And there is a certain inertia in the management of diabetes, and a lot of people in the range of not so well controlled, but also maybe not as poorly controlled diabetes are not receiving any intensification of therapy within the last 6 months. And specifically, this is a very large proportion of this group. And in this group, potentially we have the risk that people try to convince you, I'm nearly at goal, I don't want to go to insulin, so people are a bit cautious in going for the intensification here. And we do see that the majority of people with type 2 diabetes do not have established cardiovascular disease, but do have cardiovascular risk factors. And so this is the reason why we should hit hard and hit early to really meet our treatment targets to avoid any progression of cardiovascular disease. Because what we can also see is that people with prediabetes and diabetes are having an association of cardiovascular disease and also chronic kidney disease. And this already starts at a threshold below the diagnosis criteria of type 2 diabetes. So we should really take that into consideration. And when we look into the UKPDS data, we also see that HbA1c has a large impact on total mortality and also myocardial infarction. And if HbA1c is 1% lower at onset of diabetes, we can reduce the risk. So 1% higher HbA1c as treatment starts is associated with 36% higher mortality risk. So the sooner we can reduce, the better the outcome of diabetes on the long run. We also do have a very strong association of BMI and HbA1c. So the higher the BMI, the higher the HbA1c. And that's also true after we had established new medications. So also here in the more modern ages, people with obesity usually also are seen with higher HbA1c targets. The causes for obesity are very complex, so there is a hormonal imbalance, metabolic rates, medical conditions, traumas can influence it, socio-environmental factors can be influential, but also psychological factors such as stress causing unhealthy eating, unhealthy lifestyle. Other factors, very importantly and only recently found, the microbiome and other endocrine disruptors can influence it. And of course, several medications can also influence glucose control and body weight gain over time. Of course, there's also a very strong genetic association that a lot of our weight is driven by genetic factors. And if we combine all of the above, we do have criteria that make it hard to meet body weight goals, but also on the other hand side, that make it hard to meet glucose control goals. So especially people who struggle from mental conditions, even with the best medication available, might not manage to meet their diabetes criteria. So for example, I have a very smart person in my care who is a professor at a high school, and he is suffering for distress and mental disease alongside his diabetes, and whenever his mental disease is out of control, glucose control goes up and body weight goes up. And then if he's in a good phase, he manages well and achieves the target of HbA1c below 6.5 even quite easily, but again, very influenced by daily factors. So what we can also say from the direct trial that type 2 diabetes is also seeing the better outcomes the more weight we manage to lose. So we achieve high remission rates in the ones who manage to achieve the highest weight reduction. So if people manage to have weight reductions above 15 kilograms in the first year, we achieve remission rates of 86%, and even in the second year it is sustained to keeping above 70%. So weight reduction is, of course, associated with advantages for the whole body system. So we can see an increase in insulin sensitivity, an improvement in the triglycerides. We can see an improvement in beta cell function, and all of that, of course, also are drivers that are associated with improved cardiovascular health on the long run. And if we manage more weight loss, so higher weight reduction, we even see increased reductions in of inflammatory markers, better insulin sensitivity of the muscles, and improvements of the triglycerides. So what we truly can see, weight loss is associated with reduction in cardiovascular disease, reduction in also chronic kidney disease, and also can improve asthma and the situation of oxygen saturation. We also see that weight loss above 5% is associated with obesity-associated cancer risk reduction, reduction of hospitalizations due to type 2 diabetes, and improved mobility. And alongside that, a reduction in degenerative joint disease. If we manage to have higher weight loss, cardiovascular events will go down, and also liver disease activity score will go down. And the best chances we have in a good cardiovascular outcome and reduction in total mortality is if we manage and sustain a weight loss above 15%. So we can say that per each percent of HbA1c reduction, we see a reduction in diabetes-related death, we see a reduction in microvascular complications, myocardial infarction, amputations, and stroke risk. And alongside that, the body weight reduction also helps us to improve cardiovascular risk factors, and again reduces also HbA1c alongside. The best curve would of course be to reduce our body weight to a normal body weight and then manage to keep it up at that normal body weight. But what we usually see is that our body adjusts sometimes and that the metabolic rate goes down and people start to increase body weight again over time, even if they have managed a good weight loss in the beginning. And I don't know if any one of you has seen the American TV show called The Biggest Loser, where they had an intervention of 30 weeks body weight reduction, and then in a subsample looked at them after a 6-year follow-up to see what has happened with those people. So in total they had 16 participants being included there, and what they saw at week 30, they had a weight reduction of nearly 60 kilograms, so really a tremendous weight reduction that people managed. But at year 6, they had increased again by 41 kilograms. So it was not a very sustained program that helped to reduce the body weight. And what we also saw, that people had a reduction in their resting metabolic rate and a metabolic adaptation, which led to a reduction in required calories per day of nearly 500 kilocalories per day. And that, to some point, helps us to understand why maybe there are biological responses that lead to the cause of, again, gaining weight after having successfully lost weight in the beginning. So we have seen GLP-1 receptor therapies are game changers in obesity and type 2 diabetes management. So even if before we have not managed easily to achieve our HbA1c goals and body weight goals, those agents seem to be really game changers. The more we also can expect from the dual receptor agonists, as we will also learn more here during the meeting. And I shortly want to highlight to you the SURPASS clinical trial program, where we looked into tirzepatide versus dulaglutide in more than 12,000 people in that trial phase. And interestingly, we see very good effects when it comes to HbA1c reduction at weeks roughly 40 to 52. The higher the dose, the better the HbA1c reduction. We also see that the larger amount of people manage to keep their HbA1c target below 7%, which also is very good results when we look into long-term glycemic control. But importantly, we also managed to achieve HbA1c below 5.7% at a larger amount compared to active comparators. So we now have really potent agents at hand that help us to achieve and sustain those HbA1c goals. Because before, in the past, we never have dreamt of achieving these low HbA1c goals, if not maybe at a significant risk of, on the other hand side, causing hypoglycemia. And we also see good weight loss in the 40 to 52 weeks trial phase, also compared to active comparator, and of course, especially compared to placebo. When we then look into the cardiovascular risk analysis of the phase 3 studies, we do see that people have a reduced number of events, and the hazard ratio here is 0.8. Importantly, what we also learned that probably we will need lifelong therapy in many people because weight gain starts more or less immediately after stopping anti-obesity medication in the majority of people, but we can manage to efficiently treat people over a long period of time and maintaining weight treatment targets. What we also saw that it's not only the body weight, but also probably the glucose control and high glucose levels and even glucose swings that can be associated with carotid artery changes in people with and also people without diabetes. So the more stable and the flatter we achieve our glycemic control, the better it is for the long run outcome. We also looked in a joint project that I'm currently coordinating into cardiovascular outcomes in the real world, because all of what we have discussed here now are findings from clinical trials. And here we looked into the data of a Danish registry, which covers more or less 100% of their local population. And we wanted to emulate and recreate the findings from the EMPEREC trial. So they used the data and compared the SGLT2 inhibitor users to DPP4 inhibitor users, both new users, and followed them up in that virtual population. The data was from 2012 to 2022, and it was adjusted for confounders such as additional diabetes medication, GLP-1 receptor agonist treatment, and other comorbidities. And what we see here is quite promising results also from the real world, that people at 3 years have a higher risk reduction of cardiovascular disease, all-cause mortality, cardiovascular death, and heart failure in the population on SGLT2 inhibitors compared to DPP4 inhibitor use. And of course, in total, we should not forget that it's not only about the glucose. So we are, of course, focusing in many of our discussions on glucose control, but we should not leave out of our planning and discussion with the people living with diabetes also recommendations about healthy lifestyle in general, psychosocial health, and also looking into their blood pressure goals and into their treatment goals of lipids. But all of the goals that we have should be smart and achievable. So if you have a person suffering from psychological disease, potentially at some point in time, you need to accept that higher treatment targets are acceptable for a certain period of time, and only when psychological health improves again, you can try to start on working larger treatment goals. And our decision tree, and we will get an update in EASD meeting 2025 about our treatment guidelines, currently really stresses we should reassess therapy regularly and should use the optimal therapy per underlying condition and use medication that helps us in reducing cardiovascular risk. So it's not only about HbA1c, but really seeing the patient as a whole and looking into cardiovascular risk reduction. And I also want to bring to your attention a study that was done at our center with other sites back in Austria for people living with type 2 diabetes treated in primary care. And what we see that still a large number of patients, 75%, are treated still with metformin. Of course, now SGLT2 inhibitors and DPP4 inhibitors are also starting to rise. But because of prescription barriers by the GPs, because they need to be seen, or people who want to prescribe with GLP-1 receptor agonists need to be seen by a specialist. The number here is quite low, so only 16% of people are treated with GLP-1 receptor agonist in that population. When it comes to blood pressure medications and lipid-lowering medications, the majority of people is on any lipid-lowering medication, and when it comes to blood pressure medication, still a large proportion of people is receiving beta blocker followed by angiotensin receptor blockers. When we then look into the treatment goal achievements, and I think that's quite frustrating results actually, because people should have access and should be treated optimally, we see that roughly 50% meet their HbA1c targets, and only around 45% meet the lipid targets. We are better in achieving the treatment goals for blood pressure, but when we consider all three cardiovascular risk factors, only 15% achieve all of the three in combination. So there is still a long road down the line. Even if we are maybe doing good in diabetes control, we should really look at all the risk factors and combine it together. Because healthy lifestyle and cardiovascular deaths still are the main triggers for early and avoidable death. And if you have a person at age 50, you should really look for any classical risk factors and treat them well, because if you manage them well, people can have a plus 10 years greater life expectancy than if we do not meet all of the treatment goals here. So I really again want to stress the holistic approach that we should take, and with that I'd like to close my lecture. Thank you very much. And thanks to Dr. Makar for keeping you active and also reducing your cardiovascular risk by exercising during this conference.
Thank you, Dr. Julia, for such a nice, enlightening talk. Again, that glycemic, once we have achieved the HbA1c levels, glycemic management should not stop, because it includes a weight management, whether we are achieving with the lifestyle modification or the weight reduction with the help of GLP-1 analogs or the SGLT2 inhibitors. We can have one or more comments from the audience, please.
So, thank you so much, Dr. Julia, for the very nice lecture that we had. It was very enlightening, and definitely cardiovascular disease are the prime cause of mortality, and it has been shown in multiple studies that only control of diabetes, the glycemic control, does not contribute to decrease in the CV events. So thank you so much.
Thank you so much. I would now request Dr. Sanjay Singla to please pass the mementos to the chairpersons outside the hall, please. And just a quick announcement, the poster presentation is going on downstairs. So the persons for the poster presentation, please go down so that you can make your presentations. And going forward for the next session, I would like to request the chairpersons, Dr. Manisha Arora and Dr. Rutul Goklani, to please join us on stage.
Good afternoon, everyone. So we are moving forward to very important session, and that is session number 3. And the first talk is from David Strain. I invite you for incretin pathways in obesity and diabetes management. I feel he has been introduced so many times today, so no need for introduction for David Strain.
Thank you very much, and thank you for once again inviting me to this prestigious meeting. It is such a pleasure to be with you again. So I'm going to be presenting a quick chat through the incretin pathways in obesity and diabetes management. And because this is really the first conversation we're having about obesity, I'm just going to take the first few moments to talk about obesity and how the perception of that has changed over the last couple of decades, before we then go into how incretins may play a role. And these are my conflicts of interest, which will be there, not quite long enough for anybody to read, before I talk about my very first disclaimer slide. I actually still use this disclaimer slide after 20 years of having these conversations, and it's because our opinions are changing. These are the words of Abraham Lincoln. Very famously said, "Never allow scientists to partake in government." If you give a scientist a new piece of information, the scientist will change our mind. And I'm saying that very simply because as science has developed, so too has our understanding. So too is the way we actually manage our diseases. If we think about obesity, when I trained, the obesity handbook was eat less, do more. That was it. Today, we now have a greater understanding. And we need it. Obesity is growing at a phenomenal rate. The worldwide figures suggest there's about 2.5 billion adults living with overweight or obesity. If we actually just look at the figures here in India, it's about 70 million adults are living with obesity. That's more people living in India with obesity than we have in the whole of my country. The cost of obesity to the health service here is around 20 billion US dollars. There are several countries in Europe that don't have a GDP of that. And yet that is the cost every year here. And it's not just the direct impact of obesity. It's the secondary impact. We know it causes heart disease, coronary artery disease, heart failure, hypertension, stroke, osteoarthritis, gallbladder. A whole list of cancers are all directly attributable to obesity. And if we can manage that, we can make our patients better. Not just by reducing the risk of diabetes and the cardiovascular risk, as we've just heard. Not just by improving the lipid profile or the blood pressure. But most importantly, we make our patients feel better. Our priority as doctors is to improve quality of life. And managing obesity is the single most important strategy we can do in order to improve the quality of life. As well as these figures, and I'm skipping over this just because Julie's just shown it. Now, when I trained, obesity was a choice. We were told people make bad decisions. Bad decisions equal obesity. And part of that is the environment we live in. These are the figures for the change in the average calorific content in a simple McDonald's. Since it was originally founded in 1950, we have seen the calorific content increase 8-fold. Just from that simple meal that we have. Then there's lifestyle choices. Famous picture from ADA, but quick show of hands. How many people in this building know where the stairs are to their floor? Show of hands, 4 of you. 4 of us know where the stairs are to our floor. We are some of the most educated people in the country when it comes to diabetes and obesity, and we don't even follow our own advice. And then there's a perception. These are data that came out just pre-pandemic that looked at what our beliefs about the underlying cause of obesity was. And this is the beliefs of us as healthcare providers. And you can see that only 5 of the top 20 we actually attribute to external influence. The top 3 we blame on the individual living with obesity. And we now know that this ancient model is wrong. And it's not just the impact that the society has. It's not just the socioeconomic status in the environment. It costs 8 times more to eat healthily than it does to eat junk food. It's not just those additional sugars and palatability that goes into it, but there's also a hugely complex backstory. We've just been hearing about the genetics and the medications and the different elements of it, and this is where these incretins come in. The term incretins actually comes, it was coined by John Labar in 1932, a Belgian physician who described these gastric compounds. They would stimulate incretin. One of them was called secretin, and that's where the name incretin came from. Something that came from the gut that would stimulate insulin production. And this has been one of the most exciting focuses of our management of diabetes and obesity coming forward. Because we're rapidly getting to understand that this is a complex pathway. This is not just a case of eating too much and then gaining weight. Because if you then try and reduce weight, your incretin pathways change. If your incretin's pathway change, that makes it more difficult for you to lose weight. You have to make some pretty radical changes within your diet and lifestyle in order to achieve that. And that's in many ways driven by the receptors that we deal with. We know that we have this polyopioid melanocortin receptor and the cocaine and amphetamine receptor transporters. And they are one of our key drivers of satiety. We have absolutely no idea how they work. Even today, we don't know. We don't even know where CART actually is active. We have neuropeptide Y. We have arginine-related peptide, which are promoting hunger. Again, we don't know why these become increased or reduced in activity. We know some of the adiposity signals come from it. We know some of these incretins, the PYY, the GLP-1, the GIP, and the other incretin pathways that are learning have a direct impact on them. We know that ghrelin has a massive component when it comes to promoting hunger. The bits that we still don't understand is how that interacts with our hindbrain. We have absolutely no concept of what's going on there. So we're left in a position that we have some tools that we can then give in order to modify our diet, modify our relationship with food. And is this modification of our relationship with food that will give us the biggest impact when it comes to managing diabetes and obesity? Because when it comes to managing diabetes and obesity, it's not just about the HbA1c. It's not just about the blood pressure. It's about fixing the underlying neurochemical processes that have gone wrong in order to achieve this. So let's come back to the incretins. These are data by Michael Nauk that just demonstrate very nicely that people living with diabetes, all people living with obesity, have an impaired incretin response. That is, when they have exactly the same amount of glucose, they don't get the same insulin production. Now, part of that is because they've reduced GLP-1. Part of it is because they've got reduced sensitivity to GIP. And that accounts for about 60% of this. And that's the reason that we've been focusing on these two hormones primarily when it comes to management. The incretin effect is definitely impaired in people living with diabetes. This is a gap between the healthy control versus a person with diabetes, and we see that the insulin response that they get in response to exactly the same nutrition is dramatically reduced. That means your person living with diabetes doesn't necessarily produce the insulin that they need. They don't suppress the glucagon that they should be suppressing. But not just that. Remember, our incretins are not just responsible for hunger and nutrition. The incretins tell your blood vessels, food is on the way. Food is on the way. Open up, send that food to the muscles. Tell your liver to switch off. We don't need to continue making new sugar if we've got our own sugar, so stop the gluconeogenesis. It's not just the insulin that gets impaired. It's also these other measures, which means when a person living with diabetes or a person living with obesity has a meal, the liver continues the gluconeogenesis. Part of that is driven by the metabolic dysfunction-associated fatty liver disease that we see. Previously NASH, now termed MAFLD. And part of that is present from birth. This is work that we did a long time ago now. This was taking people who had a genetic predisposition towards diabetes and obesity, basically based on their race. People of Indian origin have got a higher rate of diabetes than people of European origin. People of West African origin have got a higher rates of diabetes than people of European origin. So what we effectively did was just compared what is the GLP response of adolescents. This is before they had metabolic disease, before they're living with obesity. What is the GLP-1 response of adolescents in order to a fixed tolerance test? And what we saw, in the first instance, they produced the same amount or very similar amounts of natural occurring GLP-1. What was hugely different, though, even at the age of 16 to 18, was the way that their DPP-4 interacted with that GLP-1. They had dramatically reduced in active GLP-1. The DPP-4 activity was much higher. This had the net effect of, even though you produce the right amount of incretin, it doesn't get to where it needs to be. And remember that this GLP-1, these GIPs, these other incretins are not just about sugar. They're not just about the gluconeogenesis or insulin production or glucagon suppression. They are actively responsible for the rest of the benefit our food gives us. They ensure that our heart gets the nutrition it needs. They ensure that the tissues get well perfused. They have a promotive effect on natriuresis. They actively turn our fat cells into the healthy fat cells that we need to maintain our metabolism. And so the incretin, active incretins, are far more important than just sugar, far more important than just weight loss. They are doing so much more. Now, when it comes to this cardiometabolic effect, one of the interesting concepts here is that's not necessarily mediated through the weight loss. It's not necessarily mediated through the other terms that we're seeing. These are data, again, from a long time ago. 2008 we did these, look. And we had GLP-1 receptor knockout mice. That is, mice that have absolutely no receptors whatsoever to GLP-1. And when we gave those people, when we gave those mice active GLP-1, or for that matter, liraglutide, all we had available at the time, we saw impact on the coronary microcirculation. We saw improved tissue perfusion. We saw reductions in reperfusion ischemic events, which translates to reduction in stroke. Now that is in GLP-1 knockout mice. That is not related to weight loss, not related to their sugar effects. This is a direct impact of the incretin on a tissue that is adversely affected. I now come a step forward, and we're into the SELECT trial here. And in our SELECT trial that we all know very well, what this did is took people who were living with obesity and gave them semaglutide at 2.4 milligrams. And what it demonstrated very nicely is a 20% reduction in cardiovascular events. Now, when we did the mediation analysis on this, only about a third of the benefit that we saw, oops, we're skipping through extra slides, only about a third of the benefit we saw was due to the weight loss. Only a third of the benefit was directly due to the weight loss, the blood pressure, the lipid dysfunction that was improved. Actually, the bulk of the benefit was from the GLP-1 unmeasured effect. Only 31.4% of the benefit could be attributable to the measured weight, lipids, blood pressure, HbA1c, EGFR benefits that we've seen. The incretins are having effect above and beyond their weight loss effects. Now we're starting to see newer drugs coming through. Tirzepatide is hugely interesting. And I find this one particularly interesting because we've all seen the dramatic impact that has on blood pressure. We've all seen the dramatic impact it has on weight, far superior to semaglutide or liraglutide or dulaglutide when it comes to weight loss. But it's not a GLP-1 molecule. It is a combination, it's a receptor stimulant. Now that will mean that it will give you the benefits on GLP-1 receptors. That will mean it will give you the benefit of improved GIP receptors. But we're not certain yet whether that's going to give us the GLP-1 benefit. You know that benefit that was seen on the mice, the knockout mice, the ones that don't have the GLP-1 receptors. If you don't have a GLP-1 receptor, this drug is not going to be of help. This drug will give you the weight loss, it will give you the benefits from sugar, but it won't give you that additional GLP-1 effect. Now, we've just seen the headline results of the Surmount CVOT trial. It's literally hot off the press, to the point that it's not in the manual because it was only published a few days ago. And this is what it demonstrated. You'll all be aware of the Surmount CVOT. That compared dulaglutide, the very well-respected GLP-1 once weekly, with tirzepatide, the combined GLP-GIP. And what it demonstrated is they both did exactly the same when it came to cardiovascular event reduction. There was a slight improvement when it came to all-cause death. But that's on the background of almost 50% better weight loss. It's on the background of a 30% improvement in HbA1c, comparing tirzepatide with dulaglutide. What we don't yet know is whether if we gave molecules with GLP-1 that could also achieve that benefit, are we going to start seeing extra benefit going forward? This is all part of our future. We are starting to see a whole range of new incretin-based drugs coming through. The next 5 years, we're going to see at least 3 more classes. Some of those contain natural GLP-1. Some of those are going to contain natural amylin. Some of them are going to be receptor agonists. The next 5 years will tell us how much of it is incretin benefit, how much of it is weight loss benefit, and how much is just our benefit. On that note, thank you, Chair, thank you for your attention, and I look forward to any questions you may have afterwards.
Thank you, Dr. David, for the wonderful talk. Dr. Makkar mentioned in the morning that he's one of the wonderful speakers, best orator, and he's proved one to be. So we had known incretins since 1932. Despite knowing all that, he's made the talk so simple, lucid, and wonderful. Thank you once again, Dr. David. And now I call upon Dr. Julia again. We have known her since morning, met her multiple times. She has been introduced. And now I invite her for the next topic, new drugs versus old drugs for type 2 diabetic management. Have we been able to achieve our goals? Over to you, ma'am.
Thank you so much, dear chairpersons, dear audience. And yeah, so disclosures have again not changed, but just for clarity to highlight them. So what we know already from the past, poorly controlled diabetes leads to increased risk of developing diabetes-related complications. So we know that there is an association with microvascular disease, that about 35% of people with diabetes are affected, for example, by diabetic retinopathy, and it's still the leading cause of vision loss in the working age population. We also have diabetic neuropathy, which causes up to 60% of lower limb amputations in adults who are affected by type 2 diabetes. There is an association with macrovascular events and also diabetic nephropathy, leading to chronic kidney disease and potentially even leading to requiring of hemodialysis. What we know from the old trials and the historic trials, that we managed to reduce microvascular complications also with the old drugs, sulfonylureas, metformin, and older forms of insulin. But we did not manage to reduce cardiovascular complications in most cases and also not to reduce cardiovascular mortality. So the game is now on for the new drugs if there is something different than glycemic control that we can achieve. So data from the past shows us that people who have had an HbA1c above 7% at the diagnosis of type 2 diabetes and not receiving treatment intensification within 1 year of diagnosis are worse off than the ones who received intensification before 1 year of intensification. Also, we need to consider we might have different treatment goals, and David is here a true expert when it comes to de-intensification about treatment. So the more you get to the right of the panel, potentially HbA1c is not the most relevant factor if your life expectancy is short. But of course, on the other hand side, if you are still young, working age population, healthy, you should try to achieve the best possible glycemic control. Treatment goals we have discussed. It's a complex world that what we should look at. So it's not only about glucose control, but really also keeping all the other factors in place as well, not repeating myself. And I just want to highlight this slide, and don't be shy, you have the slides back in your computers, you don't need to read this slide. I just wanted to highlight that the new standards of care from the American Diabetes Association 2025 give us again a very holistic picture, telling you if you zoom in, for example, what is the glucose lowering efficacy, what is the hypoglycemic risk, what are the weight effects, and so on. So if you have a specific person sitting in front of you and you are not 100% sure what you should use, have a look at the various positive and potential harmful effects that a drug might have. And I adjusted it according, like to make it a bit better readable, just to say we have a majority of drugs who manage to achieve HbA1c goals, but of course some of the drugs, especially sulfonylureas, but also insulin of course, come along with a certain risk of hypoglycemia. What's the new kid on the block and where we do not know yet so much is MASLD or MASH, where we do have potential benefits from even TCDs, potential benefits from GLP-1 receptor agonists, but in many cases we have neutral or even unknown effects so far. Again, clinical inertia is one thing. People are sometimes shy in intensifying treatment, and the highest risk of not achieving or being exposed to treatment intensification is the people with an HbA1c of 7 to roughly 8%. And why are people afraid of intensifying? Because in many cases, once we are having established a dual or triple oral strategy, including GLP-1 receptor agonists, the majority of guidelines lead us down the path of insulin therapy. And even if we should consider basal insulin in type 2 diabetes, people are afraid of intensifying therapy via insulin. So how many of you, and now please raise your hands, have had people with type 2 diabetes who did not want to have insulin in their treatment plan? Yeah, so large group. So, and stories can be varying. So for example, some of my people tell me then, oh yeah, granny, she received insulin and then she lost her leg and then she died. Because of course, in many cases, the intensification starts too late. So we really need to be upfront, start early, hit hard, and achieve our treatment goals. So the barriers are, of course, also complexity, hypoglycemia fear, and also poor treatment adherence. So when we see also the hypoglycemia fear, this is still present, and we do see that people with type 1 diabetes specifically do reduce their insulin dose after they had either a severe or non-severe episode of hypoglycemia, but also people with type 2 diabetes reduce their insulin dose in case of hypoglycemia. And sometimes reduction of insulin dose is not the good way down the line, because maybe that hypoglycemia was caused by something else. So maybe the person was exercising more on that specific day, was not having the same meal intake, and if on the long run people avoid injecting the suggested doses, then of course we do not achieve our goals. And if we look into the physician's perspective, we do hear that people would rather be likely to initiate insulin if they were not fearing hypoglycemia. And that is true both for GPs and diabetes specialists. And when we then look again into the barriers and burdens that we have, people have difficulties in following the instructions, having difficulties in taking the injections whenever needed, adjusting and preparing the injections. And they have the opinions that insulin-treated diabetes controls the life more than having another form of therapy. So approximately 1/3 of people with diabetes are poorly adherent to insulin therapy, and then this leads, of course, to insufficient glycemic control and insufficient long-term outcome of diabetes. We do see that uncontrolled diabetes is also costing more to the system, may it be acute complications, may it be long-run complications where we see an increase in cost. When we then think of what has also been a game changer in the field of GLP-1 receptor agonists, also here we see that once or twice daily applications were not favored by people living with diabetes, and potentially once weekly applications could be more favorable in that sense. So gives you greater convenience, better adherence, maybe even improved quality of health-related life quality, and less being overwhelmed by the treatment. Also consider having maybe an elderly person requiring insulin therapy. The district nurse could come in only once a week, or the son-in-law, daughter-in-law doing the injections only once a week, compared to doing something on a daily basis. Maybe here a bit different if you have different family structures where maybe the younger generation and the older generation are living closer together, but for example in many European countries families are not living at the same place and people need to go over there just for injecting insulin could maybe not be easily manageable. What we saw from the once-weekly GLP-1 receptor agonists, they have improved treatment satisfaction and also adherence to therapy, and these are data from US Medicare people who have been on various types of once daily or once weekly agonists. And people in more than 70% say they would be willing to take an injection if it was only once a week recommended by their physician. So now we try to translate that into the world of insulins, and we can say that potentially also here we will have the reduced treatment burden, easier to overcome the inertia, and also achieve better or at least similar glycemic control. What could be the pathways down the line? Longer half-life, more stable PK/PD, and a slower clearance rate of the molecule. So currently we do have two players on the field. We have once-weekly insulin icodec and once-weekly insulin Fc-Tora alpha, who use a different extension mechanism. We do have the phase 3 program from Novo that was already concluded. So the Onwards 3 program has looked into various populations, insulin naive type 2, insulin pre-treated type 2s, and also one population of type 1 diabetes. The trial showed us that we achieved similar glycemic control compared to other once daily insulins, which is quite promising. Also the hypoglycemia rates were not especially high in the population of type 2 diabetes. There might be some caution needed in people living with type 1 diabetes because they're not fully flat profile over the 7 days treatment period. So we do see now high doses of insulin that we now need to translate into daily doses to really overcome a potential new barrier, because people might be afraid of injecting 70 units once a week if they are just familiar with 10 units a day. So kind of to overcome that inertia will be the next hassle once those insulins are used in broader populations. We can see not only that HbA1c is quite similar, but also when we look to a very well-known insulin glargine U100, that we achieve when it comes to continuous glucose monitoring, more or less the same time in ranges, time above ranges, and also similar rates of hypoglycemia. So potentially, if you want to convince a person to go to a once-weekly insulin, there are some good arguments for that, saying that it's only 52 injections rather than 365 injections a year. We do have comparable outcomes when it comes to glycemic control, and it could be really an issue when it comes to adherence and forgetfulness and better acceptance of therapy. The other program that I shortly want to mention is the once-weekly insulin FCTORA, who is now finalized its phase 3 program, and the results were presented at the American Diabetes Association's meeting. Also here again, various groups of people with various forms of pre-treatment were investigated. So they had, for example, people already being treated with basal bolus insulin on a daily basis of the basal insulin, being switched to once-weekly insulin, and that's probably the most challenging population of type 2 diabetes, the basal bolus therapy. And also here, of course, because of the treatment within being in a trial and the titration, they started off at a non-optimal glycemic control with roughly 45% in target range and ended up with roughly 60% at the end of treatment without a significant increase in hypoglycemia. Again, we need to convince people of injecting high insulin doses. So here at the end of treatment, we had roughly 600 units a week of insulin, which might be a challenge. If you tell people to inject that now at once, that could be, of course, more difficult to understand in the beginning. But, and that's again convincing, if you ask people with type 2 diabetes about the opinion of once-weekly insulins, the large majority would prefer once-weekly insulin applications with a very strong preference. And when we ask them why, there are two main reasons: the easiness of use and also the frequency of injections. So I think we already convinced people living with diabetes, even if they have not had the chance to use it directly for a longer period of time, that once-weekly applications could be beneficial for them on the long run. And interestingly, and we had discussed about micro and macrovascular events that the old kids on the block managed to reduce. And I just want to shortly highlight the STRIDE trial, where they looked into semaglutide and its effect on walking distance. And we see that there is a mean improvement of walking distance in 40 meters. So that's maybe also a new finding for the new kids on the block, that peripheral artery disease can be improved by using more of the modern drugs. Just wanted to highlight again for the tirzepatide that in another trial they looked into obstetric lung disease, so OSAS, and what people could see that tirzepatide demonstrated an improvement in some of the parameters from OSAS in that population. Unfortunately, they did not ask for reimbursement for that within the European Union. So I think in my center we will struggle again to use the indication of obstructive sleep apnea for tirzepatide, but in the US they managed to get that into their licensing. So just to highlight again, we need to look into the individual patient, what therapy we can use. Of course, also look into the financial resources that a person has, but of course also consider the comorbidities of the persons to really look into the optimal therapy for each and every individual with type 2 diabetes. Thank you very much.
Thank you, Dr. Julia, for the wonderful talk. And it was wonderful to note that how we have moved from older drugs to newer drugs, and very rightly said that yes, there is insulin inertia, both on the part of the physician as well as the patient, and we need to really overcome that. And with the newer drugs like once a weekly insulin in pipeline and availability, I think we are going to overcome that. Thank you, Dr. Julia, for this talk. Now we invite Dr. Andrea for the next talk. Type 2 diabetes remission, a new target for type 2 diabetes therapy. Over to you, sir. You want to introduce?
Thank you very much again. Can I see my slides, please? Okay. First, what we really mean with type 2 diabetes remission. There might be different names. HbA1c below 6.5 without any drug treatment, or persistent HbA1c below 6.5 after stopping any kind of drug treatment and for a long while, or even normal HbA1c. This is HbA1c below 5.7, but it is claimed with a kind of drug treatment. It's very important. Is it because we want to really reach normal glucose concentration, whatever we mean, or we want just to stop any kind of treatment? I don't know what's your experience, but in Italy, as soon as I see a patient for the first time and it's his first visit, he comes to my office and says, I had too much sugar, too candies, in Italy, too pasta, too bread, I will stop eat carbohydrates and I will lose weight, I will do many things so that my diabetes will go back. Many people try to do like this, but then we don't see many results. I don't have data in Italy, but these are data in England, where they retrospectively collected data in patients with having a diagnosis, at least having a prescription, and then they will be followed and try to see what was the rate of remission. There was at least two HbA1c below 6.5, 6 months apart without any kind of drugs. And the case of remission was, many of them, 38,000, but just 1.7%. So this means that all the people came, had diabetes diagnosis, they tried to do something, but only 1.7% really was able to have a true diabetes remission, that is normal glucose concentration, normal HbA1c without any medicines. And in this, the incidence was, you see, very low in terms of remission. If the diagnosis was most recent, less than 1 year, was a little bit higher, 45 per 1,000. And if combining this diagnosis less than 2 years, HbA1c not that high, and BMI reduction higher than 10%, then really the remission rate was higher. So the best way to do something is to do something at the beginning, really at the moment of a diagnosis. So although most patients start a diet after diagnosis of diabetes, remission is really rare. So maybe we need to do something to make our patient follow a specific, maybe a very strict diet. I think we are all aware about a direct trial. It was a primary care-led weight management for remission of type 2 diabetes. Very intense, let's say, weight loss, weight management with the total diet replacement. Actually, there is now some TV advertising in Italy, not for diabetes, but just for losing weight with total diet replacement, for just 830 kilocalories, which is very low if you want to keep them. Then a step food reintroduction, try to go to an almost normal diet, and then try to maintain the weight loss, which I believe is the most difficult part when you have a patient losing weight. An endpoint was weight loss higher than 15 kilograms, that's a lot, HbA1c below 6.5 without any medicine, so really the true remission. And really, as compared with the control subjects, certainly patients who achieved the 50% weight loss, you see there is a 24% reduction in the incidence, an increase of remission of diabetes, and especially when patients were achieving remission at 12 months, you see the intervention was much higher in terms of success. And there was a sort of, let's say, correlation between the amount of weight loss which was reached, you see, from 0 to more than 15 kilograms, and 86% of these patients were able to have diabetes remission. But this also means that 14% of them did not get any diabetes remission, even if they lost 15 kilograms, which is really a lot. So trying to understand why this happened, they divided subjects in responders and non-responders. And maybe the major difference between these two groups was the pancreatic volume, which was measured with the NMR, and a sort of measure of the pancreatic fat, I mean the amount of fat which is inside the pancreas. And those who were able to lose more fat within the pancreas were able to really become back to not having diabetes anymore, to diabetes remission. So maybe it's not just fat or body weight, but visceral fat, meaning that the pancreatic fat is a sort of visceral fat, and we have to probably deal this with something in a different way. Another point is that it might be easy, and I think it is also your experience, to make a patient to lose weight at the very beginning, especially with the totally substituted diet, but then patients are usually restore their body weight, and these are the different phases that you see at the beginning. Most of them were able to complete, but then some of them were not able to keep on the diet. So their body weight went back again to the original weight, or almost there. And this means that at the beginning you will see there is a major weight loss here, but then after the end of the trial, you will see that the subjects who were on the trial in blue gained the weight again, and this means that at the very end they also did not have the remission anymore. So you might be able to make patients to lose 15 kilograms, 86% of them have diabetes remission, but they are not able to keep it for a long time. They gain weight again, and diabetes comes back. And we know that diabetes is a progressive disease, so maybe the major reason for this is the progression of insulin deficit. So a very strict low-calorie diet successfully induced diabetes remission, but durability is, however, too brief. So it's not a cure, it's just a temporary remission. I don't know if it's fashionable in Italy, in India, but it's sometimes fashionable in Italy, the metabolic surgery. And we know that there is some success, especially in terms of weight loss. You see these are two different approaches of metabolic surgery. You see a major weight loss, like even close to 30% here on the left of body weight. And also the HbA1c, these were diabetic patients. There were a major reduction, and many of them became almost, virtually normal without any kind of treatment. But again, remission is temporary. Sometimes the patient will get diabetes again, might be different between the two surgical approaches, a difference in terms of 4 years between these two kinds of surgery, but still the majority of them, even after the metabolic surgery, even after losing 20 or 30% of their body weight, will have diabetes again. So diabetes still recurs even after metabolic surgery. And sometimes it happens and these patients have kind of complications. I have some experience with this. These are not my data, because some of them, because of the changes in the food inside the gut, they have an increase in GLP-1 secretion here on the left, which means an increased insulin secretion, which sounds very good, but sometimes it also is able to determine hypoglycemia, some kind of reactive hypoglycemia after the metabolic surgery, and this is something that we have to look after this kind of surgery. So although metabolic surgery is probably the most successful procedure for diabetes remission, still it has complicated and it's not a cure, it's still a therapy. So maybe a temporary intensive treatment can be a solution. There have been many trials on this. This is an old trial done in China, even doing with, you see, a subcutaneous insulin infusion. Imagine a type 2 diabetic patient, you just start with a pump, trying to obtain for a short period a normal glucose control in order to remove glucose toxicity. And you will see that actually there is some kind of better improvement in terms of remission, but still after a while diabetes comes back, and certainly given insulin will not make your patients happy. Another way is to try to start with intensive treatment and then try to stop it, and this is sitagliptin trying to plus glargine. You will see in the white line, and you will see there is some kind of remission for a while, but still after a while diabetes comes back again. Maybe it's a little bit different with the dapagliflozin and SGLT2. You will see there is some kind of different of times for remission, but still diabetes comes back in all the patients. This is another attempt with the basal bolus insulin plus metformin, and trying to do it sometimes for 2 weeks, every 3 months. So patients come to the office, you give insulin for 2 weeks, and then you stop insulin, and you see there is no improvement in terms of HbA1c or remission of diabetes. This has been another attempt with the combination of glargine and Lispro, basal bolus, or glargine, Accd, or just glargine. There is a reduction in HbA1c on the left, an increase in insulin secretion, an improvement in insulin sensitivity, but still, after the washout, everything comes back. So it's just a temporary remission, partially induced by the removal of glucose toxicity. So even intense treatment for a short period fails to achieve diabetes remission. So maybe this is just because we've seen that with the direct trial, it was too late. Okay, you have to start at the really beginning. And I think the major suggestion for this is SURPASS 1 trial. I already showed you the slides. Here there is no washout period, but it's important to note that these subjects, 40% of them were naive to any kind of therapy, and all were naive to any kind of injectables. So it was really at the beginning of the national history of type 2 diabetes. And again, we see that 52% were able to reach an HbA1c lower than 5.7. Again, is after a treatment with tirzepatide, just one treatment, any other medicine is there, and more than 50% were able to reach a normal HbA1c. Again, it's under a drug, but still it's a good satisfaction in terms of diabetes progression that we can reach this normal HbA1c. I mean, having normal blood analysis, I think, is a good success. Another way has been done again in China. At the beginning of the natural history, duration of diabetes was not more than 4 months, and they tried to do some kind of calorie restriction with metformin, which was already present, and dapagliflozin, or just a calorie restriction here. So try to compare whether dapagliflozin was able to induce some kind of diabetes remission, and they treat with patient with 12 months, then they stopped all the medicine and try to observe whether some of them were really able to have diabetes remission below 6.5, below 5.7. And there has been some kind of difference. I mean, not very much, only 44% with dapagliflozin and metformin if already present, and just after 2 months of washout, meaning that 50% of them, more than 50%, did not have any remission at all, but still tells us that being aggressive at the beginning of the natural history of diabetes is the best way to delay the progression of this disease, which for many of our patients sometimes means insulin. And we do know that our patients never want to initiate an insulin treatment. So just to conclude, diabetes is a progressive disease. There's nothing we can do about it. We can try to slow it, but if both of your parents or the parents of the patient have type 2 diabetes, there's nothing you can do it. There will not be any available remission. So it's better to do a treatment and do it in the best way. So remission can be achieved, but only temporarily, and this is true also with the metabolic surgery. I believe that our duty is to choose the right therapy, even with ambitious targets, especially now that we can reach them without having any hypoglycemia, is perhaps the only way to slow its progression. And thank you for your attention.
Thank you, Dr. Andrea, for a wonderful lecture on remission. So we have time for at least 2 to 3 questions, and then we can move forward for quiz. If we have any question. Yes. Please go to the mic. We invite 3 of the speakers here on the dais, please.
Am I audible? My question is to Dr. David Strange, sir. Sir, is there a blunting of incretin effect in pre-diabetes also? And if so, is it a continuum from pre-diabetes to frank diabetes?
Is this one on? I'll swap it. I'll go for this one instead. Simple answer is yes in both parameters. Actually, the study that we did looking at West Africans, we've now replicated that in India, although that's not been produced yet, been published yet, that we demonstrated from 18 onwards, there is a reduction in active GLP-1 production to a standard meal tolerance. Basically, there is a genetic predisposition to higher DPP-4 activity in people of Indian origin, of West African origin, which means exactly the same nutritional input triggers a lower active GLP-1. And that's probably why we saw incrementally increased benefit here with the DPP-4 inhibitors. When we saw the DPP-4 inhibitors in the UK, they were seen very much as a decaf version of a GLP-1, whereas here we saw HbA1c reduction of 1.4% from exactly the same tablet that we were seeing at 0.8. That's been replicated now in people with prediabetes and also people living with obesity who are technically normoglycemic, but they do have evidence that they have reductions in GLP-1 activity and reduced sensitivity to GIP. The impact on glucagon and PYY particularly haven't yet been studied, and they're two that are going to be of massive interest in the near future because these are new medications that are coming through targeting those systems.
So my second question is to Dr. Andrea. So what percentage of patients achieving diabetes remission translate into long-term diabetes reversal? Any trial evidence?
You're asking if there is a long-term remission. I believe there is no long-term remission at all. I mean, again, diabetes is a progressive disease. There's nothing you can do about it. You can just try to slow diabetes progression. I mean, I think it's the experience for everybody. If the patient comes to your office with 12 or even more of HbA1c, you usually start with some kind of insulin. You will try to reverse a little bit the natural history of diabetes, but you will never go back with just metformin, for example. So the best way to slow down, and I believe the last slide was the best experience, is to remove glucose toxicity. Glucose toxicity is one of the reasons why diabetes progresses, together with obesity and many other risk factors, but glucose toxicity means treat, good, and early, as soon as you have diagnosis or even before the diagnosis, if you wish.
Do we have more questions? Yeah.
So this is again to Dr. David. So if I understood you correctly, you said the GLP-1 RAs have a limited effect on weight loss. I mean, they cause, of course, they reduce the weight. They also reduce the adverse events, the major cardiovascular adverse events. But there seems to be something more which is happening with the GLPs. And I believe the attribute is only till about 30%. And there are other things which are happening, maybe some pleiotropic effects. So my question is if newer GLP-1 RA analogs, while they cause a significantly higher weight loss, is it okay to continue to using the previous older GLP-1 RAs, because there seems to be some kind of a ceiling effect in terms of getting the benefit of the reduction in the major cardiovascular events?
Yeah, that's a really interesting problem that we are all facing. We are never quite sure whether we want to go for the maximum weight loss. And as you know, we've got far superior weight loss with Mounjaro than we see with semaglutide, which was incrementally better than liraglutide, which was better than anything that went before. But we have to think about what we are doing, why we are doing it, and what is the event horizon that we're looking for. So if, for example, you're looking at someone my age, I'm quite close to cardiovascular risk. I'm quite a similar age now to what my father was when he had his first heart attack. And therefore, for someone like me, I'd want to be going for a drug that gives you maximum cardiovascular proven benefit. If you're looking at someone Julia's age, who's far younger, has decades before she's at risk, then actually, if she was in the position of significant obesity, which she's not, I hasten to add before she punches me, actually for her, you'd be more interested in the maximal weight loss because the incremental time of that weight loss would give you additional benefit. And then we start to play with risks according to what we need for individual patients. We also know with these medications that we titrate according to how patients go. So actually very few of my patients in my obesity service are on maximum dose of any therapy. Most of them are on the therapy that got them to where they needed to be, and then we keep them at steady state thereafter. So we end up playing with the gap between what they want to achieve, what they need to achieve, and what we can sensibly give them with minimal side effects. And an important component of this that I'm going to come actually into our next session is how we mix this with lifestyle, or for that matter, Katrina's going to argue that we don't need lifestyle at all. And I think that is a really important component, and maybe we'll have that conversation over dinner later, because I don't want to start cheating.
Thank you.
She was coming. I don't know.
Sorry, someone has written a very important question here, but I'm afraid we can't read it because
Once weekly?
No worries, no worries.
It's regarding, ma'am, once weekly glitazone recently launched here in India. So, DPP-4 inhibitor and about imeglamin. So you were talking about the new drugs. So please let us know about these two drugs.
So for the once weekly, I have to... once weekly DPP-4 inhibitor. So I am not aware of any cardiovascular data, but I guess it will be also as similar as for once weekly other drugs, that people prefer once weekly application. So when it comes to user comfort, it for sure will be beneficial. I have to say I don't know about the drug personally. I don't know if anyone from the panel here can help on that.
we don't have the once-weekly gliptins in the UK or across Europe. It's not reached us yet. What I would anticipate, based on extrapolating the other DPP-4 inhibitors, is if it's given very early in the disease, if it's given at day of diagnosis, when you're giving the metformin and giving the first medication, if you give this plus a once-weekly DPP-4 inhibitor, what you'd see is delay of progression of the disease. What you'd expect to see is less progression, home IR would get better, you'd see better chorecycling, which in longer term, we would expect you to give a cardiovascular benefit in the long term through better diabetes control. But I would be very surprised if it's got any standalone additional cardiovascular benefit, because the very action of a DPP-4 inhibitor, it just stops natural GLP-1. You're never going to get the supraphysiological doses of GLP-1 that we see with semaglutide or the tirzepatide. You're never going to get the supraphysiological levels you need to give you the cardiovascular protection, I would guess, but I'm stressing that's extrapolation about what we already know.
And maybe just to add, at least in my country, the prime indication currently for DPP-4 inhibitors is usually other forms of diabetes than type 2 diabetes. So for example, in people who received immunotherapy for melanoma, developed diabetes, that's a very useful add-on medication here, and could be maybe the same if it's less frequently applied. And for frail people, of course, yeah, when we don't want to have additional weight loss again.
So, quick comment. We have gliptin, which is launched in India, and it's a once-weekly gliptin. I think that's what they are talking about. And it's coming straight from Japan. It's a Mitsubishi product. And so the trials show that it has got exactly similar glycemia control in terms of the A1C reduction, with a slightly less fasting control. So in clinical practice, if they're well controlled on a once daily gliptin, you can switch them to a once weekly gliptin because of convenience. And I have patients who have been initiated on once-weekly gliptins with a SGLT2 inhibitor to start off with the metformin. So working really well. So once we are starting to get the reports because it's been launched about 4 months back. So we are just about getting the reports on the HbA1c reduction. So pretty good, yeah.
So your team is already a bit conscious about time, but I still have a question back to you guys because that would interest me now. What is the cost factor? Is it like same price or more expensive than a once daily drug?
So multiply that by 7.
Almost same price.
So it's 100 rupees. So if once daily gliptin costs you about 14 or 15 rupees, this is about 100 rupees. So yeah.
Same price. So with this, we'll conclude this session and we'll move forward to the quiz. Over to you, Dr. Bharat.
I would just request Dr. Kirti Suta to please pass the mementos to the chairpersons. Thank you.
So post-lunch, we are again with quiz 2. Little tough this time, partly due to the hyperglycemia you have and partly due to the quality of questions. This is separate code for the quiz. You need to register again. I am sorry, but we are putting it separate. So all those who have joined late, there is a extra mark or extra point for answering fast. So be quick when you are answering. Put your name, 3 questions, and if you are a winner, you are in for a prize. We will wait for 15 more seconds. Should we begin? Last 5 seconds. So let's begin. Answer quickly. For people with obesity, maximum weight loss with which therapy? You need to be attentive during the lecture. So 48 have got it correct. Let's see the leaderboard. Zlatan, who is this? Can I know? Be cautious. Moving on to the next question. Barriers to treatment satisfaction with insulin therapy. Easy one. Eighty got it correct. It was an easier one. Let's see. Maintaining, good. Last question. Very thin margin, 1865 to 1852. tricky question. "33 have got it correct. It was really tricky one, needs attention. Let's see who is the winner. Thinky, can we know? Great. Can you come over here? A big round of applause for her. May we know your real name? Namita. Thank you.
Okay, going further, I would like to invite the chairpersons, Dr. Srinivas Murthy, Dr. Supratik Bhattacharya, and Dr. Anshan Kalia, to please come on the dais and set the setting for the debate.
Very good afternoon, everyone. So we are up for a very interesting debate, and the topic for today's debate is in the era of GLP-1 RAs, whether lifestyle intervention is still very important or not. And for this we have Dr. Catherine and Dr., if I'm not wrong with the spelling, Katrina and Dr. David for the motion. So I think Dr. David will come first. Yeah, welcome. Yeah.
Brilliant. Thank you very much for the introduction. Thank you. So before we start this, I do want to point out that this is a debate for a little bit of fun. This is purely fun. Our opinions that were up here are not necessarily what we believe. We will tell you right at the end. So this is fun. So before we start, can we have a quick show of hands? Particularly in light of my last presentation. How many people believe exercise, lifestyle advice is still worthwhile? Remembering that only 4 of you know where the stairs are to your room.
I think your job is done already.
That's it. Have you noticed? Lots of the hands have gone down now when I said that. Okay, so it's my job to argue that it shouldn't be just 4 of you. All of you need to find out where the stairs to your room is. And actually, although I say, it sounds like it's really easy, but we are the most educated people in the country on this subject, yet we're not following the advice. So how do I change your mind? So, here's the story so far. We've seen the Look Ahead trial. That study in America that looked at weight loss, exercise, nutritional advice over a 10-year period. It was abandoned due to futility because it wasn't showing any benefit. On the background of that, I demonstrated the semaglutide study, the SELECT trial, which demonstrated a 20% reduction within 4 years. So looking at those 2 trials head to head, lifestyle advice, waste of time, SELECT, brilliant. We've seen that with a whole host of trials, notably the Harmony trial. Focus for a moment here on Harmony, because Harmony was with albiglutide, and albiglutide, well, it was abandoned. It didn't cause weight loss. It doesn't cause a HbA1c reduction. We don't sell it because it was rubbish. But it still prevented cardiovascular events. So actually, it is quite easy to see, well, why bother with weight loss? Why bother with lifestyle? What's the point? We have twincrete, we've got triagonist, we've got ritatrionide on its way, we've got cagrisema on its way. Do we really need lifestyle anymore? Well, I am hoping over the next 10 minutes or so to convince you to find out where those stairs are. I'm hoping that tomorrow morning, more than one other person will be joining me in the gym. Because Look Ahead trial, yes, it was abandoned because it didn't work. But the main reason it didn't work is because it was done in America. And Americans don't like exercise. Americans don't like healthy nutrition. They would quite literally get in the car to drive 400 yards down the road. If you look at the population, the 20% or so who actually did manage to achieve a 10% weight loss within a year, they had a 21% reduced risk in all-cause mortality. They reduced their cardiovascular events. They had a hugely significant benefit. The suggestion is that lifestyle works if you do more than talk about it. It's not just about saying, yes, this is good for you. It's about getting off our bums and doing it ourselves. When it comes to the SELECT trial, the bit that very few people talk about, yes, it was a massive win for semaglutide. But this was only started after 3 weeks of aggressive lifestyle intervention. And if you didn't comply with that lifestyle intervention, you didn't get into the trial. If you don't show signs that you're exercising, if you don't show signs that you're modifying your diet, before day of randomization, you were kicked out. So SELECT only works as an adjunct to lifestyle. But it's more than that. It is important to treat diabetes, it's important to treat obesity early. In the UK, we have recently estimated that if we were to take everybody with a body mass index of 35 or above and give them the drugs that we know will improve their quality and quantity of life, it would cost our health service £1.8 billion. That's on a background of a £4 billion budget. Basically, a quarter of our budget would go on treating one disease. It's not affordable. Hugely cost effective, but not affordable. The importance of treating obesity early is all about stopping people getting to the body mass index of 35. And that's where lifestyle really can play a role. If we can actually get into our patients while their body mass index is still between 25 and 30, in an Indian population, while their body mass is still just touching 23, what we will see is a halving in the risk of type 2 diabetes. We'll see a halving in the rates of sleep apnea, a reduction by arthritis by a third, reducing heart failure by about 12%. But that's a much bigger population. That's 4 times more people than are living with obesity already. So if you halve the number of people who are progressing to diabetes in what amounts to around 280 million people, that will have a much more dramatic impact than reducing by a fifth the number of people who are already living with obesity. There's 70 million living with obesity. And it's more than that. Lifestyle advice is not just about living with obesity. Lifestyle advice is not just about cardiovascular events. We actually saw that in the data I've just shown from the SURMOUNT CVOT. There was a non-significant 8% difference between Mounjaro and dulaglutide. But actually, far more importantly, the bit that I'm really interested in is a 16% reduction in overall events. Lifestyle is not just about how we look in the mirror. Lifestyle is about how we feel. Lifestyle is about how much we can go out and play with our children. It's about how we feel when we go to bed, how we feel when we wake up. And there are many different components of lifestyle advice that will have an impact of that. The first of that, Dr. Makkar's already done with us. If we stand up every 30 minutes, we will give us, on average, an extra 6 months of healthy life expectancy at the end of our lives. Just that one intervention in this group is going to make you live a little bit healthier for a little bit longer. Then our step count. We're all obsessed with it. We've got Fitbits. Actually, a few years ago, we handed out the step counters when we were here. If you can walk 500 more steps per day, that will reduce your cardiovascular risk by approximately 6%, with estimates going between 2 and 9%. If you do that every day, you will live 4 years healthily longer, just from doing 5-minute exercise. Lifestyle is not just about the obesity. It's about living healthy, living longer. We then have the other components of lifestyle, the bit that I choose to ignore. Sleep is good for us. If you can get uninterrupted sleep, even on the weekdays and the weekends, your risk of diabetes falls. Your risk of heart failure falls. Your risk of cardiovascular disease falls. Your ability to concentrate improves. You will become more productive. You will get more enjoyment out of your life. Now, it doesn't matter when that is. There's all sorts of rumors out there about, have we got night owls or larks? Personally, I'm quite happy being awake till 2 o'clock in the morning, providing nobody jumps on me at 10 o'clock in the morning, before 10. And if somebody would tell my 7-year-old that, I'd really appreciate it. She's one of those larks who loves jumping on daddy at 5 a.m. However, good quality sleep is good for your mental well-being. We then have the proper exercise. We've got the climbing the flights of stairs or the joining us in the gym, just the physical sweating. Now, I want to stress, exercise that involves sweating does not involve Lycra. Anybody who feels the need to wear Lycra, basically you don't want them in your life. Exercise is just something that makes you sweat, preferably something you enjoy. It could be going for a walk in the gardens. It could be climbing a flight of stairs. It could be having a kick around, playing cricket with your son, playing with the Barbie with the girls. Don't ask. But this will improve your muscle tone. The exercise you do today predicts how frail you'll be when you're 80. The sweating you do today predicts your risk of dementia better than any drug. Sweating this week for about an hour and a half will reduce your risk of dementia by 6%. Notice I say sweating, exercise that involves sweating. This is not a case of putting on Lycra and running for half a marathon. That's just ridiculous. But it's exercise that you enjoy. And then we come to the strengthening exercise. We should be doing some resistance exercise. Our bones will really thank you for that. Your bone health is actually the most important determinant of your frailty. The bone health will predict whether you get the arthritis, whether you have the fractures, whether you end up in hospital, far more than any of the other parameters will. And bone health is only maintained with resistance training. Now that's in the pre-diabetes phase. When you've got diabetes, there is a risk of just losing weight. You see, normal physiology actually tries to make us gain weight. Gaining weight is protective. Remember, for decades, for millennia, the biggest threat to our survival wasn't obesity or cardiovascular disease, it was starvation and disease. And obesity protects you against starvation. Obesity protects you against lots of viral illnesses. Therefore, weight loss is actually anti-physiological. Losing weight goes against physiology. All of these drugs that make you lose weight will make you lose weight in a non-physiological manner.
All right, just a gentle reminder, 1 minute.
If you just take drugs, I did waste 1 minute finding out what their opinion was.
No worries,
before.
it could take you a minute.
Thank you. I'm cheating now, blatantly cheating. If you just take drugs to help you lose weight, you see this phenomenon of sarcopenic obesity. You get mitochondrial dysfunction. Your mitochondria literally shrink away, which means you get reduced ATP synthesis, which means you become less efficient. It actually means you're using the same amount of energy to carry less of you around. You need to get to a state where when you lose weight, you lose less energy in order to continue life. And in all of the trials where we look at exercise plus nutrition, we do see that that is a good plan. But it begs the question, what happens if you just take drugs? Now, to date, there's only been one trial that did that. This was a trial with liraglutide. And it was a choice between taking liraglutide, taking exercise, taking liraglutide plus exercise, or do your own thing. Published in the New England Journal of Medicine. It was picked up, unfortunately, it was in May 2021. Didn't get that much press. Apparently there was a virus going around. I don't know if anyone heard about it. Now, what they demonstrated is if you take liraglutide or if you take exercise, you will have very similar reduction in both in fat mass. But actually, if you take the liraglutide without the exercise, you will have a bit more of a reduction in your lean mass. Now, the important thing is that bone health. Because if you took liraglutide without the exercise, you developed osteoporosis. If you take liraglutide with exercise, you don't get osteoporosis. Liraglutide, if you take drugs without exercise, you are potentially harming your patients. First rule of medicine, do no harm. We need to prevent sarcopenic weight loss. And the only way to do that is with drugs and lifestyle. Lifestyle is more than just weight loss. It's more than just how we look in the mirror. It's about our total body health. And with that note, may I just say, Katrina, good luck. Thank you very much.
All right, thank you. And we now invite our second speaker, Dr. Katerina, to speak against the motion. And just to be fair, Dr. Katrina, you get a couple of minutes more. So, yeah.
Thank you. Thank you. So, Dr. David Strain is an excellent speaker, so my task will be hard, but not so hard, I believe. Because, yes, he's right, exercise is great, and I believe most of us felt kind of guilty because we know he is right. Exercise is a really good thing. We feel very good when we exercise. But then, let's be honest, do we have time? Even he just said he's 7 years old. She jumps on him at 5 a.m., so he doesn't get much sleep. Real life is different. So let's see what data say. Weight loss. Lifestyle interventions for weight loss. We have seen, we all know that these drugs, the new drugs, GLP-1 receptor agonists, are super effective. They can allow us to achieve a weight loss that is similar to what we achieve with bariatric surgery, and this is very impressive, and it's just a once weekly injection. Diet-induced weight loss is also possible. So different trials, several trials demonstrated that with diet you can lose a significant amount of weight. These are kilograms, but still most trials demonstrated that lifestyle interventions are effective in terms of weight loss, but we have just heard from Professor Andrea Giaccari that then people regain weight. We have to remember that obesity is a chronic disease, and it is hard to stick to lifestyle changes. And in fact, if we look at the same trials with lifestyle intervention, we see that in all of them, people regained weight. In some of them, there was even an overshooting. They even regained more weight, and they ended up weighing more than at baseline. It is hard to stick to lifestyle changes in the long term. So most people can make some changes in the short term, but then the magnitude of these changes diminishes when time passes by. And the same here in the Look Ahead trial, which was mentioned by David Strain in people with overweight or obesity and type 2 diabetes. So weight loss in the first year, but then people regained their weight and actually ended up with a weight loss of approximately 5% at 8 years. This was, same proportion at 4, 5, 6 years. So good, yes, they were able to achieve eventually a weight loss of 5%. That has some benefit, but as he said a few minutes ago, only for people in this room know where the stairs to their, to their room are. And we are among the most educated people in this country, and he even repeated that just 2 minutes ago. And we do not follow our own advice. It is so hard in the real world to stick to lifestyle changes. And what happens with the drugs? We have already seen this data, and this is more than 3 years. So if you stick to obesity management medications, you will keep your weight off. And again, this is just once weekly injections. It is much easier than calorie counting and exercising. We have not much time for that. So this was for lifestyle alone. Is there any data supporting the combination of lifestyle with obesity management medications? We have heard that liraglutide may cause, actually not really osteoporosis, but a reduction in bone mineral density. And then we have to demonstrate that that small reduction translates into increased fracture risk. We don't have any data on that. We know from bariatric surgery that malabsorptive procedures can result in an increase in fracture risk, but not restrictive procedures such as sleeve gastrectomy, which is the most commonly performed procedure nowadays. So what do we know about combining lifestyle and obesity management medications? So this is the step 3 trial with semaglutide, and here we have an intensive lifestyle intervention combining meal replacement in the first period and exercise with semaglutide. So eventually people on the drug and lifestyle intervention lost 16% of their initial weight, okay? And what happens without exercise? So in the step 1 trial, where they just took the drug, actually the weight loss was very similar, 15%. So there is no additive benefit of adding lifestyle to obesity management medications as far as weight loss is concerned. Of course, people here who just took placebo in the step 1 had a modest weight reduction, whereas the weight loss in people adopting a lifestyle intervention was greater in the step 3 trial, but still, look at what difference. So, as for combination, really not much data. Do we have any cardiovascular benefits? We have heard a lot about the importance of targeting cardiovascular health in patients, in people with obesity, in people living with diabetes. As we have already heard from David, there was no effect of lifestyle interventions most studies on cardiovascular outcomes. This was the diabetes prevention program. No benefit of lifestyle in the long term on MACE, on myocardial infarction, on cardiovascular death, and on stroke. Here again, extending MACEs, which included heart failure, no benefit as compared with placebo or metformin. Look ahead, we have already heard this, seen this data, no effect of lifestyle on cardiovascular outcomes. Okay, so it doesn't look like lifestyle intervention, intensive lifestyle intervention, combining dietary advice, exercise, results in any cardiovascular benefit in terms of heart outcomes. There are, as we have heard, some trials that demonstrating a benefit. In the look ahead, in particular, people who were able, those heroes who were able to achieve a weight loss greater than 10% actually had a cardiovascular benefit. Let's see how many people were able to achieve a weight loss of at least 10% in that trial. So at 1 year, 40% of people were able to achieve at least 10% weight loss in the look ahead trial. What happened in the long term? This number was quite lower. 27% were able to maintain a weight loss of at least 10% at 8 years. So yes, these numbers are nice, but we can do much more with the medications alone. So these are data with tirzepatide. Let's look how many people were able to achieve a weight loss of at least 10%. See? 80%. It is a lot. And there were more than 2/3 of people who lost more than 15%, and there was approximately half of them who lost more than 20%. And even, we go even further, 1/3 of people with the highest doses lost more than 25%. And we have also heard that the greater the weight loss, the greater the cardiometabolic benefits. So this is really important, and there is no way lifestyle could ever compare with these results. And we have already heard about the SELECT trial. So weight loss results in more than 20% risk reduction. And it's not just weight loss. It was mentioned that these drugs have pleiotropic effects. They reduce inflammation. They have other benefits. So it is probably not just the weight loss, also because these results were significant. Actually, there is a sub-analysis that was presented at the Obesity Society meeting in the United States in last November. And actually, these curves separate very early, and the benefit is already significant before 6 months, when weight loss is not that much. So it's not just weight loss. So are there maybe other data in favor of lifestyle intervention alone or in combination with these drugs? This is the data. No data so far. I'm sorry. So my key take-home messages are: obesity management medications deliver unprecedented improvements in weight, blood sugar, which translate into reduced cardiovascular events and mortality. Lifestyle changes alone, yes, some benefits, but these are difficult to implement in the long term, as we all know, as he told us, as he demonstrated to us. Lifestyle changes plus obesity management medications, well, to date, the evidence supporting additive benefit is lacking. So, David, I am very sorry, but I think you should be very, very upset by now. And with this, I thank you for your attention.
Fantastic. I think fair points on both sides. Since we still have a minute, do you have a minute of rebuttal from you?
Yes, yeah, thank you. And Katrina's just given a very eloquent argument. Her entire argument...
I would like to keep this, please.
I don't even think that's me. Anyway,
What were you saying?
her entire argument is it's difficult. Full stop. End of story. Her entire argument is this is difficult. Hands up who thought it was difficult getting out of bed this morning on a Saturday to come and learn. Thank you. But we all did it. Just because something is difficult is not a reason not to do it. The other thing has been a massive focus on cardiovascular mortality and benefit. If you'll notice, I wasn't talking about that. I can promise you one thing. Absolutely every single patient you see will die one day. Every single one of them, every single one of us will die one day. I'm not talking about cardiovascular mortality. I'm not even talking about cardiovascular benefits. I'm talking about health. What we want to deliver is health, improve quality of life. We want to deliver a better living, a better ability to spend time with your family, with your children. Lifestyle advice will deliver that far better than any drug. On that note, Katrina, what do you say?
I say, yes, it is beautiful in our dreams, but then again, it is difficult. And yes, it was difficult even for me to get out of bed this morning, every morning actually, I do it, but it's actually much more difficult to implement long-term lifestyle changes. Yes, thank you. And actually, well, for the sake of time, I didn't show a huge amount of data, but we have data, solid data on outcomes in renal function with the FLOW study. So we don't have anything like that with lifestyle interventions. Yes, there might be a reduction in microalbuminuria, but I mean, the results we see just with the drugs, without lifestyle combined with medications, are really amazing and impressive.
Did they feel any better?
Well, we have a huge amount of data about lifestyle, quality of life improvement. There are a lot of patient-reported outcomes in the trials that clearly demonstrate that patients feel better. And, knee osteoarthritis with semaglutide, we have improvements. There are not much data on that with lifestyle intervention. Or
I think you have made your point, and I think we'll stop there. This is a debate, so no questions. You can take them up on a one-to-one basis after this. But a big round of applause one more time. So well thought, yeah. And fair points on both sides. So fantastic job done. Yeah. Thank you again, everyone. Thank you.
Gupta, Dr. Meena Chhabra, Dr. Vivek Gupta, Dr. Ajay Kumar Gupta, and Dr. J. Arvinda. I would request the chairpersons to please come on stage.
So good evening, everybody. Welcome all to this another session. Like we have got Dr. Banshi Sabu, who will speak on standards of care for type 1 diabetes 2025 and beyond. Yeah, where is it? Makkar sir.
Dr. Makkar, is Dr. Bansi here? Kirti, is Dr. Bansi here?
Dr. Julia. Yeah. So Dr. Banshi will be joining in a while. So meanwhile, we can go to the next session. Dr. Julia Matter will be talking on update in AID, that is automated insulin delivery. Over to Dr. Julia.
Thank you so much. Also helps with my schedule because then I don't need to give 2 talks after each other. Thank you so much. So disclosures again have not changed. And now I want to discuss with you about automated insulin delivery updates and changes. And from the very left lower end to the right upper end, we can see the more automatization that we have gotten in the last decade or so. So we started off with insulin pump therapy, had the combination with CGMs but without interaction, and now we are somewhere between hybrid closed loop systems where users still need to administer insulin boluses versus fully closed systems that can more or less control diabetes themselves. And I would like to stress again that Danish cohort of people with type 1 diabetes, where we see also in the real world that people benefit from automatization. So if they have a fully or hybrid closed loop system, they achieve more or less the targets set by the ATTD Society, about 70% of time in range and reduction in both time in hypo and hyperglycemia. And of note, if you look at these numbers here, these were achieved already with the early version of the Medtronic system. So 670G, not 780G. So we can assume that nowadays we achieve even better control. Also in the real world, when we look into Omnipod 5, in all groups, age groups, 70,000 people with type 1 diabetes, we see achievement of time in range in the suggested amount. At the same time, reduction in time below range. So we can safely and efficiently manage type 1 diabetes using a patch AID system nowadays. Importantly, and we heard about various other forms of fasting that may occur during Hindu festivals, a relatively recent study from colleagues looked into the AID used during Ramadan, so when people are maybe worried because of the acute changes in calorie intake. So they had 3 phases. They had the pre-Ramadan phase, they had the Ramadan phase and the after Ramadan phase. And what we could see that more or less daytime when people were not eating was quite stable before, during and after Ramadan. And nighttime people achieved slightly less control, especially during Ramadan, of course attributed to the higher calorie intake, but still not doing so much worse compared to the phases before and after Ramadan. And we heard about different hurdles that we have in type 1 diabetes management, and one of them is, of course, to guesstimate the content of carbs within a meal. And I forgot to bring a picture of a friend of mine with whom I was traveling to India and his glycemic profiles on an AID system following the meals, because we Europeans, and potentially also even you, if you are well trained in what calories and nutrients is included in your meals, how to guesstimate the meal content of each meal. And so they had just a fixed protocol saying small, medium or large portion, or going with the regular carb counting. And what we can see, and these were young adolescents with type 1 diabetes, also the one who had very fixed amounts of carbs to be included, managed quite well their diabetes without increasing their risk of hypoglycemia. And that worked out quite fast, so immediately after starting, they achieved the targets and maintained that for a whole period of 3 months. Then, importantly, we also need to consider sick days, because here insulin changes might again change. So we have different types of changes that can occur. So, for example, gastrointestinal symptoms can cause to hypoglycemia because of reduced calorie intake, whereas symptoms such as fever, respiratory infections might cause hyperglycemia because of the infection that is ongoing. So they included 113 people on an AID system, and those had 91 episodes with acute disease. And when we look into the conditions that potentially can cause hyperglycemia, still during illness, the time in range was okay, with 67% in range, slightly lower than compared to baseline. On the other hand side, the diseases that can cause hypoglycemia did only marginally increase the risk of hypoglycemia, but managing quite well when it comes also to hyperglycemia. So what can potentially help to overcome those symptoms? So we can see that potentially autocorrection can be reduced in case of hypoglycemia and can be increased in case of symptoms causing hyperglycemia. The carbohydrate intake in both conditions was lower when people were sick, so of course we can imagine also the ones who have hyperglycemia might not be wanting to eat as much as normally. So another important aspect that will be discussed potentially even more in the future, AID in the long run, and there is data from colleagues in the United Kingdom where they looked into how in the real world open source AID is doing and what people are reporting here. So we can see that they achieve even better glycemic control when it comes to time in range compared to the conventional systems, because they're really adjusted to the user. They have a 0.8% reduction in HbA1c and have a time above range of 18%. We see also time below range targets are met with 3.2%. Another important topic of research, and that's still understudied, and we are currently also part of a group where we look into the insulin requirements throughout the menstrual cycle. So we can see that there are relative changes throughout the cycle where we do see that, for example, in the early follicular phase, there might be lower insulin requirements compared to the ovulation phase and also to the luteal phase. And this can potentially be of use when we have women using AID also, of course, similarly as men, but to understand when we might need a boost or a reduction in the insulin dosing. Another trial looked into the Omnipod use in type 2 diabetes, and that's a very early work for the first time using the Omnipod 5 in a relatively large group with different ethnicities and also different glycemic control as a start. And also there we can see that at the end of treatment HbA1c has significantly improved, the time in range has also gone up, and the population was quite similar to the population I was showing you before. So more or less what we always observe in insulin-treated type 2, roughly 45% in range if they have no additional decision support. And if they have use of automatization, we achieve nearly the targets that are suggested without increasing the hypoglycemia, which is of course important in type 2 diabetes who might already have cardiovascular disease where we should really avoid hypoglycemia. And we also managed not to increase hyperglycemia but rather reduce it. So they really overall managed their diabetes well with the Omnipod 5. When it then comes to the selection by the people living with diabetes, of course, we need to take into account availability in the country. So also in my country, we only currently have 2 systems available, whereas the people on our northern border in Germany have 5 systems available. But then the more you can select, the more you should base your decisions on the person living with diabetes so that they can really use the system that they are happy to go forward with. They looked then into potential barriers when onboarding. Of course, insurance coverage might be an issue, financial barriers might be an issue, but of course also the technical support and the support from a multidisciplinary team to really overcome some of the hurdles. Also the healthcare team should be familiar with the system, should be able to train the person well on the system, help them to adjust the system to their needs. And we as advocates for our people living with diabetes should also use our voice to make the healthcare system more accessible to the majority of people living with type 1 diabetes for such a technology. And shortly I also want to show you the data that we had received from our 2025 survey in Germany, Austria and Switzerland, and potentially for Indian comparisons the numbers are not that big, but we had a return rate of 1,000 physicians and healthcare professionals that gave us their voice. And what they told us that the majority of people are now using CGM systems already for the last 5 years, but that there is a steep increase in the uptake of AID technology in these 3 countries. When we then ask them about the burden with the technology, they say that they expect technical problems to happen, to have an overload of information for the people, an overload of technology for them, and potentially even a lack of trust. And the results between the 3 countries are quite comparable. When we then ask the patient voice, and so you can differentiate here on the lower end of the presentation, I have indicated the patient voice here. What they say when it comes to relevance of technology, they mention number 1 CGM and already number 2 AID technology, again consistently across the 3 countries investigated. And when we then ask the people with diabetes about why they chose a system, the top 3 reasons were user-friendliness, quality of the algorithm, and size and weight of the insulin pump. So I think when suggesting systems, we should also be aware of some of those backgrounds that could be relevant for the individual user. So as and maybe just to go back and making promotion of that, I asked Dr. Chawla to join this initiative, and for the first time for the 2026 report, we will have data from India also joining in. So I think that's a huge success, not only having 3 countries, but really going beyond the European perspective and having Indian perspective in that as well. And I hope I can report at some of the meetings next year back to you what we see in terms of differences. So as a wrap-up, we do have various commercial AID systems on the market. There might be different systems available in individual markets. We can have and can expect new developments and startups to enter the market. It is still important to know how to handle the system. Potentially over time, carb counting might become less relevant, and maybe we can work with small, middle and large size meals because still the skill of carb counting is maybe difficult. We have seen it from all different age groups that people benefit from young age until elderly populations, also people living with type 2 diabetes. and the selection of the system and the components should be according to user needs and preferences. Thank you very much. You were the first to do exercise. Very good.
Thank you, Dr. Julia. This is a sort of exercise Dr. Makkar has introduced after each talk. We'll have a question at the end of the session. Yeah. Next we have Dr. Bansi Sabu.
So, Dr. Bansi, he needs no introduction, but since it's customary, I'd like to introduce him. He's got several awards to his credit. Most impactful healthcare leader by World Health and Wellness Congress, and several other awards. He's got several publications, and he's the managing editor for Sadiko's International Textbook of Diabetes and an advisory board member for JAPI as well as the IDMR. So Dr. Bansi, over to you.
Thank you. Thank you, Dr. Meenaben, for giving me, four kind words of introduction. Thank you, Dr. Makkar, for giving me this opportunity. What I am going to talk, the standard of care for type 1 diabetes in 2025 and beyond. And primarily I am talking more from Indian perspective. As we are celebrating our 75 years of International Diabetic Federation with more than 50 years of RSSDI. And in India also we are having insulin available since last almost 100 years. In 1923, almost same time insulin was given in an Indian patient too. I have no financial disclosure except I am a technical committee member of Diabetes Task Force under Department of Health, Government of India. What is the goal of type 1 diabetes management? I am sure all of us will agree that they should achieve a near normal blood glucose level in A1C. We should not have ketoacidosis or hypoglycemia for these patients. They should have a highest quality of life compatible with daily demands of diabetes management. And in children, they should achieve normal growth, physical development and psychological maturation. This is what we want for all our type 1 diabetic patients. And we have to have a realistic goal which should be individual circumstances along with love and care. Now, goal for every insulin regime, it should mimic very physiological, healthy pancreas. That's in breakfast, it should increase lunch, dinner, snack, as per their carbohydrate intake, how much they take, accordingly insulin should be given to them. We all know about the DCCT trial, 40 years back, published, showing that trying to achieve a tighter glycemic control will reduce complication, but at the same time it will increase the risk of complication. But even after so many years, this is truth. 90% of our type 1 diabetes are having A1C of more than 8. And this is, I am telling you, average A1C. Some of the patients may be at tertiary care center, maybe at the best of the best hands, they may achieve less than 8, but this is what the truth is. Still, they get diabetic ketoacidosis, 1/3 of them, some of the centers, some centers even 10%. They get admission for hypoglycemia, and we are far from meeting our glycemic goal. DK and hypoglycemia is still very common despite many advances, and metrics are not improving. We have CDIC, we started changing diabetes in children, Life for Child, more than 734 children who are part of this group, but still we are not able to achieve. Even then we are giving them free insulin, glucose meter, consultation, HbA1c every 3 months, doing a dedicated clinic for them, but still not able to achieve a tight glycemic control, or many of them they develop a lot of complication. Because diabetes management is not just that 15 minutes of consultation which we are doing. For a person with type 1 diabetes, actually management is other than that hospital or clinic. They have to take care of their glucose at home, in school, in society, with a broad range of activities. Every time they have to check their sugar, they have to calculate their carbohydrate, they have to take the accordingly insulin also, balancing the regime, physical activity, not to go in hypo, at the same time not hyperglycemia. They need support all the time from family, from school, from peers, society. And the problem is there is a very low level of awareness seen amongst patients and society and even everyone, including doctors also. Many times doctors feel that it is not possible to achieve a good control for these patients. And this is the reason, this is in 2022, which is published paper, Type 1 Diabetes Index, showing that a person who develops type 1 in our country below the age of year 10 Actually, he is having a normal, a good quality of life around 18.7 years. This is the median age for a type 1 who develops diabetes below the age of 10 in India. This is published data from 2022, and nothing more is changed in last 2 or 3 years. And average life after that, he either have lot of complication or he or she may not survive. Why it is happening? One of them is the type 1, they normally develop complication not in first 10 years, maybe in 10 to 15 or 15 to 20 years. So most of the pediatrician or those who are seeing them first time, not very intensively controlling their sugar, because they never see in their lifetime a type 1 dying of any complication. They may see only a child with uncontrolled diabetes or sometimes with some diabetic ketoacidosis or some hypoglycemia, and that's the reason they are never intensively controlling. Even we know that DCCT trial had shown, the Accd data had shown that a long-term tight glycemic control is going to give them less and less complication throughout the lifetime. So type 1 diabetes is actually a dangerous condition. It's a serious type of disease. It's not simply what type 2 diabetes, it steals years of healthy life, and that's very, very important to understand, because many times even the senior doctors or primary care physicians, they are not understanding it, and they just write it simply that is in 5-minute consultation or writing a medication is not sufficient for these people. If they develop type 1 diabetes, on average they will lose their 45 years of those healthy years. Managing type 1 diabetes in last 35 years or 40 years, all of us have read, this is the basic treatment regime, which is nothing is in change in last 30 years. It is the basal bolus, self-monitoring, education and regular follow-up. These 4 things, I am sure all of us, we know that it's a very, very basic basal bolus therapy, self-monitoring, diabetic education and regular follow-up, but still it is not been done. Averagely in India, patients are taking around 2 to 4 injections per day. If they are on basal bolus, maybe on 4 injections a day, or some of them are on premix, which should not be used, they may be taking 2 injections. But this is what the average, if your person or patient is taking only 2 to 4 injections in a day, or checking the sugar between 2 to 4, this is the average A1C of them, 8.9 plus minus 1.6. It means they will never able to achieve HbA1c of less than 7. This is what the average has been done. This paper is from Germany. If we do the similar paper in India, probably this 8.9 will become 9.5 plus minus 2. So this is what the average. So if you want really a good control, minimum 5 to 7 times in a day the sugar to be checked. Every time there has to be a bolus injection. Carbohydrate has to be counted, so insulin carb ratio is to be done accordingly, and correction dose is to be taken. Then and then probably we may achieve HbA1c somewhere between 7.8 plus minus 1.2. So some of your patients may achieve less than 7, many of your patients may be around 7.5, which is most of Indian patients who are on basal bolus therapy are not able to achieve. There are a lot of disparities in quality of healthcare, access to drugs and technology. It does not mean that someone is in a big city or going to a tertiary care hospital will able to get the best of the best quality or healthcare, even though may have access to drugs and technology, but the doctor who is treating may not be aware or he may not be giving them best technology to these patients. That may be the reason. So there is a lot of disparity. You may find some people who are achieving a very tight glycemic control because they are going to a person or from where they are getting the access to the drugs or technology. So the access to the doctor is also very, very important. Where we are going, if you just check the self-monitoring of blood glucose for your type 1 diabetes, many of our patients who are checking their 4 times in a day, you will find their sugars are fine, relatively okay if they are checking their sugar 4 times a day, and 3 times a day, if it is normal, we will consider everything is fine and will be happy. But if you do the continuous glucose monitoring, I think that's a minimum technology which is now introduced in India last 10 years. Now we have around 10 companies in India. It should be a continuous glucose monitoring, should be a standard of care for most of your type 1 diabetic patients if they can afford. If you put them on continuous glucose monitoring, you will find that SMBG alone is not enough. Actually, out of 4 reports, which 3 of them are showing normal, when you do the continuous glucose monitoring, you will be finding that person is actually developing post-meal hyperglycemia, 2-time hypoglycemia, midnight hypoglycemia. So a continuous glucose monitoring should be a standard of care for a person who is insulin deficient or who is taking insulin, or preferably for all type 1 diabetic patients. Do we have evidence? Yes, we have evidence the utility of continuous glucose monitoring. The same data which is in 1983 of DCCT trial had shown there is a from mean A1C from 9 to 7.2. To achieve that, there were 62 per 100 patients here were getting hypoglycemia. Putting them on a continuous glucose monitoring, you can see that significant risk reduction of hypoglycemia from 62 to 20. The mean A1C from 9, it was 7.6, and they could achieve around 7.1. So relatively very well controlled diabetes with a continuous glucose monitoring with still less risk of hypoglycemia. On this, in 2017, there was a consensus with a international consensus of using the continuous glucose monitoring. I was part of this consensus, and after this consensus, it has been accepted by almost all guidelines across the world. And UK was the first country to started using continuous glucose monitoring for all the type 1 and all insulin deficient patients and all those who are on insulin. And what they have done, they have started giving continuous glucose monitoring, and that had become standard of care by NHS, and then it was followed up in US, in Canada, in Australia, in many of the developed countries, and it had become a part of routine care for all type 1 diabetic patients. If someone is using continuous glucose monitoring, then should we chase the HbA1c or should we monitor them through HbA1c? No. If you are using continuously glucose monitoring, then probably a different monitoring system should be there. That is what time in range. It means now 70% of the time you should be in the range of 70 to 180 instead of changing HbA1c, which is a retrospective data to show that what was your sugar control. So if you are using continuous glucose monitoring, so this was in 2019, again I was part of it, and it has been accepted the time in range a monitoring that should be considered for all type 1 who are using continuous glucose monitoring, and all those who are using continuous glucose monitoring, and more than 70% of the time they should be in time in range. But when we do continuous glucose monitoring, particularly in type 1, sometimes we find that they may have two different sugar report continuously, maybe on one day or other day it may be completely different, because there are more than 50 factors which are responsible for this glucose variability. So it's not just the carb intake, it is not just the food which is responsible for their increase or decrease sugar. Sometimes the type 1 have multiple fluctuation, and this is very important. This is the data which I am trying to show you. Even the middle of the night, it is from 12 to 7 o'clock, you can see day 1, the person is having sugar around 92 or 95, the other day the sugar is 180. So now, even if you put this patient on a continuous glucose monitoring, even person is educated, self-monitoring, doing multiple times monitoring, taking multiple time insulin shot, still he will not able to control, because both the days, 2 days of a same person with a similar lifestyle, on both the days, still the sugar variation is very, very high. So continuous glucose monitoring alone is not enough, and this is what after 2018 in NHS everyone was given continuous glucose monitoring, but still only 30% of the patient could achieve tight glycemic control or their A1C less than 7 or time in range more than 70% of the time. So they mean they need something more. They need a pump therapy which is having a flexibility of using different basal. On every day, you can also differently use it, and multiple bolus can be given. As I had shown you the data that more than 5 times, 6 times, 7 times, if someone has to take the bolus, then this become very convenient tool. And they can also use the pump therapy for changing the basal also differently. But again, these are the two different devices, which is one is continuously monitoring and other device is continuously subcutaneous insulin infusion pump, which is available since last 25 years. But when 2017 the CGM guideline had come, then there is a time in range guideline it came, then sensor augmented pump had become a standard of care, and this is what in ADA after 2019 in their diabetes care, they have written that this is what the standard of care for all type 1, they should be on insulin pump or they should be on a sensor augmented insulin pump. But do we have data? Yes, it is in 2016 a published data which was talking that if a patient with a mean HbA1c of 7.7 put on a sensor augmented insulin pump therapy in 2016, you can see in the pivotal trial the risk of hypoglycemia became 0, and patients were achieving mean A1C from 7.7 to 6.9. So you can see the difference, how they could achieve a tight glycemic control even without getting hypoglycemia. And that's the reason in 2019 in ADA had put in their guideline also that should be the standard of care. So what should be the treatment goal in 2025? As I written in the first slide, that they should not develop decay and hypoglycemia. They should achieve a time in range more than 70% of the time, and they should have a normal growth also, physiological, psychological and sexually. So that if we use any variety of therapy for a type 1 diabetes, whether it's a multiple daily insulin injection or whether it is a pump therapy, if it is not sensor augmented therapy, if it is not advanced hybrid closed loop system, then probably they will not able to achieve time in range more than 70% of the time. And what previous speaker Dr. Julia had talked about all about the AID, so I will not be talking more about the AID, but AID is a auto basal correction for the bolus dose. As sugar increases, it can increase and the decrease of the basal insulin from pump itself. That's what automated insulin delivery device which is available to us. We had shown this paper with 219 patients with a time in range for more than 75% of the time with the hypoglycemia not less than 5%, less than 1%. So it means they can achieve tight glycemic control without getting hypoglycemia. This is the Indian data, and the best part is the consistency. It means not just 14 days. You can see for year round, every time the time in range more than 75% or 70% without getting any hypoglycemia. So the consistency of the report, that's also very important. So it's not that over a period of time, now they are losing for their time in range. So there was a consensus after the AID system that ADA, AS and SPAD, they completely changed their statement. They were having that yes, in a position statement A, everyone should use, but now what they are, AID should be offered, strongly recommended, and it should be offered to everyone. This is what the SPAD guideline is saying. So we have written a paper, Call to Action, that is standard of care for glycemic management in youth and adults with type 1 diabetes should be AID system, and this is what in 2025 I published along with all those experts. And what we are writing, it must be given a choice. It does not mean someone is not affording, you write it, document it as a medical record. That yes, we have explained the patient as a clinician, as a diabetologist, a person had come, patient is not affording, is not willing to take, but we had explained that should be given a choice to all type 1 diabetic patients. And long term, do we have the, everyone will ask what is the cost? Cost is 6 lakhs rupees. Will it be a cost effective? Yes, we have done a one paper modeling to estimate the impact of this AID on a long-term diabetes complication. So a person with a type 1 diabetes for a long term, you just see for another 30 or 40 years, the chances of developing all complication and dying, he will die because of complication, are much more higher. The cost of those things are more higher in compared to the therapy of AID or the consumer. What is the future? Future is restoring the insulin production, cell source, which is stem cell derived therapy, immune protection, you can protect or someone to prevent diabetic patients. Also, Lentidra is already US FDA approved. There are a lot of trials which are going on. Vertex is one company, but there are many more companies who are coming out with the cell replacement therapy. We can detect someone for early and we can prevent diabetes also. At present, we don't have any program in India, not possible, but some of the countries in the world have early detection program also. There are 7 disease modifying therapy are part of it as a preserving C-peptide. Teplizumab is already available, US FDA approved, and one more drug which is in phase 2 trial is going on for for glucose control for type 1 diabetes too. So the clinical care for type 1 is changing. At present, the standard of care is definitely AID if one can afford. Tomorrow may be a time that we will be early detecting them and giving them a disease modifying therapy for preventing or delaying type 1 diabetes therapy, or maybe down the line in 5 years or 10 years, we will be replacing them with the cell replacement that will be cure for type 1 diabetes patients. DCCT still remain a critical in shaping type 1 diabetes care, and India has a potential to become a global model because we have both varieties of patients. Some of our patients can afford for AID, and some of the patients to whom we have to provide everything for managing type 1 diabetes in resort-constrained setting. We have dedicated meeting for type 1. This is what on 6th and 7th December in 2025. And I welcome all of you for a Diabetes India, World Congress of Diabetes India, which is on 12th to 15th Feb at Hyderabad. Thank you once again. Thank you, Dr. Makkar, for giving me an opportunity.
Thank you, Dr. Banshi Saboo, for an excellent deliberation on type 1 diabetes. Very illuminating. I'm sure there are so many things to learn, so many things to do for the better care of the disease. Dr. Banshi, if you can join for that.
Thank you.
There is slight change in the program. Next talk will be by Dr. Julia. Dr. Katrina will be her talk is postponed to tomorrow, as Dr. Julia is leaving tonight. So Dr. Julia will be speaking on handling of diabetic kidney disease. Over to Dr. Julia.
Thank you so much, and thanks again for your flexibility. So we are now looking into diabetic kidney disease. And first of all, I'd like to highlight that, of course, there might be different angles to look at a patient or a person living with diabetes. So for us as diabetologists, it might be a person living with diabetes, but of course there can be other diseases there as well, or predominantly, and so we should still have the holistic picture. Just asking into the audience, and please raise your hands, who is diabetologist here in the room or person working mostly with diabetes? Do we have a lot of cardiologists here as well?
Doctor, we can't hear you.
Huh? You can't hear me?
Yeah.
Okay, sorry for that. Cardiologists also in the room? Over there I saw some raised hands, but I don't know if they just did not... Oh, sure. Do we have other professions than diabetologists? So the diabetologists already raised their hand. Anyone who is working cardiology, nephrology, mostly? No one. So, okay, so we can be very frank amongst each others, because I think in the end all of that goes together in the hands of the diabetologists, because cardiologists, at least in my country, prefer to work with the gadgets, to implant the stents, to implant all the nice and shiny devices, and we are kind of the bottom line to fight all the diseases together in the hands of the diabetologist. But of course it's on the one hand side global burden, and it's not just the kidney, but I would like to call it the cardiorenal metabolic syndrome. And in the global perspective, we do have now really astonishing numbers that 1 in 10 individuals have diabetes. Every 50 minutes, one person dies of the consequences from diabetes, in most cases cardiovascular disease. And diabetes is still the leading cause for developing kidney disease. Individuals with type 2 diabetes, in that sense, are cardiometabolic renal patients. So they are not one or the other, but really a holistic picture that we also need to take care of. And now take a close look. How many animals do you see here? Take guesstimates of you. How many do you see? Not even close to that. We see a total number of 12. I counted again. And of course, we only see what we are familiar with. So if you don't screen for kidney disease, of course, you can't see that the person has kidney disease. So it's really important to have a close look, to not overlook something that might be there, but we don't have the focus on. So just to really stress, there can be other causes of kidney disease which are not related to the diabetes. So if you have a person having diabetes and kidney disease, does not naturally mean all of them have diabetic kidney disease. So if it's a type 1 diabetes, short duration, well controlled, rapidly declining eGFR, rapidly or very high UACR or urine protein creatinine levels, or no retinopathy in a person with type 1 diabetes, think of it, there can be also other causes of kidney disease, and these patients should be additionally seen by an expert, by a nephrologist. What can cause the chronic kidney disease, and we have discussed about that up front, uncontrolled diabetes, not well managed for a long time, so really it is in our hands to look at well-controlled diabetes. But type 2 diabetes not only needs the focus on diabetes management, we also need to look into cardiovascular disease to really hit hard, hit early to well manage, and also hitting hard, hitting early will help us to avoid the progression or development of chronic kidney disease in that population. When it comes to chronic kidney disease, we do see that there is also an approach over various stages, and in many cases there is a silent progression over the years. So we do in many cases see renal functional reserve, and only at a certain point in time we do see that the EGFR declines, that the urine albumin excretion changes, and people have the risk of becoming dependent on dialysis. So what we also can see is that cardiovascular events might be an early warning signal for people who are at risk to develop chronic kidney disease, because the risk of diabetes in people with cardiovascular disease is tenfold higher in people with early stages of chronic kidney disease compared to people who do not have chronic kidney disease. So whenever you have a cardiovascular event and not already known chronic kidney disease, really look at improve the control of all the risk factors early to avoid a progression. Chronic kidney disease still is a fatal disease. If we have a look here at the numbers, it's really close to cancer mortality, and we should really see for a good cure upfront so that we avoid the progression to dialysis, because once dialysis is there, it usually does not take long until people actually die, a bit more pronounced in males compared to females. So the early intervention is crucial to really gain dialysis-free years and also gain in survival. And the less you intervene, and especially if you don't intervene, then you have dialysis earlier and also earlier death to expect in that population. And I've discussed about that before, and that's one of the diseases where also good glycemic control is important, because here we can avoid microvascular complications. But of course, the better drug we use, the more holistic approach we take, the better the outcome for the person living with type 2 diabetes. So we require a multifactorial approach. So it is on the one hand side glycemic management, but also blood pressure management, lipid management, and also using agents with cardiovascular and kidney benefits. And below all, kind of the founding base of everything is lifestyle modification and diabetes education. So again, find the stairs, use the stairs, exercise, and maybe tomorrow we have a doubling in the people who use the stairs here. So the important aspect here is prevention, because once chronic kidney disease is here, of course, the harder it is to get a good outcome. What are the risk factors? We have male gender as a risk factor. We do have chronic inflammation. We do have older age. We do have also, again, obesity, hypertension, and smoking. So all of that are modifiable risk factors that we should address and discuss about. So for example, if you have a smoker with you in the outpatient clinic, discuss about smoking, discuss that smoking cessation has a benefit also on the kidney disease. Again, use the person-centered approach to meet all the care goals, to really have that cycle to avoid complications, to improve and optimize quality of life, and really regularly check for comorbidities, for laboratory values, and in case of progression, go for hitting the goals hard and early. And if we look again, how long can we ourselves treat people with chronic kidney disease? So up to the level 3 here, which is indicated in the light red, it can be seen by diabetologists. And if we see the kidney disease worsening over time, we should refer at least once to a nephrologist to see and help with potential therapy and maybe even further diagnosis. what interventions can help us to reduce albuminuria. So we have, of course, blood glucose management at the center, but also blood glucose control, treatment with ACE inhibitors or ARBs, smoking cessation, weight normalization, changing the eating pattern. So here, high protein intake might be not beneficial. And what recent findings show us, the treatment with SGLT2 inhibitors, MRAs, and GLP-1 receptor agonists. So when we look into the American Diabetes Association recommendations, again from 2025, foundation, healthy lifestyle, upfront and for all, then first-line drug therapy, SGLT2 inhibitors, metformin until eGFR is above 30 still, and then intensify to GLP-1 receptor agonist or non-steroidal MRA and other glucose-lowering drugs if needed. Go for hypertension, RAS inhibitors at maximum tolerated dose, then optimize if you don't achieve and go for steroidal MRA again. And for the lipids also, we need to meet the goals, start the statin early, use potential other agents if goals are not met, and use also antiplatelet agents in people who have cardiovascular disease. So the lipid goals, where should we go? So the higher the risk, the lower the goal. So we should really have low goals in mind when we want to avoid chronic kidney disease. So we should really go for the 55 milligrams per deciliter pathway. And the first trial for a diabetes drug that also looked into, for a GLP-1 receptor agonist, sorry, that looked into the outcomes of chronic kidney disease and type 2 diabetes was the FLOW trial, looking into semaglutide and people with chronic kidney disease for a period of up to 5 years, event-driven. And what they included a population with substantial type 2 diabetes burden, HbA1c above 7.5, 57% already had long-standing disease, and also high number of comorbidities such as MI, stroke, or chronic heart failure. And that was more or less the FLOW population, so the one at high risk of chronic kidney disease progression. What they saw that the semaglutide managed to have a 24% reduction of the composite endpoint, including kidney disease progression, cardiovascular disease, and kidney death in people with chronic kidney disease and type 2 diabetes. And so I think these are promising results for the new kids on the block to also help us with relevant comorbidities of diabetes. When we then shortly also look into the Fidelity trial, which is a pre-specified pooled analysis from Fidelio DKD1 and DKD2, and they looked into a composite of time to cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. They saw that there was a 23% reduced risk of CKD progression in the ones being exposed to finerenone compared to placebo. And also finerenone reduces the UACR between baseline and 4 months versus placebo by 32%. So side effects, what we have seen, no effect on HbA1c, no difference between acute kidney injury, not a big difference between systolic blood pressure, and also no effect on gynecomastia that could be a side effect. So what should we do to manage chronic kidney disease? And it's potentially a lifelong treatment that we need to do. And when we look what we had in the 1980s to what we have now, so we should really look into anti-hypertension treatment, best possible treatment using ARBs and ACE inhibitors, using SGLT2 inhibitors, non-steroidal MRIs, and also GLP-1 receptor agonists, specifically semaglutide, in this high-risk population. With that, I would like to conclude and thank you very much for your attention.
Thank you, Dr. Julia. Next we have Professor Andrea. He'll be speaking on can we use GLP-1 RAs and SGLT2 inhibitors in type 1 diabetes. Interesting topic. Over to Dr. Andrea, please.
Okay, thank you again for the invitation. If you want, I can just answer, yes, we can use and finish the talk right with the answer. But I will try to give you some reasons for this answer. Well, the first slide I will show actually shocked me a little bit, was published in the New England Journal of Medicine, so it's not my Italian small journal, it's the New England, with semaglutide in early type 1 diabetes. But if you read it, you really understand that something is changing and the world is changing. Why is that? Because we know that most type 1 diabetic patients are lean, and because they lose weight, they lack insulin, but this is not completely true anymore. Sometimes type 1 diabetic patients are overweight or even obese, and this obesity determines some kind of insulin resistance. And remember that diabetes appears when insulin is not sufficient to compare with the insulin resistance. So in this, it was not a trial, it was just some experience. They suggest that if the patient with type 1 diabetes is overweight, you might try to treat them with the GLP-1 receptor agonist to remove overweight, to remove obesity, and sometimes to recover a little bit of insulin, which is sufficient to at least introduce our type 1 diabetic patients to insulin treatment later on. So they were really able to eliminate most of their insulin, at least for a short period of time. There have been not so many trials, but some experience with trials using GLP-1 receptor agonists in patients with type 1 diabetes. Here is liraglutide on HbA1c and body weight. Clearly, GLP-1 receptor agonists cannot stimulate insulin secretion in type 1 diabetes because there is no more insulin, especially after years from diagnosis. But you can reduce the body weight, try to treat obesity, and eventually try to reduce the insulin dose in these patients. This is liraglutide. This is another trial, the adjunct trial. You will see that again was easier to reach lower HbA1c, adding liraglutide at different doses. And on the right part of the slide, you will see that there is also a reduction in the insulin dose, which might be somehow useful for patients with type 1 diabetes. So, as type 1 diabetes now also occurs in obese patients, GLP-1 could delay insulin dependence in these patients. And there is also some observational retrospective studies suggesting that GLP-1 receptor agonists, the dual agonist tirzepatide, could reduce obesity and insulin dosage, and I know that there are trials that are going with tirzepatide in patients with type 1 diabetes, again, because they often are obese or become obese for their insulin. So the additional GLP-1 receptor agonist or whatever might be useful for them. Now, the most difficult part is what about the SGLT2? In Europe has been a strange story, and we'll try to tell you about. There have been trials with many of these SGLT2. This is with dapagliflozin, and you will see a reduction of HbA1c with the dapagliflozin, either 5 or 10 milligrams. But the problem is that with the use of SGLT2 inhibitors is the fact that there is an increased risk of ketoacidosis, okay? This is mostly due to several reasons, including the fact that the patients are not educated to adjust their insulin dosage with the use of the SGLT2. The same is true for empagliflozin. Here, following the EMA rules, they also tried to use an EMPA dose of just 2.5, which is 1/10 of the maximal dose of 25 milligrams, to observe whether the reduction in the dose of the empagliflozin was able again to reduce, you will see the green line, to reduce the HbA1c better than the placebo, but still you will see that even if the number of episodes of ketoacidosis is lower, still the risk of ketoacidosis is there. So it's something that we must be aware of. So actually in Europe, dapagliflozin was really approved for treatment with patients with type 1 diabetes. And this determined the fact that dapagliflozin had a sort of alert telling that with dapagliflozin there is a risk of ketoacidosis. Okay? This was not true with empagliflozin or canagliflozin. So because of that, of this difference, which was against dapagliflozin, the risk of ketoacidosis, which was just for type 1 diabetes, AstraZeneca, the producer of dapagliflozin, decided to retire the permission of prescribing dapagliflozin in patients with type 1 diabetes. I still use it, but I'm not allowed to do it. And now I'm trying to explain why I still use it. Well, first is we need to understand what kind of patient we have in front. This is the risk for ketoacidosis. From the left side, you will see different bars according to age. Certainly the risk of ketoacidosis is higher with the lower ages, so probably we might use them with the higher ages, in patients with type 1 diabetes, where the risk of ketoacidosis is lower. And another important point is the mean HbA1c, meaning that with lower HbA1c, probably the patients with type 1 diabetes have higher education on diabetes, and they know how to handle their insulin use, and certainly for patients who have HbA1c with 9 or higher, they don't know anything about their treatment of diabetes, so the problem is not SGLT2. Further, there are machines coming us, measuring ketones continuously, just like they are measuring glucose, so it's something that we can really measure very easily in the future. So use SGLT2 in patients at low risk for DKA. Further, another important point is that this is another trial done with sotagliflozin. We don't have in Europe, but I also participate in this trial. And the difference in this trial was that patients were, let's say, optimize their HbA1c before entering the trial, giving some more education to their insulin dosage in order to really see the difference with lower HbA1c, trying to reach lower targets of HbA1c. And you will see that actually targets were very low, but the most important point is that the risk of hypoglycemia was reduced. This is a sort of complicated slide. You will see the HbA1c here. So the lower is the HbA1c, the higher is the risk of having hypoglycemia below 70 or below 55. Now, adding sotagliflozin, and I think the same is true for any SGLT2, what we obtained was a reduction of the episodes of hypoglycemia. You will see that, for example, the patient having 7 of HbA1c, there are much less episodes of hypoglycemia if they are using an SGLT2 inhibitor. So rather than treating diabetes, because type 1 diabetes needs just insulin for treating diabetes, remember that these drugs are able to they stop working when glucose concentration goes down. And try to represent this, a patient with type 1 diabetes, we have remember, for example, in hyperglycemia, euglycemia, and hypoglycemia, remember the SGLT2 work depending on the glucose concentration, meaning that the glucose concentration is high, more glucose is lost in urines, glucose concentration is low, less glucose is lost in urines. So when the patient is going to hypoglycemia, there is no effect on SGLT2. In type 1 diabetes, you inject insulin, and when glucose goes down, really the SGLT2 stop working. So you have a drug, the only drug that stops working when hypoglycemia is coming. And that's the reason why there is a reduction in hypoglycemia episodes. Are there any other advantages? I think this is the most important, because remember that the patient with type 1 diabetes, we already heard about that, there is an increased risk of chronic kidney disease for many reasons, higher HbA1c, longer history of diabetes, and SGLT2 are able to reduce, at least in this trial, the urine albumin creatinine ratio, so to reduce the albuminuria. And as we know for type 2 diabetes, it's also true for type 1. This is a sort of comparison. It's a real life. It's another trial between GLP-1 receptor agonists and SGLT2 in patients with type 1 diabetes in the UK, meaning that in the UK and also in Italy there are patients, there are doctors who are treating their patients with type 1 diabetes with these drugs. And certainly there is an increase of DKA with the use of SGLT2 as compared with GLP-1. There is an increased pyelonephritis because of the urinary tract infection. No other major risk factors, but what is important is there is a reduction in hospitalizations, there is a reduction in heart failure, and what is more important, there is a reduction in chronic kidney disease. So really we can prevent heart failure, we can prevent chronic kidney disease in patients with type 1 diabetes just using a drug which has been approved for type 1 diabetes as well, at least in Europe. So really SGLT2 already have and will have indication for heart failure and prevention of chronic kidney disease, even in patients without diabetes. Okay, we can use them for heart failure, we can use them for chronic kidney disease. GLP-1 are indicated in prevention for overweight patients even without diabetes and prevention of chronic kidney disease. We've seen the slides before. Other specialists can prescribe these drugs, can prescribe the SGLT2 for heart failure or chronic kidney disease, and the same is true for GLP-1 receptor agonists. And I think that this is still a diabetes drug. And so do we really want to say that we are the ones who are not able to prevent an event of DKA in our patient with type 1 diabetes? I think that the answer is no. We need to prevent DKA, we need to prevent chronic kidney disease, heart failure, and treat our patients also using SGLT2 inhibitors in type 1 diabetes. Thank you.
Thank you, Professor Andrea, for the wonderful discussion. So now we'll open the floor for question and answer.
Request the speakers to join us.
Yeah.
So may we request Dr. Bansi Sabu, Dr. Julia, Dr. Katerina, and Dr. Andrea to be,
Yeah, no verbal questions. We know that. Unka naam kya hai? Sit. You have place? Uska naam kya hai? Uska naam kya hai?
actually you all sit here.
Sit. So I'll just ask. I've read. Yeah. Okay. So I think we'll start with you. So there's a question from the audience on kidney disease. You spoke on chronic kidney disease and type 1 diabetes. So do you agree that you should start SGLT2 inhibitor in type 1 diabetic patients with microproteinuria?
Yes, so I personally also would go down that line in type 1 diabetes. I interestingly had a discussion with our nephrologist, and she was, no, never give SGLT2 inhibitor in type 1 diabetes, but I think the data that we have in type 2 diabetes also will translate into type 1 diabetes, and we are withholding a very good drug in type 1 diabetes if we don't start it. I would be only a bit cautious about two things, that's a person very well instructed about what they're doing, so that they should not reduce their insulin in case their glucose goes down, but then maybe pause the SGLT2 inhibitor. And number two, in case of the person has an infection, again, increase insulin dose and pause SGLT2 inhibitor, because the cases of ketoacidosis that we had seen under SGLT2 inhibitor in my center and also in Austria were not really the ones with SGLT2 inhibitor in type 1 diabetes, but more in type 2 diabetes where no one has told them how to properly handle.
So, two comments rather. One is that still SGLT2 not approved for type 1, number one. And the second one is if they are on AID, if we put them on SGLT2, automatically the insulin requirement will go down because AID will not put the further bolus. The risk will increase for diabetic ketoacidosis. And my question is why we are not using Finridone, even that is not approved, but in India we use off-label for type 1 diabetes, which is easily to be given in type 1 diabetes, except that hyperkalemia may be challenged. Now after the data of a combining using of SGLT2 along with Finridone, we do use for our patients for type 2 diabetes, diabetic kidney disease, why can't we use for type 1 diabetes also for Finridone?
So I guess for type 1 diabetes, we will go down the line in the near future. It's just not there yet. And the trial will give us the results. For type 1 on AID, similar as on basal bolus therapy, the majority of kind of the insulin that we will spare will be the mealtime insulin and not so much the basal requirements on the AID. So I have a lot of people who are doing excellent on AID and even better on AID with SGLT2. So I would not see that as a risk. And now even that we have potentially the sensors, the ketone sensors knocking on our doors, potentially in that scenario they might be even more beneficial.
How much is the approximate reduction in blood glucose percentage-wise once you start SGLT2 inhibitors in type 1 diabetes who are well controlled?
So I can't say for HbA1c, I only see, for example, the ones who are struggling with high insulin doses and have like a time in range of 70%, go up to a time in range of to 75% on AID. So, and when it comes to the meals, I would think it's about 20-30 milligrams that we can achieve. Depends a bit on I guess the kidney function as well. If in type 1 it should be, young type 1 should be stable and good, so maybe even more to be expected. So it really nicely caps the peaks that we see. But I don't, of course, can't say what's the effect of the SGLT2 inhibitor versus the insulin that's coming from the AID. But that would be my guesstimate when I translate it from insulin doses to the glucose reduction.
Thank you.
So my question to you, sir, is that you said GLP-1 RA in type 1s. So when and would you like to do the C-peptide, and those who have residual C-peptide, would you like to give GLP-1 RA? Or would you give it to, or anything about antibodies, people who are antibody positive type 1s versus antibody negative type 1s? Is there a difference?
That's a very interesting question. As I said at the beginning, now the classic type 1 diabetic patient is not just lean or whatever, okay? Mostly it's the combination of overweight. Let's go back to the definition of diabetes in general, at least except for the autoimmunity. Diabetes, hyperglycemia appears when insulin is not sufficient. Either you are normal in terms of insulin sensitivity, and so really there is almost a complete lack of insulin, or you have some kind of insulin resistance. In this case, you might have need of higher insulin concentration. So treating, at least at the beginning, these patients while some insulin resistance, because they have obesity, might reduce their insulin requirements, so the low insulin they have might become sufficient to treat their diabetes. Certainly autoimmunity will keep on, so they will become completely insulin dependent, but still this is much better for them if they are overweight. And the second point is that just like SGLT2, it's ridiculous that we not treat patients with type 1 diabetes and obesity. If they are obese, they must be treated like any other obese patient. Why not? I mean, I don't understand the reason. So at least it's for some strange European rules because they're not tested, they're not approved, but still, I used it and I don't think there are any problems at all. And going back to another question, a patient with type 1 diabetes, how much is the glucose lowering in terms of chronic kidney disease? Chronic kidney disease might be albuminuria, okay, but also might be reduction in GFR. If the GFR is low, the glucose which is lost is almost nothing. Okay, so really the effect in terms of glucose lowering is nothing, but still the effect on kidney protection is there. So especially in patients with low GFR, higher than 20, I think it's mandatory to start SGLT2 inhibitors in type 1 diabetes patients.
There was a talk which was to happen, type 1 diabetes with obesity and insulin resistance. Probably these are patients who are also called double diabetes because they've been type 1 and now they have developed stigma of metabolic syndrome. Yes. So these are the candidates who are, these patients, type 1s with metabolic syndrome or obesity and insulin resistance, in your view, are candidates for GLP-1 RA as well as metformin and SGLT2 inhibitors?
I say absolutely yes, also because, I mean, we all have experience with type 1 diabetes. We know the tragedy, which means go for insulin 4 times a day. If you're able to reduce a little bit, this some kind of prolonging the honeymoon. Remember, the honeymoon is the period in which the patient starts learning how to use insulin. You just prolong the honeymoon. Sometimes you can even stop insulin, as I showed in my slide. I mean, those are American, probably very, I mean, really severe obesity might be there. It's not the situation, the same situation in Europe and I think also here, but still, it's something that can be done, especially if you expect that some insulin resistance is there.
Do we have some data of GLP-1, SGLT2 inhibitors in patients with LADA?
Yes.
Yeah, latent autoimmune diabetes of adult. So that could be one of the area where you still have good number of beta cells, still you are C-peptide 0.8, 0.9 sometimes.
Because it's a slowly progressive type 1.
They have get positive. And do we see any kind of recovery in them as far as C-peptide is concerned, or there may be conversion from LADA to frank type 1 diabetes might be delayed or something like this? Do you have some data on these lines?
Yes, there's been a trial in Italy not conducted by me, by Professor Paolo Pozzilli at another Roman university, which was a comparison between an SGLT2 and glargine, which I think is probably the best thing you should do with the LADA when hyperglycemia goes there. And there are no major differences. So at least it's better for the patient not to start insulin, so I would suggest to do it also in LADA. The only concern I have with LADA is that with the SGLT2, you're not really able to catch the moment in which insulin is not there anymore, and you cannot get just with the glucose concentration because, especially at the beginning, GFR is very high, meaning that SGLT2 are very efficient. They can normalize glucose, and sometimes the patient do not realize that they are completely lacking insulin and might really go in DKA. But just give some education. If you also give some insulin, there's no problem at all. Just give it.
Question to Dr. Banshi. Sir, what is the role of verapamil in the management of type 1 diabetes?
It's for prevention. So I had shown you the last one of the slide, the 7 different disease modifying therapy for prevention of type 1 diabetes progression. If we detect them at early by doing the autoantibodies, which is like a mass screening program, which is not possible probably in India. Maybe in next 10 years, I don't think there is a possibility of doing it. But definitely those kids who have type 1 diabetes and their first family member, if they are screened for it, and we can diagnose them at a stage 2 or 3A, then there are few immunotherapy which is going to prevent. At present, teplizumab is already approved, US FDA's approval. It delays for type 1 therapy. Verapamil had also shown. So these are the different, maybe in future there will be a time will come that different combination of these therapy will be used for preventing or delaying type 1 diabetes. At present, we don't have any clear-cut guideline that how they are going to delay. And at what stage you are picking up a type 1 diabetes, that will also decide that how much it can prevent or delay the type 1 diabetes.
I think due to the paucity of time, we'll wind up this session. A very big round of applause for all our speakers. Thank you so much. Thank you.
I would request Dr. Hanish to please pass over the mementos to the chairpersons outside at the podium. And now it's time for the quiz.
Thank you, ma'am, for the help. Third quiz. Already the paper is out in discussion. A different code again. Kindly register. We'll wait for 20 more seconds. Last 5 seconds. Dr. Nilesh, you want to participate? First question. Tough one. There was a slide, 2 slides here and there. You got it correct. Let's see the leaderboard. It gives really interesting name, huh? Dr. Centipede. Who is Dr. Centipede? May I know? Oh, there. So all the winners are coming from that end. I don't know what is the bias there, but all the winners are coming from that end. Moving to the next question. Be very quick. Easy one. Most have got it correct. Let us see the leaderboard. Dr. Centipede is maintaining the lead. Last one. This question was already out in the discussion. Most got it correct. Now see who is the winner. Interesting name, huh? Peelings. Who is Peelings, by the way? Again, coming from the very same end. Can you come over here, ma'am, again? Because you are already a winner, we will like to give it to the number 2 with your consent. You please come over first. Second is Ashley. Who is Ashley? Again from that end. I don't know what is going on at that end. A big round of applause for us because she has won it twice, not once. Ma'am, can we know what is your name? The real name. A big round of applause for her. Thank you.
Good evening, friends. To keep the ball rolling, let's move on to the next session of the day. For the next session, the chairpersons, I would like to request the chairpersons to please join on the stage. Dr. Divya Saxena, Dr. Nilesh Kapoor, and Dr. R.M. Chabra.
Good evening, everyone. So, it's indeed an honor and pleasure to have very distinguished speakers on this august platform. And I am happy to invite next Dr. David Strain, sir, for giving his seminal talk on CGM in non-diabetic persons, relevance and potential harms. Can we have his CV slide, please? So Dr. David Strain, sir, is a senior clinical lecturer at the University of Exeter Medical School with an expertise in microvascular structure and function. Clinically, he runs a community service for the older adults with diabetes and or cardiovascular diseases and works as an inpatient consultant. His main focus is the health of older adults with diabetes, ensuring the right patients get the right treatment. This includes research exploring the mechanism that some medications, specifically the SGLT2 inhibitors and GLP-1 analogs, give benefits for people with diabetes, heart diseases, and renal failure beyond their effect on sugar and blood pressure. So over to you, sir. Thank you very much.
Thank you very much, and sorry for you having to listen to me over again. So I'm here to be talking about something a little bit off-piece. It's the continuous glucose monitoring for the non-diabetic patient. And this is something that's taking more and more interest. These are now consumer products. Our patients go out and buy them for themselves. Many in our obesity clinic, I quite regularly get people coming to see me with their CGM reports. And it then becomes a problem is, what do we actually do with the results? So in doing this, I want to take a quick overview of where the utility of CGM is. Now, we've already heard from Prof. Andrea the use of a CGM for our patients. And we know this in type 1. Also, we're increasingly seeing it in type 2 diabetes, where it is of great significance. However, there are many other individuals who are using it. And there's many reasons why it is. Basically, what gets measured gets managed. If you cannot see something, you cannot do anything about it. If you don't know what's happening, how are you supposed to make things better? But of course, the problem there lies, how do you know what to do about it? At the end of the day, this is a new parameter. Looking at continuous glucose monitoring in people who are otherwise well, so what? So there's several places where I went through it, and these are the 4 key places where we are seeing a lot of it being used. And so I'm going to go through each of these in turn. Let's start with our diabetic cohort. Now, we know that HbA1c is a measure of an average over 3 months. We know that average doesn't give us all of the information we need, and where we're using insulin particularly, or other drugs which has time-dependent effects, then knowing the continuous glucose will give us a much better perspective of how to change those time variants. But then when we're using drugs like GLP-1s over a week, or SGLT2s, a daily treatment, whether we're looking at DPP-4s, even a weekly DPP-4, the reality is, does it matter what's happening on a day-to-day basis if the medication is acting over the entire week? But there are a few examples where it's very pertinent. And one of those is for our more mature adults. I use that term very carefully. I used to say for our elderly patients, and then as the hairline receded and the silver got more, they're just more mature these days. We don't call them old anymore. And one of the problems we have with our older adults is their hemoglobin lives a little bit longer. That's because they get reduced red cell turnover, they get lower levels of erythropoietin. They have multiple comorbidities that are draining on the things from outside. And so there's a lot of people over the age of 75 to 80 who are diagnosed with diabetes purely on the basis of their HbA1c. And we know from the natural history that they don't always develop the natural process of type 2 diabetes. And what we're starting to see is those numbers may be wrong. These are data from the Switch 2 trial. Now, you don't need to know anything about it. It's a historic study, one insulin versus another insulin. And the only thing I've done here is stratified people by age. We have the youngsters, the pediatric population, as I like to call it, those under the age of 65. Yes, as far as I'm concerned, everyone in the room is pediatric. We've then got the over 65s in blue. And you can see the HbA1c was the same. That's what we were treating to. That's what the aim of the study. However, in order to get the HbA1c the same, our older patients had to have an average of around 10 milligrams per deciliter lower sugar than the youngsters. That means if you see 2 patients, one age 55, the other age 75, with the same HbA1c, your older patient has about 10 milligrams per deciliter lower at any time point. What that means is the risk of hypo is substantially higher, that you are at risk of making them go lower. So for our older adults now who get a diagnostic HbA1c, but when we look at the overall profile, they don't typically look like a type 2 diabetic patient. We will routinely put a CGM monitor on them to find out, does this person really have diabetes? Can we predict what's going on? Because if the CGM looks pretty normal, then we don't need to intervene at all. There are several other conditions that have early signs of dysglycemia before they actually start to get it. And for these individuals, it is often worth putting a CGM device on to identify those who are at risk. We can identify postprandial hyperglycemia. We can identify those features of insulin resistance before they start to cause problems. And there are many cheap medications available. People with polycystic ovary syndrome, we know they benefit from metformin, but many other similar conditions would likely also benefit. Plus, if we see patterns, we can do something about those patterns. If we see regular peaks of hyperglycemia, maybe an SGLT2 inhibitor may be better for them. If we see an overall rise in their sugar, they may benefit from a DPP-4 inhibitor before they're diagnosed with diabetes that would slow their progression. The difficulty here is what is actually normal. You see, our normal range for HbA1c is very much based around the HbA1c that marks the inflection point towards retinopathy. What's the normal level for a continuous glucose monitor? What's the normal time in range? How many of us who don't have diabetes have worn a CGM so we would know what to expect? A lot of what we do when we're managing our patient is comparing it to what we've seen before, to patterns, to meetings like this. If there is no real knowledge of what normal CGM looks like, how do we then know what to do about it? Now, the next group are those who are at risk. The people living with obesity, the people who've got the strong family history, the people who we know we need to intervene with some sort of lifestyle intervention. Yes, Katerina, lifestyle intervention. Those that we need to do with a lifestyle intervention today to stop them becoming our patient tomorrow. And there is a very clear evidence base that suggests real-time knowledge of what's going on changes behavior. These data found out what happened if you give a continuous glucose monitor to people with a few standard tests. One day you'd say, take your meal, then go for a walk. Tomorrow, go for a walk and take your meal. Do you spot a difference? Eat a banana. Eat lots of extra rice. Eat different meals. Put them in a different order. Find out what happened. We very rapidly, the patient sees for themselves, exercise after meal is better for you than exercise before. That fruit at the start of the meal causes a spike in sugar. Fruit after carbohydrate doesn't cause that spike. Those sorts of different things. Now, we could tell them that, but they don't listen to us. When they see it for themselves, when their own glucose monitor sees, oh look, I've been for a walk and I've got a nice flat profile, then our patients are far more likely to pay attention. And this real-world tool to help counselling and health coaching is a really strong advocate to get our patients the positive reinforcement they need a long time before they see their inches disappearing from their waistline. Of course, one of the problems here is how do we know these devices are effective in people who don't have diabetes? They're all validated on people with diabetes, but we also know that people with diabetes have a different interstitial flow. Any nephrologist will tell you a diabetic patient with peritoneal dialysis will have a different movement of solutes across the peritoneal membrane than a non-diabetic patient. They get fast transporters versus low transporters. Interstitial fluid is exactly the same. How do we know the interstitial fluid that we're measuring with our Dexcom or our Freestyle Libre or whatever the device may be is actually telling us the truth? And remember, those things are designed with protocols, with AI, that predicts what the sugar is going to be based on what it's reading now. The interstitial fluid is what was happening 15 minutes ago. The AI will tell you what we think is happening now based on what was happening 15 minutes ago. But those AI databases were trained on people with diabetes. They were trained on those people who've got the fast solute transporters. Do we even know that the sugar that the CGM reads in a non-diabetic is accurate? The answer, quite simply, no. But then does it matter? If all you really want to do is say, if you go for a meal and then have your exercise, then you'll get a blunted response compared to if you get your exercise and then have your meal. Does that matter? Because they will still get the same learning, just the numbers may not be the same. The data suggests that CGM does not work as effectively in people without diabetes. We saw that during the pandemic when people were sticking them on because a spike in sugar was one of the first things that predicted severe COVID. Actually, it does not work effectively in people with diabetes, without diabetes. The reason it worked so effectively in the pandemic is the first thing that happened when COVID affected you is that you became a rapid transporter as your glycocalyx broke down. There's also ethical considerations. What is the effect of having a CGM monitor on somebody who doesn't have diabetes or, for that matter, the need? I put one on just for a laugh. We were doing it in one of our studies. I wanted to explain the patients what they were going to experience. I find myself swiping every 15 to 20 minutes, even 2 weeks later. Now, I was going in as a healthy control just so I could explain to my patients what to expect. Is this promotion of autonomy, or are we just generating a brand new thing for our patients to be worried about? How do we feel about recommending things that are completely off-label? We've just had a conversation about whether GLP-1s and SGLT2s should be used off-label with some concern. So yes, we've got good evidence for it, and we are still not sure about using it because there's no label. We have no evidence for this, and yet somehow we're not even considering the potential harm that could be done. There's also the practical implications. Hands up in this room, who has a spare hour a day to go through CGM for people who have got no indication to be on that CGM? If you have got a spare hour in the day, find the stairs, go for a walk. So the problem here is we have brand new technology. We know it is incredibly effective in type 1 diabetes. It is incredibly effective in type 2 diabetes. It is useful for diagnostic purposes in early disease. It's also useful for behavioral changes in people with type 2 diabetes. These devices are not validated in people without type 2 diabetes or type 1 diabetes. So we have to be very cautious as to how we interpret the results. Trends, however, within patient trends, they could be useful as a behavioral tool. But maybe what we're really doing is telling our patients, look, if you don't believe me, see for yourself. For those people, that could be of use. But only if you have time. We are promoting socioeconomic divides. Only people who can afford to go out and buy will have it. We don't know how to interpret the data. We don't have time to interpret the data. And never forget that giving people something else to worry about could be doing harm to their overall well-being. On that note, I'd say this is a potential tool for the future, but be careful. Thank you very much.
Thank you, David, for the excellent presentation. Now I invite the next speaker, Professor Enrique Gurkari, for the next session. Dr. Enrique, mentored by the Ralph D. Franco in 90s, and Enrique Gurkari is a currently associate professor of endocrinology and senior diabetologist. He is a head of the Center for the Endocrinology and Metabolic Disease of the IRCCS and the UCSC, the largest Italian hospital. He has a substantial track record as a principal investigator in the diabetes focused in the clinical trials and has acted as a senior advisor to the European Medicine Agency for the diabetes. Henry takes active part in the stakeholders dialogue within the diabetic scientific community, and he is a former member of the Executive Council of the Italian Diabetes Society and at present scientific director of the Diabetes Research Foundation. Over to Dr. Henry, please.
Thank you very much. I'm here again. I'll try to be faster also because Julia already showed some slides on weekly insulin, which I think is something really change our way of treating type 2 diabetes mostly, but it can be used also in type 1, will be used also in type 1 diabetes. Well, he collected all my history, and I think that we have to start again with the history of insulin treatment. I mean, I'm not that old, but I'm old enough to remember many of these passages. I actually graduated in the 80s before the DNA recombinant, but I still remember the monocomponent insulins, which really changed something in terms of immunity against the insulins. I also remember the faster analogs, and I think the true revolution in treating diabetes with insulin was the introduction in glargine. Those of you who are old enough will probably remember the revolution which happened with that, because we are really able to most of our patients to treat them for 24 hours in terms of basal insulin, while with other basal insulins was really difficult to have the 24-hour profile completely covered. So after glargine, also we got Detemir, which we close to be retired in the future, Degludec, which is even longer than glargine, then glargine 300, and we will see tomorrow that something is coming on the future, but now we'll speak a little bit about the weekly insulin. The first of the two, which is more advanced in terms of research, is Icodec. Icodec is just a regular insulin which has been modified in order to increase the stability, reduce the enzymatic degradation, and slow the receptor-mediated clearance, meaning that this kind of insulin, just because of how the protein is built, lasts more. But beyond that, it's also linked to a C20 icosane fatty acid, which means this molecule is linked to albumin, and this really determines a major difference in terms of the half-life of this insulin. So clearly the major differences between weekly insulin and the regular daily insulin is the number of the injections. With glargine 100, but it's the same for all the basal insulin, you have to give them at least once a day. But the advantages with this insulin is that you reach the steady state just after 2 or 3 days. With the Icodec and the other weekly insulin, you need 2 or 3 weeks before you can really reach a steady state. So it's not really something for trying to reach a faster glucose control, at least in our patients. For Icodec have been conducted many trials, 6 trials in generally speaking, 3 of them in insulin-naive type 2 diabetic patients, 2 of them in insulin-treated, already insulin-treated type 2 diabetic patients, just with basal insulin and just with basal bolus insulin, in which the basal insulin was switched. And the last trial, the ONWARD 6, has been conducted in patients with type 1 diabetes. I'm not showing all the results, otherwise I could stay here for hours, but just showing you the main results, trying to understand whether there are differences in terms of glucose control of these patients, at least during these trials. First is the ONWARDS one. Again, these were patients naive to insulin treatment, and you will see there is a sort of a slight better HbA1c with Icodec as compared with glargine. Again, this is a trial, it's not real life, but at least we can say that, I don't know whether it's really more efficient in terms of HbA1c, but at least you can reach higher, lower HbA1c, better results with Icodec, and this is the comparisons in terms of timing range. You see here the timing range is before, comparable between the two groups. Here you see on the right side the timing range is higher. Probably this is because it is due to a lower variability with this kind of insulin. This is the combination, triple CGM target, which is in better time in range, lower time above range, and lower time below range. Combined its 3 endpoints with Accd, they were able to reach better results. These are all trials together. Again, this is the comparison in terms of HbA1c, and you can notice that maybe it's a better result and it's better in insulin naive rather than in a combination. This is the basal bolus, there is no difference, and you can see that even the reduction in HbA1c in type 1 diabetes is not that good, even with the Diagrodec or the Icodec, meaning that probably the trials was not sufficiently designed in order to get this lower HbA1c. This is the composite endpoint of HbA1c without hypoglycemia. Again, the best results are conducted in insulin-naive patients rather than in the switch patients. And this is the hypoglycemia, probably is the reason for that, for the results that we've seen before, is that, again, in patients with basal initiation or just basal switch, you will see low hypoglycemia rate, which really increase while when the patients are treated with basal bolus, both in type 2 and in type 1 diabetes, and actually there is an increase in terms of hypoglycemia in patients with type 1 diabetes. Another insulin which is coming is Efsitora. I'm not sure it can be called really an insulin analog because the molecule, the Efsitora, is really complex. This is the classic insulin, the B chain, the A chain, a little bit modified, again to modify the half-life of this insulin with the linker. Then there is a second molecule of insulin here. All this is linked together with an IgG2, meaning that this molecule insulin is really really high molecular weight, really rather than calling it an insulin analog, I will call it an insulin receptor agonist. It's just the same, but this is it. So while the Icodec links to albumin, here it binds with this FcRn within the endothelial cells. So really this insulin is stored inside the endothelial cells and then is made free during time. With an half-life much longer than Icodec, here is, you see, is 70 days. So really you can reach very stable insulin concentration with this. The studies are very similar. We don't have the third trial in insulin naive, but rather than very similar as we've seen with the Icodec, showing just some results. At the beginning, the major concern was to how to titrate this insulin. Again, because the half-life is very long. So the first trial is this is the Quint one. You will see that really in insulin-naive patients, the protocols was really complicated. Start with the 100, and then go to 150, then 250, then 400 per week, according to the glucose concentration. Again, this is designed for the trial in order to reach faster glucose control, which is not something that's really often needed in our patients. And this is the classic titration for the glargine, at least in this trial, minus plus 3 units according to the fasting glucose concentration each week. And you will see, even if there was this fast titration with Efsitora, really the glargine was a little bit better at the beginning, but then at the end of the trial, the results are very similar. Just a small signal of clinical significant hypoglycemia, but the numbers are very low. Another trial is the Quint3. In this case, probably based on the experience, they just did a very simple titration protocol. It's just multiplied by 30 The only difference is that this was a switch trial, so if the patient was already on insulin, the amount of insulin you have to give the first time, since the half-life is very long, so in order you need to reach a faster steady state, you have to give a very high dose at the beginning. You see the amount of insulin is close to 600 units just the first, so it means might sound a little bit, this is weekly, might sound a little bit, let's say, dangerous to switch from, I don't know, 30 to 400 units of insulin, but this is the way the trial was designed. And even if they gave such a major load at the beginning, you see actually the glucose concentration was higher with Efsitora rather than glargine. So really, we do not need to be afraid in giving such a high doses of insulin. Again, HbA1c is not that different, a little bit better with Efsitora. Again, there is some alert in terms of hypoglycemia in these patients with Efsitora. This is, again, a switch from other basal insulin with the basal. Here, results are a little bit different with Icodec, maybe because of the trial design, there were no difference, and this is also in patients with type 1 diabetes on the top over there. You see there are no major difference in terms of HbA1c, but also no major difference in terms of time in range, time below range. It's just a reduction of the insulin, the number of insulin administrations, which might be comfortable or not. I don't think it's that much in patients who are on basal bolus, but still it's a reduction in terms of insulin injection. Again, in type 1 diabetes with Efsitora, as we've seen with Icodec, there is an increase in hypoglycemia episodes. So maybe we have to learn a little bit more in patients with type 1 diabetes. At the end of the trials, all the patients have been asked, do you prefer, especially in type 2 diabetes, and you will see that really most of these answers were yes, convenience, flexibility, willingness to recommend treatment to other patients, a willingness to continue the treatment. So once they switched, they prefer to continue this kind of insulin. So really weekly insulin achieves similar or sometimes superior HbA1c targets as daily insulin, so it might be comfortable to give less insulin. We have to remember that switching from daily insulin, the loading dose, can be difficult, and this is more true for Efsitora because the half-life is longer, it's 17 days. Weekly insulin help and simplify the initiation of insulin therapy in terms of compliance of our patient. I think there will be certainly a very useful tool in the future, although more data is needed for patients on basal bolus regimens. Thank you.
Thank you, Dr. Andrea, for giving wonderful insights into the subject. Thank you, Dr. Andrea. Now, moving towards the next session, it's my honor to invite a legendary speaker, Dr. Accd sir, who doesn't need any introduction, but as a customary, I have to introduce him. He has been listed as a noteworthy medical educator, diabetologist, consultant, physician by Marcus Who's Who. He has taught the medical undergraduates and so many postgraduates in medicine and diabetology for more than 33 years. He has affiliations with Member Research Society for Study of Diabetes in Developing Countries, Endocrinology Society India Conference, and Associations of Physicians India. He is a president-elect. Over to you, sir.
Thank you for the generous introduction. My dear friends and my esteemed colleagues, this is based on excellence in insulin therapy. And as you rightly know, that diabetes is a disease relentless, but the advances in insulin, I just now show Andrea's talk, the advances in insulin also relentless. What I'm going to talk about is this excellence that is depicted in the presently available and presently we're using the empowering excellent control with Tresiba, a long-acting potential for diabetes management, accelerating the control with a molecule which is PIASP, enhancing diabetes therapy with fires with swift action, and excellence in dual dynamics where we have Ryzodec, a synergistic effect of Tresiba plus insulin aspart. Dear friend, this is a talk which has been sponsored by the Novo Nordisk, and I have been contracted to give this talk here. Dear friend, I must tell you, let us start looking at a patient which we see every day. Ramesh, 38 years, teacher, 78 kg, BMI 26.8, normal blood pressure, known case of type 2 diabetes for last 7 years. 7 years, and he has a BP, he has a HbA1c of 9.8, fasting plasma glucose 202 and FPG 234. And you know, what is his current therapy? Metformin 2 grams a day, glimepiride 2 milligram per day, and empagliflozin 25 milligram once daily. Now, what are the challenges in this case? Number one, Ramesh has been diagnosed with type 2 diabetes for 7 years and currently uncontrolled on 3 OADs. We distinctly today remember that if the person is not controlled 3 OAD, it is time not to add 4th, 5th or 6th, but beyond 3 OAD, at least if you have not started earlier, change over to insulin. Now, uncontrolled hyperglycemia is the primary challenge in this patient. And you know, he has a very hectic life, balancing between the work and his own life. And he is very afraid that insulin initiation can affect his life for 2 things. Number one, he is very afraid of hypoglycemia. It's a very typical patient we see every day. Number 2, he is not very confident that he can take insulin at a fixed time daily. We have a term called insulin overwhelmicus. With the older insulin, when you have to give the every day, say type 1 diabetes patient, every day at the same time, and that overwhelms the patient. So he's also not confident whether he can take the insulin at the fixed time. Now, suboptimal glycemic control, despite multiple OADs, is one of the most contemporary challenge we have in our type 2 diabetic patients. You see, 2 OADs can bring down HbA1c -1. If you make it 3, another 0.5 may be achieved. If you go to 4th diabetes, 4th OADs, you will find it does not help, rather it degrows. And at this point, if you give insulin, you can bring down the HbA1c to a very considerable level. Why we give multiple OADs? We give driven by 3 things: because it is convenient, it is accepted by the patient, and we say we have limited time for the consultation because huge number of patients and less number of doctors to take care of them. Successive OADs, at least beyond 3 OADs, provide lessening effect, and there is a substantial benefit at this stage by initiating insulin. Now, even today, ADA 2025 said basal insulin is the most convenient insulin to be started in type 2 diabetes mellitus. And you saw the beautiful cartoon which Dr. Andrea showed, showing the century of insulin discovery. And you know, what is most important, remember that we have today in the armamentarium, these 3 insulins I'm going to talk about: the Tresiba, the long-acting, very flexible, I'll come to it, long-acting, excellent insulin. We have the Fiasp, short-acting, very swift-acting insulin, and the Ryzodec, a co-formulation of Tresiba plus insulin aspart. Dear patient, what are the insufficiency of the conventional basal insulin? They do not cover the entire basal situation. We sometimes have to give 2 injections. There's a lot of intra-individual variability and variable absorption and rapid peak. There's need for resuspension after the injection take time. There's a lot of glucose variability and the higher risk of hypoglycemia. If you take care of the first generation basal insulin, not truly daily, higher variability, fixed time dosing, not truly peakless, and higher nocturnal hypoglycemia. I'll show a cartoon. You see this insulin Tresiba, which is really a flat action potential. And also Tresiba shows lower within day GV, glycemic variability. And you know, it has been calculated that at least 40% lower intraday variability compared to the Glargine U300. Now, if you compare Tresiba with Glargine U300, you see the glycemic variability here. The Tresiba gives much lower GV, glycemic variability. And you know, the precipitation is one of the marker of GV. Precipitation and redissolution are processes inherently associated with substantial glucose variability, and formulations that do not precipitate after injection have low rate of variability. Suffices to mention, insulin glargine forms microprecipitates after subcutaneous injection, which must redissolve before the absorption occurs. Now, Tresiba provides greater H1C reduction. Is a cartoon which shows that it was about 0.3 greater H1C reduction, and in the BRIGHT trial showed that the mean difference of FPG, fasting plasma glucose, from baseline to week 24 was 7.7 milligram percent per deciliter. It takes care of the fasting also, and also the CONFIRM trial has shown that Tresiba has a much lower risk of hypoglycemia, and there is a change in rate of hypoglycemia and change in proportion of people developing hypoglycemia. Now, if you look at the dose, it has been shown Tresiba requires lesser dose. I'll come to how much less in a minute. At the week 24, the mean daily dose was much lower than the glargine U300. There was minus 22% lower dose of Tresiba needed compared to glargine U300. Now, if you give glargine U300, in the other way of looking at it, we need at least 20% extra dose. This has been recorded in our RSSDI clinical practice recommendation. Now, the other advantage of Tresiba is the high flexibility. Duration of action 8 to 40 hours, whereas glargine U300 gives about 13 hours, and glargine 100 doesn't have any of this advantage. Now, if you look, it gives, if you look at the patient, it gives a greater treatment adherence, and treated with Tresiba were 27% less likely to discontinue because they like this insulin for the quality of life they have. Now, across the board, all types of patients, it can be used above 1 year of age, pregnancy, pediatric, above 1 year, adults, elderly, renal hepatic impairment, and hospitalized patients. Now, if you are going to switch, you can start with 10 units of Tresiba. Reduce the dose Tresiba by 20% when adding GLP-1 RA to Tresiba, which is the order today. And if you are switching for the basal OED, 1:1 switch, no need of change in dose. Basal component again 1:1, basal component in basal bolus or basal component in the premix, same dose can be given. Per basal BID, 20% dose reduction when changing from the glargine 300. Now you see, revisiting our case at 3 months, you find that HbA1c has come down to 8.1, fasting plasma glucose to 110, and postprandial to 148, and he was only put on 14 units of Tresiba along with other OADs. And if you look at the patient was advised to take mealtime insulin. However, he was concerned about the adding prandial insulin, as the meal timings are erratic, but you see how he accepted Tresiba because of long-acting insulin. We'll come to the second component. Now, the second component is about what are the limitations of the conventional insulin. Slow absorption, slow onset of action, need to administer 30 to 40 minutes before the meals. And for a type 1 diabetes, do not know whether he will eat or he will throw up, or even for the type 2 diabetic patients, and risk of delayed hypoglycemia due to slow effect. Now, this is the FIASP. It almost mimics the physiological insulin profile even further, and it shows greater PPG control both at 1 hour and 2 hour. And if you look at the delayed hypoglycemia, it was much less compared to glargine U300. I've given the percentage. FIASP showed a significantly low rate of delayed hypoglycemia versus it is own comparison with Aspart. With comparison to Aspart, insulin Aspart versus FIASP, it showed much lower delayed hypoglycemia. And FIASP also given convenient dose flexibility. You can give it before start of meal within 2 minutes, or you can dosing window after start of meal is up to 20 minutes. So more convenient in daily life, reduce risk of hypoglycemia, and useful person with diabetes with irregular eating pattern. Therefore, flexibility of Tresiba can be used any time of the day. You have sent a patient for the morning investigation. He can come back and take the insulin with an inter-injection period varying between 8 to 40 hours without regard to meal timings and without regard to meal portions. The FIASP also flexible it is dosed 2 minutes before the start of meal to 20 minutes after the start of insulin. Allow precise calculation of the dose depending on the food it takes. We'll come to the last part of my talk, the dual dynamics of one of the excellent co-formulation, the synergistic power of Ryzodeg. Now this is a patient, Suresh, 54 years, businessman, weight 75 kg. You see HbA1c is about 10.3, fasting plasma glucose 154, ppg 286. He's on a very high dose of metformin 1 gram BD, glimepiride 2 milligram BD, and dapagliflozin 10 milligram OD. And you see that now Ryzodeg today is recommended as a choice for insulin initiation at the initiation. Ryzodeg, if you compare to other premixed insulin, less hypoglycemia, requires less dose than the other premix, and there is less weight gain. The flexibility of administration and adaptable to various significant meals that varied in different days. Now, if you compare premixed insulin like biphasic human insulin, biphasic Aspart, or biphasic Lispro with insulin Ryzodeg, you will find that the Ryzodeg mimics physiological insulin secretion closely. There is no shoulder effect, which we find ordinary premix, reduced variability and simplify the insulin regimen without requiring resuspension and lower the injection burden. Whereas the premix can give you glycemic variability, incomplete 24-hour basal coverage, and need for resuspension, which is absent here. Therefore, good PPG control we need from the very beginning, because HbA1c has a stronger correlation with the FPG and PPG. Increased PPG and FPG drive increased HbA1c, and this Ryzodeg fulfills the promise of taking care of both. Now provides greater A1C reduction versus glargine U100, and you find that provides superior long-term glycemic control compared to glargine U100. Now, low rates of hypoglycemia with Ryzodeg, this has been confirmed by various studies, including Bright study and others, and you find here the cartoon that the severe hypoglycemia and other confirmed hypoglycemia is much lower. And if you look at the quality of life, if you look at the diabetes-related quality of life score, the Ryzodeg is much more accepted and gives a better quality of life. So there's improvement quality of life. So improved efficacy, low dose requirement, reduced injection burden, and improved satisfaction, and improved safety. So switching over from older premix into Ryzodeg provides superior glycemic control, and the significant improvement in HbA1c at 3 months and beyond. Now, switching from the old premix insulin to Ryzodeg provides superior glycemic control, and there is significant improvement 3 months and 6 months. The dose reduction also occurs in the degludec component of Ryzodeg at 3 months about 20%, and at 6 months about 19% of the dose reduction of the degludec of the Tresiba. Now, if you look at the CREATE study, it is about the real-world experience of switching, and it showed the superiority of Ryzodeg, and also it has been shown in other finding for other study. I just summarize to say that the statistically significant reduction of FPG across all groups, significant reduction in the incidence of non-severe nocturnal, non-severe hypoglycemia, the diabetes treatment-related quality of life score increased, and 93.3% expressed willingness to continue it, and 93% expressed preference to Ryzodeg over other previous insulins. Thank you very much.
Thank you very much, sir. Thanks a lot for a very enlightening talk on the subject. Now I would like to request our next speaker, Dr. Shagun Bindlish, and she would like to speak on the topic, what's new with interpretation of CGM matrix and relationship with A1C, EA1C and GMI. A little bit about Dr. Shagun. She is a board certified internal medicine physician, board member, educator, writer, international speaker with advanced training in diabetes and metabolic disorders. She has a fellowship in diabetes from OU University Athens. She did her internal medicine residency from Lutheran Medical Center, Brooklyn, New York. Internal medicine residency from Berkshire Medical Center, Pittsfield, MA. Doctor of Medicine from Yerevan State Medical University, Yerevan, Armenia. She has many different certifications and awards, like honor to receive Dr. Peter G. Linder Award for Outstanding Contribution in Teaching. And she also has certification in obesity medicine from American Board and Institute of Integrative Nutrition Health Coach Certification Program. Thank you very much, madam. Please, over to you.
Thank you very much for the kind introduction. And one more introduction I have is that I have my own non-profit that I started, a Golden State Obesity Society, and I have a small logo here. I think this is more of my close to heart work, and if I see long back, I have come a long way from my diabetes fellowship to obesity medicine and lifestyle medicine specialist. So that's my another introduction. So thank you again. And it's like a gratifying moment. I always start my talk with a gratitude, and I'm very thankful to the Team India and Dr. Makkar and Dr. Amit Gupta. I would like to start my presentation. So today I'm going to talk about beyond A1C, how do we interpret the numbers like GMI, EA1C, and A1C. So every time, as soon as I became a diabetologist, I came across this samosa analogy. So I thought I'll put it here. Whenever I came to India, and some of the friends or relatives, they will ask me about samosa. And as soon as I start talking to them about samosa, the first thing will be, just take one extra pill. Who will leave the samosa? So I think you would have seen that so much, right? So for patients, actually, pills can be negotiable, but samosas are not. And until CGM showed the reality. So right after samosa, you can see the big time spike, and now we can talk about samosa analogy. So just humor, I wanted to see if you all are awake or not. All right, so CGM actually has come a long way. This is like 100 years of innovation. We used to have this blue solution, green, orange color. Actually, it started from our Ayurveda, where we call it Madhume. And from that time, if you really look back and see, we have come a long way. And we have traces of reducing sugar initially, and now we went to the, if you see, that's the real-time blood sugar logbook that patient used to use, which has some blood stains, you can see, which was the reality as well. And now we have come from like 1,300 to up to 20,000 measurements per person for 14 days. That's a CGM. So these are the current methods of monitoring blood glucose. We are very used to and prone to use the hemoglobin A1C, which is a current metric which is used also for the quality purposes, has been used for long, long time. And it is basically the average of 3 months for glucose control, but it cannot determine the glucose variability. Self-monitored blood glucose is the finger stick. Again, it provides glucose information for point in time. And then we have the CGM, which is a real-time glucose levels, seen with alarms for low and high sugars. From, again, 100 years of improvement, CGM also has come a long way. We started with the Minimed in 1990. And slowly, as we move towards the current era, the difference between and the accuracy of the CGMs has significantly improved. So as you see, from 25% to 9.2% in Libre 2, that's a significant improvement in the CGM data, which is more accurate now and more precise for the blood sugar control. So what are the FDA approved personal glucose monitors? So we have Freestyle Libre. So we have Freestyle Libre, which was the old one. I was trying to use the pointer here. I don't know if this is working. So Freestyle Libre 14-day, then Freestyle Libre 2, and latest one is 3 and 3 plus, but I think in India it is 2 plus right now. We have G7, Dexcom, G6 and G7, and Medtronic, and I'm not sure if you're aware about the new one, which is Senseonics, which is an implantable CGM, which is good for 180 days, but it needs a procedure, small procedure in the clinic, and it is actually coming up for patients with type 1 diabetes in case they want to. So, but this is again implantable, it stays in for 180 days. So believe me, this is not my arm. But I wanted to show you all how are the different types of sensors and how big and how small they are. So top one is Dexcom G6 and Libre 2, which were bigger in size. Now we have the smaller version of Dexcom and Libre, the second row if you see. And this is the Senseonic, which is the biggest one, which is again implantable, and that's the way it looks. And if you see the image on bottom, we have the side profile, and you can see again, the size started from Guardian 3 to the latest Libre 2, which is a quarter size. So again, it's a long innovation, and it's definitely great for the patients now. And how does the CGM work? We all know we are measuring the interstitial fluid as compared to the blood vessels. So that's why it is important to know is because of the lag that happens. So SMBG provides the glucose information for a single point in time. So I tell my patients that this is like a photo for you as compared to CGM, which is like a movie. So why does it matter? So hypoglycemia and hyperglycemia both can be missed when we are only doing the SMBG, because it is very patient dependent how many times they want to do the finger stick, and finger stick is definitely not very pleasant for patients to do it constantly. So even if they test 4 to 5 times a day, we're still getting just a photo, and we can miss many important events. So CGM measures the glucose continuously. So again, why we need the continuous monitor? So ultimately it comes to the heart. So what it is telling us is about glucose variability, and glucose variability is associated with endothelial dysfunction, and that is actually directly correlated to the cardiovascular disease outcome. So that's the reason we want to know about CGM overlay of SMBG. So why do we want to look beyond A1C? So A1C is giving us the picture for only 8 to 12 weeks average, misses daily fluctuations. It is very much influenced by diseases like anemia, kidney diseases, hemoglobin variants. And in India, it can also vary by meal patterns and variability, and that basically makes it very valuable. So now we'll go to our point. These numbers, these terms can be very confusing. So we call it like an alphabet soup. So we'll detangle these words. So we have GMI versus EA1C versus EAG. So EA1C is an old term, not used anymore. It is called estimated A1C. It is replaced by the new term called GMI, which is glucose management indicator. So GMI is the first thing you want to see, or you can correlate, or you want to basically, when you get the AGP report, this is the first thing you want to know, what is the current GMI in last 14 days. That can actually help to define the outcome for the patients. GMI formula actually came, if people who are really mathematicians, they can see this is the formula. GMI percentage is equal to 3.31 plus 0.02392 times mean glucose. So this is the formula which has calculated this number. But EAG is the average glucose. It converts lab A1C into average glucose. So it's just the average glucose that is telling us about the patient's blood glucose. So what is the strength of the GMI? So GMI is estimate of A1C based on mean CGM glucose over the past 14 days. And it is absolutely independent of any impact of glycation rates or red blood cell turnover. And when we have GMI and A1C, they both are discordant. The discordance is consistent with individual over time, and it can be very informative. So that's the reason this is the indicator is used for example, patients who are going through surgery. You can actually tell with the last GMIs and actually clear them for the surgery if that has improved as compared to A1C, which you have to wait for 3 months. So, but limitations are also there. GMI and lab A1C often differ by 0.5% or more due to either both in A1C and in CGM glucose measurements. So this study was done actually in the patients mostly who had type 1 diabetes, and they developed and validated this cohort mostly in white adults. So they used the Dexcom G4 sensor and G5 CGMs. So when they did the study, they came to know that in type 1 diabetes, it was very valuable, but they did not do the study in type 2 diabetes. So it was initially discordant whether this is going to be impactful for the patients with type 2 diabetes. Later on, when the studies developed for type 2 as well, and the GMI actually was better for these patients too. So when the discordance between GMI and A1C happens, the patient gets very confused, and it is difficult for them to understand. So that's why when you see the first graph here, we don't want to go through detail every paper. This is a different papers, and it shows the percentage with GMI and A1C discordance which is more than 0.5%. So if you just see the first line, which is 68%, so that is actually giving us knowledge about A1C, which can be incorrect in the setting of altered glycation rates and RBC turnover. GMI can also be incorrect in the setting of CGM sensor inaccuracy, use of different CGM sensors, and known inter-individual variability between venous and capillary glucose. And that's the reason that calibration and checking with the real-time blood glucose monitor is very, very important. So the true glycemic indicators that should be used for treatment decisions are glucose values and trends. So that's why we will go on three more terms, and all indicators should be interpreted dependent on the patient situation. So whenever A1C and CGM disagree, first thing we have to do is check the CGM data quality. How many times, or it's very important to know how much time the patient has worn that sensor, because if patient is wearing the sensor just for 50% of the time and it comes off, then you're not having the accurate data. So it has to be at least more than 70%. Review the acute illness or therapy. So whenever patient, for example, while the patient is wearing CGM and had a fever or they got sick with any upper respiratory tract infection, that is going to screw up the curve big time. So it's always better to have a second sensor later on to make sure that was a real-time elevation of the blood sugar or not. Or anytime you change the blood sugar therapy, we should always review the data. Third is always investigate anemia and hemoglobinopathies. We have been seeing a lot of patients right now, especially in the menopausal and perimenopausal state, going through anemia. So for them also, this can be very discordant, so we have to always address that issue. And for short term, we trust the CGM, but long term, we can still track the A1C. So time in range international consensus, this is a very good visual for how do we differentiate between type 1 and type 2 diabetes versus older patients who are high risk, and pregnancy has a different cutoff, and then pregnancy that is gestational and type 2 diabetes has a different cutoff. So it basically tells you the different time in range based on the different patient population. Time in range is TIR 70 to 180, time below range, then we have time above range, percentage CV is correlation variance, that is glycemic variability, and mean glucose and AGP pattern. So every time that there is a 10% rise in TIR, there will be decrease in minus 0.5 to minus 0.6% of A1C, which is actually a very good result. So we should use it directionally, not as a direct conversion. And time in range is basically 70% is usually come with the A1C of 7. So if you see this line, that's where the 70 to 180 number has come. So 70% is actually equal to almost like A1C of 7%. So quick review of AGP report is that, and that's why we need this TAR, TIR, and TBR. That's what I was telling. This is like alphabet soup, but if you just understand TAR is above range and TBR is below range, and between everything is, which is normal, is TIR. And these are some of the factors that impact A1C levels, so we always have to look for these and rule them out. And again, GMI is our new way to gauge glycemic management, because this is, again, so if you see the graph, GMI calculated for various CGM-derived mean glucose concentrations, we have different numbers of glucose, which is correlating with the GMI percentage. So most commonly, if you see this 175 blood sugar is about 7.5 of GMI, and 200 of glucose is about 8.1% of GMI. So, but if you check for the A1C, it may not capture that value. So for the guidelines in Indian context, we have seen, I have seen that RSSDI has their guidelines for 14-day CGM with more than 70% of, if patient is wearing it for more than 70%, it has a valid assessment. Then again, for adults, we want more than 70% of time in range and glycemic variability of less than 36%. For children, again, time above range should be less than 25%. This is for patients with type 1 diabetes, like children with type 1 diabetes. And pregnancy should be more than 90%. So again, it depends on the patient and the population. And for elderly, it is again not very, TIR is like less than, more than 60%. So AGP quick reading, just in 1 minute, what we need is like completeness, the variability, headline metrics, that is TIR, TBR, TAR, and glycemic variability and mean glucose. These are the 5 numbers that you have to see. Look for the post-meal peaks and the nocturnal lows, and then plan the adjustment based on the trends. So trends are very important. That will actually give you the main idea. So CGM systems are more than new monitors, but most important is monitoring is not managing. This data can become very overwhelming, and CGM can give you the fatigue. So data is always good unless it is interpreted right and conveyed correctly. So again, monitoring is not managing. It's very important to basically work with your patient and make them understand that how we are managing and making the changes in their medications or lifestyle using the CGMs. And this is the note template for interpretation. I have put it together. This, if you document this much, it's very easy for you to future interpretation, and you can do the comparison, and patient also likes it. So we use this template a lot in our practice. So if you just put in the history, download from date, indication, why we are using it. This helps us for the insurance purposes as well, like nocturnal hypoglycemia and pattern identification. And then we put interpretation. You again see that these are the words that we definitely have to put, because once you have the next level, it will be very helpful for you to compare. So from where we started and where we have come. So, and then most important, glycemic variability. And then recommendations, based on this, you can make the changes in the treatment plan. So key takeaways, lead with TIR, glycemic variability, not A1C alone. GMI is just contextual, not equal to lab A1C. And targets should be tailored by the patient population, and use AGP as a clinical dashboard. So remember, CGM is, it shows us where we, A1C actually was, it shows that where we have come from, but CGM actually shows where we are going. Both the perspective are very important, but using the CGM real time and managing patient right now basically helps in the better outcome. Thank you very much.
Thank you, madam, for the excellent lecture. Now I call all the speakers on the stage for the discussion. All the speakers kindly come to the stage for the discussion and question answer. Dr. Andrew.
So please come over here.
Please be seated. मजा आएगा सर आपके साथ बैठने का. Andrew, please be seated. Dr. Andrew,
I'm ready, sir.
Dr. Divya.
So we have enough time for the discussion. Thankful to our speakers, they have finished in time. So there is one question coming from the audience. Dr. R.K. Kinvasna want to know, this is addressed to you, Dr. Das sir. He's saying that in one of your slides, you discussed a case about Mr. Ramesh. He was taking glimepiride 2 milligram per day. Although he was on 3 OHAs, but he want to ask, just a small query, can we further increase the dose of glimepiride to a maximum of 8 milligram, or straight away go to the insulins?
The glimepiride maximal dose is 8 milligram, but in clinical practice, we do not go up to 8 milligram because of hypoglycemic fear. We usually stop at 4 milligram. The two cases I presented, one was on 2 milligram, the other one was 2 milligram BD along with metformin 1 gram. There has been a suggestion when we published the paper of 3 oral hypoglycemics not working to change over to insulin. There was a suggestion like resistant hypertension. 3 drugs, one of them must be diuretic. The letter to editor said there must be 3 oral hypoglycemics. One of them must be sulfonylurea. From that point of view, your point is correct, that glimepiride. But normally we do not escalate glimepiride too much for the hypoglycemic fear. And you know, all the oral drugs are said to work better with submaximal dose.
Dr. David, next question is to you. So your talk was centered around CGM in non-diabetic persons. So what do you think, sir, about, so in India what we are seeing is more or less athletics are now started using it, people who are doing marathon running, people who are doing occasionally into gymming, they have become conscious about their health and they started using CGM devices out of their own. But the problem is that we are still following the evaluation matrices based on diabetics. So how do you foresee the situation moving forward around that cohort of users?
That's a very common problem, and we're seeing that in the UK and across Europe as well, that this is becoming a commodity that's being used by the worried well as a route to try and do something about their health. But the reality is, we don't know what to do with those results. What we're using it in our cardiometabolic clinics is a lifestyle modification tool. And we'll do that in a structured manner. So the example we gave, where I gave suggestions for what people to do for alternate days. So one day with the walking before and after, one day with the sugar at the start of a meal versus the end of the meal, different diet compositions. Very, very good for behavioral modification. And it's very good to be using it intermittently every 3 to 4 months, particularly if we're using it with the GLP-1 based drugs or the incretin based weight loss drugs, that we can actually see the benefits in real time. My worry is that we are never really sure what the numbers mean. And because I'm not even sure that the numbers are accurate, I'm only ever talking to my patients about the trends. What patterns do they see? What peaks they see? And I think that's the thing to be able to do. The other thing is there's a couple of really good AI companies sat outside. There's several people who've been developing in AI technology in how best to predict the numbers that we see and how to turn that into actionable outcomes. But they are still only in the developmental phase, and they still do very much need our input in order to make those work. So the bottom line is this is a commodity, this is a behavioral modification tool, helps with some diagnoses, but you have to take those results with caution, and you have to make sure whoever's using it fully understands the fact that you can't really understand and interpret those results because we still don't yet know what normal looks like for that population, let alone what abnormal looks like.
Previously, we had the availability of flash CGM. We're doing it for a shorter time.
Yes.
Vis-a-vis today 14 days. What's your comment on that?
So we have moved far more from flash glucose monitoring to continuous glucose monitoring for several reasons. The one is it gives you real-time updates. My dashboard at home for my older adults, particularly for the frail older adults, I have a dashboard at home where all of my older adults that I've got CGM and on insulin comes up, and the AI interface for that allows it to flash up to me when that patient's having problems. Historically, we saw patients based around appointment schedules in a diary, whereas now the interface says this person's having extremes, ups and downs, and it's having hypos, which means I can then prioritize that patient for a callback. Other patients that have excellent readings, I'll delay their appointments for weeks and months, and moving away from seeing patients when the diary says it's right to moving it to when the patient actually needs it. And that's one of the real perks of the continuous glucose monitoring with the real-time uploads to our dashboards. But of course, the big barrier there is the interface that we are using and the access that we have to those interfaces. We ended up having to have a bespoke AI-based interface written for us with one of the major companies that is outside. And in the interest of transparency, I'll have that conversation outside of this so I don't appear to be advertising.
Dr. Das, deglutide is long-acting insulin, but we in the Ryzodac it is a co-formulation. Why we should give in the BID dosage?
It is given, you know, that it is the same concept as we used for the premix. The rapid-acting component will work for the postprandial, immediate postprandial, and the long-acting component will act for a longer time. That is the one.
Why we should give the long-acting again in the evening?
Why should you give?
Long-acting in the evening, Ryzodac.
No, it is actually given once daily with the major meal, usually. If need arises, we give 2 doses. Only 1 dose with major meal. Yes.
So I received this question, if a young patient comes with an HbA1c between 5.7 and 6. Should we continue some basal insulin if he's young, 30 to 45, and does not have any hypoglycemia? Well, that's a really good question. You know, always my effort is to try to avoid insulin as much as I can. I mean, first sulfonylurea. I don't prescribe sulfonylurea since 10 years, unless really desperate cases. But also to avoid hypoglycemia, because hypoglycemia is the major danger for our patients. It's maybe not this young, but we know that hypoglycemia episodes of hypoglycemia are associated with mortality and cardiovascular events. So insulin now is the only treatment which determines hypoglycemia. So if I can, I try to stop. That's my first rule. Unless, as I mentioned before, LADA. I mean, obviously, we cannot stop insulin type 1 diabetes. That's what we're talking about, type 2 diabetes. So the only patient in which I try not to stop insulin, to give a little bit of insulin, maybe a weekly insulin, just to be sure the DKA is not there, is not coming, just because, who knows, maybe some other events, some infections, something different, is fasting, is vomiting, or whatever. If some insulin is there, probably the risk of DKA. And I'll tell you that it happened in my life many times, especially in newly diagnosed patients that comes in my office with very high HbA1c. I start insulin, sometimes I start basal bolus insulin, but then I start to titrate other drugs. For example, semaglutide. I mean, you cannot give 1 milligram semaglutide one day to the other. Once semaglutide goes to 1 milligram, maybe in the meanwhile, the patient starts to diet, to lose weight, to eat better, and maybe you can reduce the basal insulin, even the bolus insulin, and sometimes I'm also able to stop insulin. It's really a good satisfaction to stop insulin.
In our country also, the maximal use of insulin is also as a bedtime insulin and daytime oral drugs. I mean, giving them the combination therapy is quite prevalent in our, and the Ryzodec can be combined with the oral insulin. That's why both the cases, the oral drugs were continued. What you said is absolutely correct. If you can get better result with combination therapy, that must be promoted, and Ryzodec can be combined with the oral drugs also.
I'm going to tell you something that is very different between me and you. Because now I never give insulin at night, after dinner, because, I mean, basal insulin should be decided according to fasting glucose.
Yeah.
And 50% of the patients do not remember at all how was the fasting glucose the morning before. So they measure glucose there and they decide based on that, which is not correct.
Yeah.
So since now we have, with Glargine 300, Degludec, and now the weekly insulin, we have the fasting glucose in the morning. Give the basal insulin in the morning.
Yeah,
it's much easier.
we do that, sir. We give it to the major meal in the morning, high breakfast, and or the lunchtime, when the lunchtime is major meal. Absolutely correct.
I just want to put a hypothetical to you, because we're seeing far more patients with type 2 diabetes that are reaching that stage of pancreatic burnout. And we know that low insulin levels is very tightly associated with Alzheimer's type dementia. It's pro-inflammatory. How do you feel about low-dose insulin for those very elderly patients when the before the HbA1c gets to the characteristic pre-ketotic level? Where do you think the right time to introduce insulin is as a protective drug?
That's something I do, but I try to do it temporary. I consider insulin my failure, not a failure of the pancreas, my failure. If it's autoimmunity, there's nothing I can do. If it's not autoimmunity, well, probably something, I can try to do something different. At least I try. Then we will see. If I'm not able to do it, I mean, explain to the patient that maybe you have, again, another intermediate disease, an infection or whatever, and then maybe you need some insulin because of this period. But then I try to stop insulin because, again, it's the quality of life which is important for patients. Without insulin, without hypoglycemia, it's completely different. And also, this is the reason why for older patients, I mean, I'm not trying to follow to have HbA1c very strict. I mean, I just want to avoid hypoglycemia.
But the lack of insulin for these very elderly patients is one of the drivers of sarcopenia that we know is one of the hallmarks of frailty. I mean, I've got some patients that have had type 2 diabetes for 40 years. So they were first diagnosed when the only treatment was metformin and glycoside, or actually chlorthalidone, those sorts of patients. They surely are allowed to have pancreatic burnout.
Yes, you're right, but you can try to also try to modify the diet. For example, much more common for me is the lean patient on SGLT2, in which you have massive calorie loss, and you try to recover the body weight is difficult because, I mean, they lose lots of calories. So I tried a little bit to modify the diet away from glucose, try to, I mean, healthy fat, omega-3, for example, this kind of nuts or whatever, trying to give less glucose and have less glucose loss and try to recover some body weight, and also obviously protein and trying to recover skeletal mass. And we'll see tomorrow that there are also drugs coming that try to increase the skeletal muscle, especially in patients with are using GLP-1 receptor agonist.
So, thank you, sir. Now, we would like to conclude this session, and thanks a lot for your very, very invaluable inputs on the topic and very enlightening talks that you gave us. So, thank you very much.
Thanks for the wonderful session. I would now request Dr. Paras to kindly hand over the mementos to the chairpersons.
कोई बात नहीं, एक मैं वही सोच रहा था सुबह से गड़बड़ कैसे नहीं हुई, तो अभी हो गई. Twenty seconds more. Last 5 seconds. This is last quiz for today. Try your luck. Here comes the first question. Be quick. Very easy one. "56 are correct. Let's see who is the leader after first answer. Apurba. May I know where Apurba is? Oh, at least someone from this end. Great. Second question. Little tricky one, but if you were attentive, you will be able to answer. Good. Everyone was attentive. Most of them. 51 are correct. Let's see the change in leaderboard if there is. Great, maintaining the lead. Good. Last one, the margin is very thin, huh? Last question on your screen. Very easy. I thought it was easy. Anyways, here is the winner. Let's see. Oh my God. Oh my God, this is how it can hurt. Where is Thinky? Oh no, again from that side. Can you come over here, sir? Please. A big round of applause for him. We know you were thinking, but what is your real name? Dr. Prabhat? A big round of applause for Dr. Prabhat Dutt Tripathi from Ayodhya. Come over.
So moving on to the next and the last session of the day, it's the panel discussion on diabetic distress, for which I would request Dr. Ajay Tiwari to kindly come on the stage and moderate the session.
Thank you, ma'am. And we are at the fag end of today's program. But this is something which is very interesting, and it is about diabetes distress. So we always talk about the physical, micro and macrovascular complications of diabetes. But we do not understand what it is causing to the emotional plight of our patients. So today we will be discussing this very interesting topic, and for that we have very eminent panelists with us, Dr. Accd Das sir, Dr. Purvi Chawla and Dr. Saurabh Srivastava. So I'll request them to kindly join us on the stage. Okay. And I would request J.K. Sharma sir to join us. So this is more of what we intend to do, that we need to involve the audience also. Because what we are trying to do in this particular panel discussion is that we want to have your views also. What you see in your patients, because this is all about how we see, how the patients are overwhelmed by the number of medications, sugar testing, the name of insulin. So everyone has a story, and we all have very eminent clinicians with us. So this will be a sort of a open house sort of thing, that our panelists will give their opinions, but I would request all the people to come forward what they think about diabetes distress. So basically, what is diabetes distress? So first we have to understand there are some things which mimic diabetes distress. So we can have depression, depressive disorders, we could have generalized anxiety disorders, or we could have diabetes distress. So diabetes distress refers to the emotional burden, worries and frustration that people with diabetes often feel while managing their condition on a daily basis. So this is specific to diabetes. So we have depression, we have generalized anxiety disorders, but they are not disease specific. So we can have coexistence of these factors. So I would request our panelists, so how do you define and what you understand about diabetes distress, and why it is important to differentiate this with generalized anxiety disorder or the depressive disorders. So may I request Das sir to kindly start.
I think the most important thing that I must mention before I start, Ajay, with your permission and please permission, that the ADA was publishing the standard of care. I don't see Andreas here. And they had all the standards of care, but there were no psychosocial aspect. You might remember, before 2017. And it was one of us, namely Sanjay Kalra from this part of the country, who wrote, and we all together discussed, he wrote, he took the leadership. He said the psychosocial aspect must be also reflected in the standard of care. I'm very happy that we contributed, like metformin and many other things, we contribute to this. Now, diabetic distress, as we have defined in that paper, we said it's a negative emotional impact for three things. Number one, fear of diabetes. How do I manage it? How do I manage it? And how is my future health? That future health also includes whether it will go to my children, it will be transmitted to my wife, etc., etc. So it's a negative emotional effect. Overwhelmed by the burden of diabetes under 3 areas. Number 1, fear of diabetes, fear of complications. Number 2, how do I manage? And third thing, will it go to my children? I'll be infecting my wife, because a lot of illiteracy exists, medical illiteracy exists even among literate people. That is the definition, Ajay.
Yes.
Negative emotional effect.
Yes.
Negative emotional impact.
So we have to understand that this diabetes distress may coexist with depression, or there could be a generalized anxiety disorder also. So we have to understand, but we have to elicit this from our patient. And as sir was suggesting, that we need to ask them every time, are you overwhelmed by the medications? Do you have fear for the pricks, what you are doing on a regular basis? What do you think? So those worries have to be addressed by us. So that is what we call as the 5 A's of how we go ahead with diabetes distress.
So one small interruption, that, you know, as Ajay said, depression is always associated with diabetes distress. But it is different from distress. It is different from distress, diabetic depression, but it is almost always associated with, as you rightly pointed out, with diabetes distress.
Dr. Purvi, please.
And we have ways and means of providing treatment, counseling se lekar dawai dene tak. We have ways and means to take care of it. Sorry for the interruption.
Yeah. Dr. Purvi, your ideas about this, and how do we differentiate diabetes distress from depression? So that is, I think, very, yes.
So before I get to that, I think one thing we must all recognize is that, so first of all, thank you for bringing up that background on Dr. Sanjay Kalra sir, bringing it to the fore, because diabetes distress has actually come into play as a formal definition only since then. This is very specific to diabetes, and we can still, you know, they have tried to organize it and sort of structure it well so that we can understand as clinicians and also offer, you know, some detection as well as support to the patient to deal with it. So that's one aspect, that there's a formal definition as we just discussed, and it's very well structured so that we can address it better. It can be just the emotional burden of diabetes. It can be interpersonal affection and burden because of diabetes. It can be treatment regimen related burden also, and it can be physician related also. So a lot of different aspects to it, and the key is that we need to really talk to our patients about it, because even in that short consultation, I think there is enough opportunity to understand. There are pointers like uncontrolled glycemia, poor adherence to therapy, or even lifestyle changes that may have been recommended. Sometimes patients themselves talk about it. It may not be in a formal way, but they may have different language or different emotion being shared about fear or about, you know, even stigma, or they may not want others to know about it in the family, and or clearly there is no support around them. All that can be overwhelming, and that needs to be identified and then dealt with clearly. So while there are formal scales to understand diabetes related or diabetes specific distress, of course for anxiety, depression, we would like to involve our psychiatry colleagues also, so that we are not missing out any disorder as such, and may require formal treatment of the same.
Okay. Thank you, ma'am, and I will ask Dr. Saurabh to kindly elaborate about it and why, what could be the features, because now we are discussing about the features. What are the factors which could cause diabetes distress in a patient?
The most important thing is that in patient having diabetes, there are many challenges. First and foremost challenge is how to go about, there are n number of drugs, there are insulin, I have to take insulin or not, whether there will be complications or not, how to tell others if we are sitting in a social gathering, how to disclose about it that I am having diabetes, I have to take medication in that scenario. If I am in an office scenario, then whether I have to take medicines, how to take medicines, how to restrict from others. Others are taking, they are sitting in a place, they are taking sweets. I have to avoid sweets. If I avoid sweets, then there will be questions about why you are not taking, then it will, so they are basically having n number of fears. As I already told that there is a fear of complication, there is a financial burden to it also, because diabetes comes with a financial burden. So there is a financial aspect also to it also. Most of the patients, they leave the medications just because, and some are having perfectionists, they want that their sugar blood glucose should be in very tight range. And if they are not able to achieve it, they get themselves distressed. So these are many things which are there, and these are the things which we should talk about it. We should talk about the patient, that what is the most difficult aspect of the diabetes which you are having, and then only the patient will come out of it, and then he can discuss all these things with you, and then all these things which are being displayed, that they can come into picture.
So I think you have very well pointed out that it is eliciting from the patient.
Ajay, actually, the depression, you have rightly said, compared to general population, the diabetics have more depression. And also sometimes they have what we call MDD, major
depressive disorders.
Major depressive disorder. But majority may not have the major depressive disorder. Number two, we also wrote an article called Diabetes Care by Ear. Diabetes Care by Ear. And where we wrote two things, as you rightly pointed out. We talked about supportive listening. Supportive listening. Just listen to the patient what he's saying. I'm sorry, I'm talking too much. I will not talk after this. Supportive listening. And second is sensitive questioning. Sensitive questioning, so supportive listening and sensitive questioning. So I think it's understood. Sorry I took time, but I want to give this diabetes care by ear. Supportive listening and sensitive questioning. Sorry for the interruption.
So I will request Jugal Kishore Sharma sir, what type of emotional, and if you can give a real life example of a patient, what if you declare the diagnosis of diabetes or if you initiate insulin, so what type of things are happening in his mind? What are the issues that could be there in his mind?
Thank you, Dr. Ajay. The very important thing is that the diagnosis of diabetes, if it is at a younger age group, then it is more difficult to convince the patient, not only the patient, the family, because then the cycle starts. My daughter has got diabetes, how she will get married, what will happen to the family where she is going, what about the children? And dear friends, I can vouch on this, and I tell you that the best psychologists for our patient are we. If we can give time to our patient, counsel our patient, discuss with the patient and the family about this, we can definitely overcome the anxiety part. The first happens is the anxiety, and the symptoms of hyperglycemia may be associated with other anxiety symptoms, like the patient may have palpitation, patient may have loose stools, number of times going for that, must be thinking all the time what will happen, I am only 25 or I am only 30, what will happen to me in the future. So we have to be a part of the managing team. Not many people. I don't agree with Dr. Purvi regarding the psychiatric assessment. No, if it is required, then we'll go at a later age. But before that, the doctor himself, the family and the patient. So this is the team which will take care of everything. You have to listen to the patient, as Professor Das said, treatment by ear. So give a patient learning to the patient without any interruptions. Let her come out or let him come out with all the anxiety, all the worries, and then one by one we have to give special time to these patients at the first time, and then we explain everything. And I think it will not be difficult. In 2-3 meetings, the patient will definitely take it. The elder is the age group, or the older or the late age group, things are little less problematic, because then the patient also explains, say, I had a diabetes at the age of 60 years, but difficult in the younger generation. So you have to give time, you have to explain to the patient how is happening, what is our course of treatment, and how the things will improve, and definitely it will be of use.
So very easy to say I disagree, but I think the real point is that if the patient, we know that the prevalence of anxiety and the incidence of anxiety and depression in our people living with diabetes is at least twice more than that of the general population. In that case, we need to have that index of suspicion. Of course, we as experienced clinicians, we have to learn that with sensitive listening to the patients, we need to decipher whether it is really an organic problem which requires further psychiatric assessment, or it's going to be handled at our level, or just with some formal counseling also. So I think I very clearly did mention that it has to be if there is any confusion or if there is shortage of time, then we can implement those formal scales that we have today, very easily downloadable from the internet. It's called the diabetes distress scale, 17 questions, very easy for the patient also to kind of mark. The scoring system is very easy. In case we are short staffed or we do not have adequate time or confidence that we will be able to decipher the difference, then definitely we can implement those formal scales.
Definitely, I agree to that. But before that, you take a good history. If the patient was
Absolutely.
having any symptom of anxiety or depression before this diagnosis was done, so, and at least give 2 to 3 sitting to the patient, patiently listen to the patient, and I think if there is no underlying depression or anxiety before the diagnosis was made, it will be easy for us to tackle the situation.
And like all the factors I mentioned, unexplained, uncontrolled glycemia, hypoglycemic spells also, lot of, lack of sleep without any adequate reasoning, then all this should raise a doubt in our minds that, there is some amount of distress that the patient is feeling and we can address it better.
Okay, so I think we have brought out few things. One is very important, that is listening. And as Dr. William Osler has said, that listen to your patient, he is telling you the diagnosis. And same holds true for these psychosocial elements also, that lot of listening is needed. And I would add empathetic listening, because you have to be empathetic to the patient. You have to understand what he wants to say. You have to understand his condition. You have to put yourself in his feet, then you will understand that what is the issue. Then Madam has elicited some important points about the scores. So we have got well laid out scores, and like the PAID-5 or the diabetes distress score, or we have the PHQ-9 for depression. So all those things can be given by the attendants at your clinic, and this could be very well elicited. So it is not that you just think about it. So we have got well laid out methods of knowing these things, and this PAID-5 has got only 5 questions, and if it is positive, then you have to go for the 17 questions. So this is like this. So this is something like this. So then we can have different types of diabetes distress: emotional, adjuvant distress, physician-related distress, interpersonal distress. So these have been discussed in great detail by our panelists. So I'll be moving forward. So this has already been asked from Sharma sir, that emotional, regimen-related, physician-related or interpersonal. So the most important problem that the patient feels, whether it is emotional or it could be related to the physician is not giving him the right information, or something is related to this, or interpersonal. So in your aspects, so I would request all the eminent panelists to kindly give your opinions, what could be the most important. And there are studies on this also. So what are the points which are the most important reasons which are causing distress in our people with diabetes? So over to the panelist, whether it is emotional, regimen-related, physician-related or interpersonal.
So very quickly, I think most of the studies or lot of studies have shown that emotional distress is the most common one. Again, just to give a sense of the prevalence of this diabetes distress, it's 1 in 4 of type 1 diabetes, 1 in 5 for type 2 diabetes on injectable therapy, particularly insulin, and 1 in 10 of type 2 diabetes with on oral medications. So it's not that uncommon, and you will see 1 or 2 patients every day that may have diabetes distress. Again, the emotional burden of diabetes can be very high, resulting from either diabetes related complications itself, the stigma or the bias of it, and again, other, just the fear of diabetes itself, like sir started with, that fear of diabetes itself can lead to that. And a lot of other studies have also shown that the next common one probably is regimen related, and in that particularly with insulin.
As Dr. Purvi has already said, that the first and foremost shock comes when the patient is said that he is having diabetes. And the first comes a denial that I cannot have diabetes. मेरे तो किसी को डायबिटीज नहीं है, मेरे को कैसे हो गई, और अभी मेरी उम्र ही क्या है डायबिटीज होने के लिए. So this is the response which we get from the patients, and अरे डॉक्टर साहब दोबारा से चेक करा लीजिए, ऐसा नहीं होगा, ये गलत हो गया, रिपोर्ट गलत आ गई होगी. So first is denial, and that is the emotional aspect which Dr. Purvi is telling about. कि first thing comes to mind that it should not come to me, why me? Then comes why me. First is denial, then why me, and then comes the fear of diabetes, that how I will manage, what will be the course of illness, what will the complication, what will the future aspects, whether it will be transmitted to my children or not. So these things are there. So first comes the emotional aspect, then comes, she has already told that regimen related, that kitni dawai leni padengi, how much I have to take. And then interpersonal is always very important, that how I can cope with the peers, how it will be there in my workplace. So all these things come whenever a patient is diagnosed with the diabetes.
Okay. So a question for Accd Das sir and Sharma sir.
Ajay ji, they say report may be wrong.
Yes.
They want to see it.
Yes.
They say why me? Report, to cross check it, and then comes self blame. What have I done to earn this?
Why it has happened to me
And that's
only.
very important. Now about the prevalence, Purvi wanted me to say that the studies that we quoted, the prevalence of diabetes was about 27%, and the prevalence of depression was 18%. And that is up to the questionnaire and scoring.
Sir, I wanted to ask you about the physician related. So this is most important, and I think you will be able to, because the patients have their perceptions about their physicians, and there could be many issues with that. He is not giving him the actual knowledge, or he feels that his knowledge is not up to mark and he may be hiding the things. So these are very important things. So I want both of you to answer, what are those things which can cause anxiety to a patient which are physician related? He is not talking, he is not giving the right answers, he is trying to hide those things. So these things I would like you to elaborate.
That's correct, because whatever we have to discuss with the patient and the family both. Do not discuss with the family in absence of the patient. Like you say, the patient you just sit outside and let me talk to them. No, don't do that. There is nothing to hide from the patient. We have to explain them. We are experienced. Keep our emotions away from, and don't go with the emotions of the patient. Intelligently understand the emotion of the patient and deal with it. Give time to the patient, which is very, very important. Let the patient feel that, yes, I have come to a place where I will really get the assistance and my things will be all right. So discuss real things, do not hide anything, and because we just can't hide, and let the patient explain everything, what he or she thinks, what the family thinks, listen to them. And another important thing is that the family, the parents, the relationship between the parents, the environment of the family, if there is some toxic environment in the family, which is again leading to increase in the distress, please try to explain them so that the family circumstances, family situation is very supportive to the patient, and tell them that there is nothing like a stigma, and we are the guiding force to the patient, and we have to socially means emotionally, and we should be available to the patient, give the patient time, that will be the right thing. Sorry.
I think absolutely correct. We have a role play in my medical college where we do the role play. We show a bad doctor threatening the patient and a good doctor saying, that is very effective for the students. We do it for undergraduate students, and the things have changed. No more neurology, cardiology is the prime exam cases, diabetic neuropathy and diagnostic diabetes, things like that. We tell them three things, sir. Number one, we tell them in our brochure, we have said that a non-diabetic is better than non-diabetic. Sir, you are a non-diabetic, you are better than non-diabetic. तो उसको फिर समझना पड़ता है कैसे है. Since you have diabetes, you go to the doctor. You do not get sudden, we tell them, sudden heart attack, sudden brain attack, sudden foot attack. Because you are always with the doctor, repeatedly checked, and the diabetes, you check everything, so you are better. Number two, we say them, full life despite diabetes. We tell them that, people are worried about the longevity. We say them, full life despite diabetes. Then we add very slowly to say, for a controlled and disciplined diabetes. And these are the words, soothing words you have to say, and you have to also mean it. So the full life despite diabetes. And third, we have an announcement for the 100 years for diabetes, and then we give those photographs, and the brochure we prepare every year, we give a brochure, 100 years diabetes. I think all of us, Indian doctors, I hope there are nobody else here, we are much trained how to talk to our patients and how to take them into. Thank you.
Okay, so next very interesting point is that you have to use the right language with our patients. And that is what Dr. Kalra, and this is an international movement, that we have to use the right language. We don't need to say, tumhe diabetes hai. People living with diabetes, so that is, the right connotations are to be used. Kidney kharab ho gaya. You can give the numbers, your is working less, or EGFR is less. So that is way, tum uncontrolled ho. So those type of things, and I think Dr. Das sir, because he was part of that particular movement, this is an international movement, all across the world, Canada, Australia, and we also have an Indian words. So, ki tum control nahi kar pate ho. So don't give the patient this type of thing. So I would request you all to kindly give your comments. So this is very interesting.
So this is called language matters, and this has come up from the fact that all our guidelines also now, I mean, it should have been a natural thing, but it is not, and we are going back towards it, because meaning as doctors, as trained to treat people, I think that empathy and everything should come naturally to us, that respect and trust that we want to build with our patients. But unfortunately today we have guidelines telling us, or drawing our attention to it. So importantly, last few years, or almost 8-9 years, our guidelines have all become patient centric. We want to do what the patient would like us to do and guide them accordingly, right? We are not just enforcing our views on them, and that mindset itself will change our language and how we speak to the patient and how we address them, how we counsel them with respect to diabetes control as well as screening for complications and the future course. I think all that is coming up in a very formal way, and it's called language matters. Being respectful, being very appropriate. Nobody is asking you to mollycoddle patients or sugarcoat things. The same facts can be shared in a very sensitive manner with the patient and in an objective manner, so that the patient also can understand the risk and consequences of what is happening, at the same time not feel distressed about it. So this is a skill which comes with experience and with little mindfulness, but I think it's time. We are living in that era where you just don't speak your mind. I mean, you don't just use words that are inappropriate, but you use them effectively and correctly.
I think we tell them कि डायबिटीज़ को आप कंट्रोल करेंगे तो आपको यू कैन किल 5 birds in 1 stone. आपको देखिए कितना हार्ट अटैक आता है, ये आप हार्ट अटैक प्रिवेंट करेंगे, स्ट्रोक प्रिवेंट करेंगे, ब्लड प्रेशर प्रिवेंट करेंगे, स्ट्रोक प्रिवेंट करेंगे, डाटा वी टेल देम डायबिटीज इज ए ब्लेसिंग इन डिस्गाइज, दैट आपको ये सब नहीं होना है क्योंकि यू विल बी टेकिंग केयर ऑफ दैट. एंड वी ऑलवेज से दैट आप अलोन नहीं है. अभी भारत में 1.2 बिलियन है तो समझेगा नहीं. आप बोलाएं कि नाउ से 11 point. As Purvi said, don't tell a lie. We say that out of 9 people, there is 1 diabetic. So you are not alone, and it is not that you are going to have it. You are controlled diabetes, you are compared, you are equivalent to a non-diabetic. So 9 आदमी में 1 आदमी को है तो ये कोई स्टिग्माटा नहीं है. Number 2, I'll tell you rightly, sir, APJ Abdul Kalam was sitting left to me in Bangalore meeting. He said, Dr. Das, with such a wide prevalence, usko disease mat bolo. Don't tell disease. Tell it is a syndrome. It is syndrome.
Disorder,
So, it was so
metabolic
nice.
disorder. Yeah.
It's so nice of him. I have kept that paper with me. I'll pass on to RSSJ. बोला उसको disease मत बोलो. डॉक्टर साहब उसको disease मत बोलिए. बोलो ये syndrome है. क्योंकि इतना लोग affect करता है. How can it be disease?
So what sir has said, that is absolutely correct, that if you say that it is a disease, then it gives a
Stigma.
bad feeling, and if you say
Stigma.
that it is a syndrome, that it is a thing which is in most of the people, then probably he is not ashamed of it. There is a feeling of ashamed also, that something I have done, that's why I have got this disease. So this thing will not be there. And another thing is that if you give a helping hand to a person, if you give your shoulder to the patient, then probably the distress will always go away. So that is the most important thing, that you have to listen to the patient and give him a helping hand. That is the most important thing for the distress to be removed and for the patient not having diabetes.
Okay. So, some very interesting point
Dr.
at this
Ajay,
juncture. Yes.
There's one
Yes, please.
point I want to raise. So, with all this prevalence of diabetes, I think young onset type 2 diabetes is a really emerging and a very aggressive entity of diabetes that is coming up. And all of us, we are seeing these young people with diabetes, but the course of diabetes is very aggressive in them, and in all the work pressures and other pressures that the age also brings with it, I think they are also not compliant, plus the disease is more aggressive, beta cell function is rapidly deteriorating in them. All those aspects makes them a very vulnerable population for this kind of distress. And it's we don't have adequate studies because it's still coming up, and we are, there's a lot of studies from the UK, but as an Indian subpopulation, we've not really studied much, but we know anecdotally that we are really seeing a lot of it. And I'll request our seniors also to comment on this particular subset which we need to pay attention.
I think if you have watched morning wardings of Julia Murder, whom I'm so grateful to Bridge for having called this galaxy, even Catherine, how he took over David was really great, no? Absolutely great. She showed data is there, then showed a blank slide, that there's no data on that exercise. You saw that. So Julia in the morning referred to this Bridge. She said in the classifying diabetes, now this is a very separate class. Type 2 diabetes in the young adolescents is a separate class. I mean, all of you know, sir, I'm carrying cold to Newcastle. If you do not take care of them, as Ajit ji, as we are listening right now from Ajay ji, they will develop into complications. So we have coined a term in the we have a YDR, Young Diabetes Registry, from Government of India. We have told these people, quote unquote, not to them, but to their physicians and sometimes the family, it can become quote unquote malignant diabetes because they get all the complications. I'll just tell one patient before I close. I saw a patient called Dutiman from Sri Aurobindo Ashram. Mom and dad told me that he जब पूरी खाता है तो 50 पूरी खा लेता है. जब रसगुल्ला लेता है तो South is very famous for sweets. So there are raskadam, rasgulla, gulab jam, सब लेता है तो it is in 2 digit, not in 1 digit. And it doesn't go to the class, does not go to the group activity, physical activity. And वो रहता है, and जो non-veg खाता है उनका quantity and is quite big. So Dr. Saab, you have to very carefully deal with them. Slowly you have to make them out of this. But what is most important, that we also have to have a focus on properly counseling the type 2 diabetes in the young, because they are still children, adolescents, and also counseling their parents. And that's a great job. And if you do not do that, I'm not scaring you, sir. Somebody has written in that article for Government of India, are we prepared to see the funeral of our own children? So that is the thing we must drive home to our physicians, our parents, that type 2 diabetes in the young, as you rightly pointed out, is a very important thing. Very quietly, very lovingly, with all our heart, we have to take care of it. Thank you.
Sir, as you rightly said, we have to stand with the patient. We have to tell the patient that it is not a disease, it is a metabolic imbalance, which we all are here to correct it. And give him the confidence that me and you, we are not 1 and 1, 2, we are 1 and 1, 11 to look after this metabolic disturbance. And a day will come very soon that we will take care and we will overcome this problem and you will be all right. There will not be any problem. So you be friendly to the patient, give time to the patient, explain everything in the language he or she understands. Don't try to say, scare the patient about anything, and also to the family. At times you have to speak in favor of the patient also, in front of the family, and defend the patient. Because if we, the family, the patient, we all together sit, then it is not a big job. Thank you.
So, very well explained, and now we will be just small, I'll just moving you because we are already short of time now. So we will be just talking about something which is very interesting, and that is motivational interviewing. So what we are doing is we are always putting our authority before the patient and trying to put our thoughts to him. But the concepts are now different. So this is what is motivational interviewing. Express empathy, that is you have to put yourself in the patient's feet, and then you have to understand how he must be reacting when this news is broken to him. Or a child is that you have told him that is type 1 diabetes, he has to have a constant pricks throughout his life. Roll with resistance, don't be argumentative with the patient. You have to try to pick up some important, or we call dance with the discord. So that is the second aspect. Then develop discrepancy. Try to find out, could there be something, you can ask him from a scale. In your high school you were very smart, so is it not the right thing to do it? So just try to find some points where you can create a discrepancy, and then support self-efficacy. So this is what our panelists have already pointed out. So I'm just moving you because this was this part which was important. And what are the key motivational interviewing skills? So recognizing change talk. So we have to pick up those subtle cues from the patient that he wants to change, because there is a model of how this thing will go from pre-contemplative to contemplative. Then you have to preparation, action, and then you have to reinforcement. So that is a cycle of doing these things. So you have to pick those subtle things. I want to lose some weight. So that is the cue. I think Dr. Purvi will accept this thing that these cues are to be picked up, because they are very important from where the change can come. And the change has to come from the patient, not from the doctor. So we have to reach to an agreement, and everything has to come from the patient. So I think the panelists will concur on this. We're running short of time, but I think I'm trying to bring these important aspects because the time is already up. So we were given 25.
One sentence,
Yes,
Ajay, is that we qualified by saying it is they use motivational interview for many things. One of the things for the persons with diabetes, we say it is centered around the person sitting in front of you. And number two, it is all centered around changing the behavior. So very, and they call it ambivalent behavior, change behavior. And they say it is supportive at the same time directive. So the similar few attributes, they write it also MI. This motivational interview centered around the person sitting in front of you, so you don't talk anything else about him only and how to improve him, your own focus. And most important, MI is for changing the behavior. And third thing is that it is a way that you can build up the persons and take him with you and walk with him, showing him the change that you want to bring in him. It's not easy, it is a very deep interview, but I'm happy you pointed out MI, motivational interview.
So these are the key concepts of MI skills. These are called as OARS. So this is called OARS. These are the OARS by which we have to move our patient's consultation. So first is open-ended questions. So just try to elicit from the patient. Don't give them questions which have got yes and no answers. Just try to get their story, then affirm. If they are doing something good, then you have to reinforce that. Then reflective listening. Listening to them, that should be reflective, because you have to point out that you wanted to say this thing. Then summarize everything. That gives the patient the confidence that the doctor has listened to whatever has been told to him, and he understands that this is what it is. So these are the basic concepts of this. This is how you do it. So as Das sir was saying that usually a role model is played for this. So a role is played, a patient is sitting and a physician is sitting, and then you have to conduct a session of motivational interview. Because this is not part of our education. We are told to be authoritarian. We are told that this is your diagnosis. तुम्हारे शुगर कंट्रोल नहीं, तुम्हारी साथ परेशानी है, तुम चीनी खाते हो इसलिए तुम्हारा शुगर बढ़ रहा है. But we have to understand his condition. He is already in the guilt. He is in denial. So we have to bring out the good things from him. So these are the basic things. So now I will end this thing, and I would request all the panelists to give one sentence what they think and how they think that this diabetes distress should be addressed. What are the key concepts? Please.
I think the most important aspect of it is that you have to listen to the patient and listen to the worries of the patient and give empathetic word to what he is saying, and try to simplify his regime and try to make him understand what you want to tell.
Not sympathize, empathize.
Empathize.
Yes, no sympathize. So sympathy will cause you that you will put him down. So you have to keep him at your place. Yes.
You have to empathize.
Yes.
I think beautiful points brought out, a great reminder to each of you to again implement this and develop an eye for that, and heart for that, and a ear for that. So I think my summary would be that it's real, it's not just a woman going, very schizophrenic about her diabetes or anything. The diabetes distress is absolutely real. And we as their caregivers, we need, or providers, we need to really be empathetic towards each of them, no matter what the background, and we still have to listen to them and then do what's best for them in agreement with them.
Dr. Sir, about the beautiful things have been discussed. I'm very happy. Breeze and Ajay thought about it and put it in this meeting. It's rarely discussed. Now, the most important issue is that we have found if there is severe score diabetes distress. You told about the scoring. If the score is high, we always ask them to do some relaxation techniques. Like simply we tell them, बेटे ज़्यादा तकलीफ मत लो, ठीक हो जाएगा. They open the tap water and sit below it, or just watch water flowing. Some relaxation techniques. We also tell them to do some physical. It helps her. Some physical activity. चलो हम एक साथ चलते हैं. You may not go. The parents will walk with the child. Go to a park. And sometime also we have given them a break. I come from Pondicherry. Our slogan is where time takes a break. So I tell my, educated students, children, Pondicherry where time takes a break. Where are you so depressed? Take a break, take a break. So I know, and of course, there are some techniques of severe distress. There are some techniques are there which are used in association with the MI and also with the help from the counseling psychologist.
Make yourself the team leader and be a member of the team with the patient and the family to look after this distress.
Okay. So actually I was to be a part of this panel discussion, so I'll just end with one word, that is don't use bias. Bias stands for blame. Second is that is irrespectful to the patient. Third is authoritative, and the last word is stigma. So avoid these bias and you will have good relations with the patients and you will avoid diabetes distress. Thank you everyone for sharing.
Clapping for Breach for having thought of this topic, and Ajay for your
Thank you so much for the wonderful panel discussion. I would now request Dr. Kirti and Dr. Pooja to kindly hand over the mementos to the panelists.
Thank you, everyone. I think we had a very good, busy, fruitful day with the sessions that we witnessed today. Dinner is arranged on the lower ground floor, so dinner is open. You can go and enjoy dinner. Tomorrow morning, again, we will start sharp at 9. Today also we started on time. Tomorrow also we will be following the same timelines, and we hope that all these sessions will continue on time. So be there at 9 and don't miss important sessions. Thank you so much. Have a good time.
लेना तेरा प्रोफेशनल फोटो खिंचाते हैं